Welcome everyone to this FOGSI POGS International Virtual Conference hosted by Pune Obstetrics and Gynaecological Society. The theme of the conference is Just Tumors, Benign to Malignant, with special focus on gynecologic oncology. The conference is in association with AOFOG, ICOG, AGOI, ISO, and endorsed by SAFOG, ISMPO, AMOGS, ISPSM, PMS, making it a congress with national character and global participation. In these trying times, we wish to give you a wonderful experience that could be unique and would leave you enriched with knowledge. May it be keynote addresses by experts from all over the globe, their interactive exhibitions, or e-posters, we have it all. Enjoy an array of keynote addresses by the likes of Dr. Alpesh Gandhi, our FOGSI President, Dr. Kazunuri Ochiai, AOFOG President, Dr. Robert Coleman, IGCS President, Dr. James Bentley, IFCPC President, Dr. Sudeep Gupta, ISMPO President-elect, and Dr. Shankar Narayanan, a pioneer in preventive oncology. There are 4 workshops, 8 panel discussions, and numerous lectures in our conference, which will be conducted simultaneously in 5 virtual halls over 3 days. We have received an overwhelming response of over 5,000 delegates, 22 international faculty, 260 national faculty, 120 oral papers, and 225 e-posters. Team POGS 2020 has worked relentlessly to ensure that you enjoy this scientific bonanza in the comfort of your home. My special thanks to Dr. Alpesh Gandhi, our FOGSI President, and Dr. Jaideep Tank, Secretary General FOGSI, and the office bearers of FOGSI for giving us this opportunity. And finally, I would like to thank our academic partners Zydus, Sun, MCure, Zuventus, Corona, Periwinkle, and Acumentis Pharma, without whose support this would not have been possible. So come, enjoy this unique experience at this conference that is like every other and yet unlike any other. It has been a pleasure. Thank you.
You all are familiar with the modern technologies. We have ultrasound, we have CT and MR. But for all practical purposes, usually in a day-to-day practice, the first thing we do is start off with an ultrasound. And as far as ultrasound itself is concerned, we have got significant advances which have come up. We have imaging probes which have got phenomenal resolutions, something which we never imagined would happen many years back. But that's the sort of resolution we have. And ultrasound is a very, very versatile technique in the sense that once you put the patient on the table, you can do transvaginal scans, you can do a transrectal scan, which is very useful in CS cervix, or you can look at abdomen with multiple probes, multiple frequencies, multiple shapes, etc. So all in all, it's a very, very versatile technique. And it's a real-time technique. That means with the probe, you can do sliding, look at parametric infiltration, look at paracollium infiltration, etc. when it comes to CS cervix for that matter. And then we have 3 advances which have come in ultrasound. One is a volumetric ultrasound. Second is, of course, elastography, and third is contrast. Elastography gives us an idea about the consistency of the lesion, whether it is hard and soft. Volumetric ultrasound gives us a volumetric or a 4 or a 3-dimensional view of a tumor, which again is very, very useful in several situations. And contrast is something new. Contrast ultrasound is basically microbubbles, which we make and inject in the peripheral system. In contrast and color Dopplers, that we get blood flow information at a microvascular level, at the level of RBCs. And this is very, very useful in gynaecology, as we'll see subsequently in our practice. So coming to the most common things, fibroids is what we see commonly. Today, ultrasound can not only pick it up, give the exact size and location and map it as per the FIGO classification. With 3D, we can show the exact relationship of the fibroid in relation to the endometrium. And again, when you suspect that there's an intracavitary fibroid, we can put a saline and then do a 3D reconstruction and then say whether it's type 0, 1, or 2. And that helps you in deciding whether you should approach hysteroscopically or whether you should approach a particular fibroid laparoscopically. Now, sometimes there's an overlap between fibroids and adenomyosis focal. But on contrast, this can be resolved. Typically, fibroids show a pericentripetal enhancement which comes from the periphery to the center, whereas adenomyosis so diffuse enhancement which comes from within the tumor. Similarly, when you use elastography, we can differentiate between fibroids and in adenomyosis. Fibroids tend to be very hard on elastography, whereas adenomyosis tends to be softer as compared to the surrounding myometrium. So we can more accurate about this too. Today, contrast can also help us in differentiating fibroids from sarcomatous changes, which everyone is always worried about. But when it comes to differentiating a fibroid from a suspected sarcoma of the uterus, then definitely an MR is a modality of choice. MR basically helps us in multiple ways on both on T1 and T288 images, as well as with contrast. It helps us in differentiating between, or at least it makes us suspicious about leiomyosarcomas. Polyps are very common in practice. We see them day to day. But the main issue is this polyp a simple polyp, as what we see daily, or is it a malignant polyp? And it can be differentiated between the two. Let us see some newer techniques in that. Now, this was a patient who came with intermenstrual bleeding, and ultrasound showed this vague sort of a lesion within the uterine cavity. Not sure what it was. So what we do next in this situation is put some saline. So moment you put some saline in the uterine cavity, you can see it's a polypoid lesion there. On color Doppler, there's a pedicle. There is no flow within the polyp, which is very typical of a benign epithelial polyp, which it was on histology. Now, this is another lady where someone reported a thick cystic endometrium, and I won't blame them. This definitely looks like a thick cystic endometrium. She was 60 years old with spotting. So we said, okay, let's see what's happening here. So moment we inject contrast, we can see that it is not a thick cystic endometrium, but it is a polypoid lesion with cystic changes. Again, we switch on color Doppler and there's a pedicle there, but the polyp itself is not vascular. Now further what we do is inject contrast and we can see the pedicle of the polyp there, but the polyp itself is not significantly enhancing as compared to the surrounding myometrium. And this is a very typical feature of a benign polyp. So we said this is polyp. Now this, which looks like benign, now this makes a lot of difference in your practice. If I'm sure that something is benign, you just go in, do a hysteroscopy and come out. But if I feel this is likely to be malignant, your approach is going to change. Now what happens in malignant polypoid lesions is that they enhance significantly as compared to the myometrium. And sometimes the enhancement is much early as compared to the myometrium. And it is much more intense as compared to the myometrium. And that is typical of a malignant polypoid lesion within the endometrial cavity. So with contrast, we can able to differentiate between the two. So that's a large polypoid lesion, again, markedly enhancing. So what we do is we have these graphs here where we compare the uptake in the polyp and compare it with the myometrium. And we can see that the polyp, which is malignant, takes up the contrast much faster and much more. Now, typically when we have postmenopausal patients who are bleeding and we see thick endometrium, we are worried about and today with power Doppler and newer techniques like color power angiography and 3D, we can not only pick up endometrial CAs, but also look at the infiltration in the myometrium only with ultrasound. Of course, MR is good. So here's, for example, again, we can add contrast. Here, for example, we have a large lesion in the lower uterine cavity, which is involving the cervix, extremely enhancing on contrast, very vascular on color Doppler, typical of an endometrial carcinoma. We can pick up focal lesions. For example, this lady had diffuse endometrial thickening, but if you look at the contrast, this area in the endometrium where the interface with the myometrium is poor is enhancing much more. So if someone is doing a biopsy, if at all, then we can tell them this is the area which looks abnormal and they can focus on that particular area whether if they're doing a biopsy or a hysteroscopy. And with contrast, we can pick up the CA endometrium infiltrating into the myometrium. Here, for example, we see that there's infiltration of the malignancy in the posterior in the myometrium, which is confirmed on MR, of course. So as far as CA endometrium is concerned, there is no doubt that MR is a gold standard as far as staging is concerned, as far as infiltration within the myometrium is concerned. So we can stage much more accurately with the help of MR. But CT plays a role typically in looking at distant metastasis. CT is all imaging modalities basically are complementary to each other, and that is what we need to remember throughout. Now, when it comes to CA cervix, again, good old days, ultrasound was not even able to pick them up. But today things have changed. Again, with newer techniques like saline sonography and of course powerful color power angiography, we can not only pick up CA cervix on ultrasound, we can actually assess the tumor volume. We can follow up these patients accurately, and moreover, with a combination of transrectal ultrasound and a transvaginal ultrasound, we can pick up parametric infiltrations again very accurately. Now, some of these patients bleed on touch if you do a TV, and therefore a good number of times we do a transrectal ultrasound on these patients. So again, we combine techniques, what is known as multi-parametric imaging. So we have ultrasound, we have color Doppler, we have contrast and elastography. So we'll combine everything and give the clinician the more details as far as the malignancy is concerned. Now, again, when it comes to CA cervix, no doubt that to find out the T stage, again, MR is very good because MR can accurately look at the volume of the lesion. MR can help you plan therapy as well and stage it properly, and as well as look at parametric infiltration or infiltration into the rectum or vagina, as in this case, much more accurately. But when it comes to distant metastasis, lymph nodes, looking at the rest of the abdomen, then of course CT is a better technique. Now CT definitely does not have the resolution like an ultrasound has or like MR has, and therefore it's not a very good technique to look at local lesions within the endometrium or in the cervix. But when it comes to metastasis or looking at the rest of the abdomen, CT is definitely a better technique, and then again it can help us in planning therapy and following up the patients. Now, when it comes to ovarian tumors, there's a significant change, paradigmatic change in our approach to ovarian tumors overall. And thanks to this IOTA group, which has been coming out with guidelines over the years. And therefore, today, when we look at an ovarian mass, we have definite terms which we use. For example, unilocular solid, multilocular solid, etc. And we define them in a particular pattern. Number two is we have some simple rules. We have some classical features of a benign lesion. For example, benign lesions are unilocular cystic, they are multilocular again cystic, they may have a solid component which is small, they have shadowing very often in dermoids, and blood flow is minimal. Whereas malignancies typically are more solid, they are irregular, they could be multilocular solid, they very often associated with ascites, multiple papillary projections, and of course, very strong color flow. So with these, what happens in our practice is we are able to eyeball and basically based on the pattern, give a specific diagnosis in more than 95% of the cases. Now today we don't say ovarian masses, but I made a diagnosis. This is classically an hemorrhagic cyst. This is classically endometriosis, and this is a classical dermoid. And that's a cyst adenoma where we have a large cystic mass with multiple septae, but the septae are not enhancing. So that's a classical benign tumor. Here, typically when you do contrast, benign lesions typically show peripheral flow and they do not show any flow within the tumor. And that is known as pattern 1 or pattern 0. Whereas typically when you look at malignant lesions, they show enhancement of solid areas, they show enhancement of thick septae, and this is typically known as a pattern 3 or pattern 4. So this is what happens in practice. We have similar looking masses, both have cystic areas and solid areas. You're not too sure what's happening. We do contrast, and this one shows marked enhancement in the solid areas, very typical of malignancy. This one shows no enhancement at all within the tumor, and therefore this is typically nothing but an hemorrhage within the ovarian cyst. So we are very confident when the patient goes away from our center, which is malignant and which is benign. Here's another example, two similar looking masses, not too sure what it is, we give contrast, and this one is showing no enhancement at all, just a septa, thin septae, that's typical of an hemorrhagic cyst, whereas here you can see that the entire solid area is enhancing, which is very typical again of a malignancy. So in practice, we see these solid papillary projections or solid areas, and if these are enhancing on contrast, like what we see here, then that is typical of an ovarian malignancy. So again, we don't leave the patient with doubtful diagnosis, or could be this, could be that. We are much more specific nowadays. Here's another lady where we see multiple papillary projections, and you can see that on color Doppler there is hardly any flow. But when we inject contrast and all the papillary projections are enhancing, And that makes us very, very suspicious that this is a cancer, and this indeed was a borderline ovarian cancer. And we can look at a pattern of contrast as it comes in. So I'll show you two examples of solid lesions. Here's a young girl with a solid lesion, fairly vascular. And in contrast, we can see that there is intense enhancement, and we see blood vessels coming from all over the lesion. That is a dysgerminoma. Now, as opposed to that, here we have another young lady, another solid lesion. It is hard on elastography, but if you get a pattern on contrast, it shows like a fibroid. The blood flow is coming from the periphery to the center, and that is typical of an ovarian fibroma. So today we are more specific about even a solid lesion. We just won't say it's a solid lesion. We'll try and tell you as much as possible. So what we do in cases of doubts is we have some softwares. So we put in all the details in the software, and the software can give us at the end what is the risk of malignancy in this case. Is it more likely to be benign or more likely to be malignant? This is known as an aorta index model. The Americans have come out with what is known as an ORAD system. Similarly, just like your index model, in ORADs, we have ORADs 0 to ORAD 5, and as the suspicion of malignancy goes on. And now we have got definite guidelines of ORAD, whether it's ORAD 2 or ORAD 3. And again, this can be done on a software as well. So
Sir, sorry to interrupt, but can I request you to sum up? Last 1 minute left.
Yeah, I know that. So typically, how does it help us? Here's an example of an early detection of CA ovary. We have an ovary which is bulky, but it is enhancing much more as compared to the normal side. So with transabdominal ultrasound, we can do a lot of things. We can pick up peritoneal deposits, which are very small, and we can differentiate from something benign like tuberculosis. We can look at omentum. We can do an omental biopsies as well. We can characterize lymph nodes much better. We can do a true-cut biopsy of ovarian masses if it's an advanced malignancy, just for the sake of histopathology. So as far as ovaries are concerned, for characterization. Then of course, we can do invasive techniques. For example, we can aspirate ovarian MR images into ultrasound, and we have a GPS. We have our treatment choice. We have got MR guided focused ultrasound to treat fibroids as well as focal adenomyoma. So we have done almost about 1,300 cases with good results. I think Dr. Soni is going to talk on this. But all in all, what is important is teamwork amongst all modalities as well as with clinicians, so that we can give the best to the patient. Thank you so much.
Thank you so much, sir. But I'm really sorry as we're short of time and our next speaker is waiting. I will have to take the questions in the end of the session.
I may not be there. What time is the question session?
I might try and take it at 2:50 if we have. Sir, 250.
Okay, just give me a call if you can possibly.
Definitely, sure. I'll do that. Thank you so much. Dr. Kasturi Donimat, our chairperson, can I request you to please introduce our next speaker as she's present with us? Yes, thank you.
Good afternoon, everyone. I'm really pleased, very happy to introduce Dr. Aruna Menon, and Gynaecology, AFMC Pune. Now, today she'll be addressing on tumor markers, narrating the
Dr. Kasturi, I'll just quickly add, she is Brigadier Aruna Menon, and she heads the Department of OBGYN at Medical College, Pune. Thank you. Welcome, Dr. Brigadier.
Thank you.
Thank you so much. Ma'am, can I request you to please switch on your camera and share your screen? Dr. Aruna Menon, ma'am. Can I request you to please unmute yourself?
I have unmuted, but you have stopped my video, so I'm not able to start. They say that I can't start my video because the host is stopped.
Okay, ma'am. Just give me a second. I can operate it from here. Ma'am, can you please accept my request?
Yeah.
Yes.
Yeah. Good afternoon.
Good afternoon.
So I'll just share my screen and
Yes,
you can
ma'am.
Yeah. Can you see the?
Yes, ma'am.
Yeah. Thank you. So at the very outset, a very good afternoon to everybody, and a huge thank you to the organizers for giving me this opportunity to come and be a part of this wonderful extravaganza of academic feast that we are having over the last 2 days, and it will go on till tomorrow. So I'm Brigadier Aduna Menon, and I'll be speaking today on tumor markers in gynae. How can we narrow the choices? I bring greetings from AFMC, the place where I head the department. And moving on to the topic, since we have a very short interval. As we all know, tumor markers are substances which are present or are produced by the tumor or by the host in response to the presence of the tumor with specific biological characteristics which allow us to, which notify us of a presence of a tumor in the body. It can be either quantitatively determined by in the serum or or the growth of the tumors, or it can be an HP. Now, what is an ideal marker? Like I've tried to bring it out, it is yet to be found. It's as rare as the unicorn because it has to be specific to a single pathology. It should be sensitive enough to detect very low levels in the body. It should deliver a value which is so that it enables us to use it as a monitoring agent during treatment to see how good our treatment has been. Now, a marker with all these characteristics is very difficult to find. There are very few which fulfill these characteristics, but if we do find one, it may be an antigen, it may be a hormone, it may be an enzyme in the body, or it may be some other tissue-specific marker. It gives us a positive predictive value. It also gives us a negative predictive value. A cutoff value is dependent on the assay with which we are monitoring it, and that differs from the type of assay that we are doing. Now, as we all know, there's an array of tumor markers which can be used either for screening, for early detection, or for treatment, or for prognosticating and monitoring the treatment that we are putting. So this is just a list of several markers that are being used today. Now, as we are interested in gynae markers, in gynecology, we have markers which are mainly used in the field of ovarian tumors, some for endometrial carcinoma, a very few for cervical carcinoma, and of course for gestational trophoblastic disease. We will take the most common and the most studied and the oldest one, that is CA125. It is known as either a carbohydrate antigen or a cancer antigen. We all know it as CA125, and it has been one of the most studied ovarian tumor markers. And the diagnostic performance has been good from the time it was detected somewhere in the early 80s. It is a glycoprotein which is derived from the epithelium of the peritoneum, pleura, pericardium, and Mullerian tissues as well. Now, that itself gives us a clue that it is not precise or it is not exactly specific to the ovary, and thereby it limits its use as a tumor marker. It can so it does limit its performance as a marker, but for want of anything better and its consistent performance over the last almost 30, 40 years, we still continue to rely on it as a marker for the early stage disease. It is still not very pertinent to use it as a screening tool. However, it is pertinent to mention here that any level, if you get a ovarian cancer, the sensitivity is just 78%. It is not raised in clear cell and mucinous ovarian cancers. It is mostly raised in epithelial or EOCs, and that too in stage 1 of the ovarian tumors, thereby limiting its use as a screening marker. It has to be done in the first 2 weeks of a cycle if you're doing it in premenopausal women. And the recent ACROG guidelines state that if it is more than 35 IU in 100 international units in premenopausal women, it is best that we refer that patient to an oncologist treatment that the patient can get. It also has a prognostic value in CA endometrium, where it done during follow-up. It is not used as much for a screening or to diagnose, because usually CA endometrium presents with bleeding and gives us an earlier look into the disease. But if you've done the surgery and you want to use it as a follow-up, it is a useful marker to show it the presence of extrauterine disease. Now we come to beta HCG, which is the beta human gonadotrophin. Now, coming to like the unicorn that we spoke of, beta HCG comes pretty close to being an ideal marker, because it is very useful in the diagnosis. It is very useful in the prognosticating the treatment, and very, as we all know, it is of extreme importance in the follow-up. So beta HCG actually comes quite close to being an ideal tumor marker, and it is usually raised in all gestational trophoblastic diseases, choriocarcinoma of the uterus, as well as embryonal carcinomas, mixed germ cell tumors, and less commonly in dysgerminomas. Beta HCG and HPL marker together give us a huge look-see, and is of extreme use in both PSTT as well as gestational trophoblastic disease. I will not go into the follow-up here because of the lack of time. This is a new marker which has come up, that is the human epididymis protein 4, HE4, especially in CA endometrium. It is a glycoprotein which is not expressed otherwise in ovarian surface epithelium. It belongs to a family of WAP or whey acidic proteins, and it is overexpressed only in ovarian tumors. It is not expressed in other respiratory epithelium and those kind of epithelial areas, and so it makes it more specific. It is not very useful in clear cell carcinomas, but current studies show that it is more reliable than 125, CA 125. The cutoff is usually taken as 140 for postmenopausal women and 70 for premenopause. It is not affected by endometriosis, which is a huge advantage it has over CA 125, and it is not as affected by BMI either. However, smoking does increase the levels, and we should be careful when we're evaluating this marker in smokers. Best results are obtained when we do it in conjunction with CA 125, and it is harboring major interest in using it as a combination with both TVS as a screening tool and in combination with CA 125. So there are various algorithms which have been now made in incorporating both CA 125, HE4, and the postmenopausal status of women, and they are then divided into high risk and low risk. There is a way of calculating the ROMA, or the risk of ovarian malignancy, and depending on the reference values, you take HE4 values cut off as 140 or less, and CA 125 as 35, and then you divide them into low risk and post and high risk, where in premenopausal, if it is less than 1.14, it is low risk, and postmenopausal, it is low risk if it is 2.99. Now, how do you calculate it? It has got an algorithm, and you add, it is called the premenopausal predict. It has got two different formulae for both the premenopausal as the postmenopausal, where you take the values of HE4 and CA 125 and replace them in these equations, and then you get a predictive probability which is expressed as a percentage. So it is more of a percentage based on the values of CA 125 and HE4. It is now being increasingly used, and we are also carrying out a study in our own institute to know the use of ROMA in predicting ovarian malignancy. RMI, as we all know, has been in use for a very long time. I will not dwell on it. It depends on the ultrasound imaging, the postmenopausal status, and the serum CA 125 levels. Any level more than 200 is taken as a cutoff for malignancy. Now, the problem again, as we have already stressed, is that CA-125 can be increased even in a situation like menstruation, pregnancy, uterine fibroids, and so has its own limitations. So what are the newer or more promising markers? We have an array of them as well, which includes lysophosphatidic acid, M1B1 determined tumor growth fraction, mesothelin, osteopontin, vascular VEGF, interleukin 8, macrophage colony stimulating factor, tumor associated trypsin inhibitor. Now, the more other useful markers which we may be familiar with already include the CEA, but again, that is increased in vulvar tumors as far as the gynae tumors are concerned, and in vaginal adenosis, and almost in 35% of endometrial cancers. So it does not serve as a sensitive marker, but it can give you a pointer towards one of these cancers if it is raised. Then squamous cell carcinoma antigen, or SCC, it is raised in epidermoid tumors, cancers of the cervix, and may be a useful biomarker in the future to evaluate its response, especially to chemotherapy. MIS, which is produced by granulosa cells in developing follicles, is a biomarker for granulosa cell tumors, but it is not yet freely available for commercial use. Another marker which is showing promise is topoisomerase 2, which is detected by IHC, and it is a promising biomarker for epithelial ovarian carcinomas. AFP is, we are familiar with AFP, but alpha fetoprotein, but it is raised in non-seminomatous germ cell tumors of the ovary, but it is not recommended again as a screening marker, but in diagnosed cases, any level which is above 10,000 nanograms points it towards a malignancy. Inhibin has shown a lot of interest over the last few years, of which again, it is secreted by granulosa tumors and any granulosa cells. So it is increased in mucinous cells as well as epithelial carcinomas and granulosa cell tumors. It exists in two forms, A and B, and inhibin B is more sensitive. And when we order a tumor marker panel, especially in a postmenopausal women, if we are suspecting a granulosa cell tumor, then we should ask for inhibin B as one of the tumor markers in the panel. Estradiol again is increased in granulosa cell tumors, and it is useful to remember that in 35% of carcinomas, in postmenopausal patients, they may not be increased because of lack of theca cells. Then
so sorry to interrupt, ma'am. Can I request you to please sum up?
Yeah. So the new markers again are HTERT, or human telomerase reverse transcriptase, CA 19.9, CA 2729. And these are some of the normal levels that we can see, which are there in non-pregnant females. Now, this is just a small table which is there, which, if depending on the clinical presentation, what all you should ask for as tumor markers. If you have a clinical presentation in a young girl, then you can ask for CA-125 and CEA. In postmenopausal, I mean, so this table I found was very interesting, but right now we don't have the time to go through it. So I will just flash it and move ahead. So again, depending on the tumor markers that are raised, if CA-125, CEA, and HE4 are raised, then it points towards epithelial ovarian cancer. AFP, LDH, and may be towards dysgerminoma. Beta HCG, of course, is choriocarcinoma. Inhibin and estradiol are towards granulosa cell tumors. So as we can see, there is no perfect tumor marker yet found, but maybe in the future we will find something that will give us a specific reason to say, yes, that this patient has got this particular carcinoma. So it is best to interpret the values in conjunction with the clinical profile and the wonderful imaging lecture that we just saw. So in conjunction with that, we have to use our clinical acumen to interpret these values. And various indices and algorithms, which I've already mentioned, should be used more often when we are triaging these cases and sending them to the oncologist. So later on, we may have surgery or biopsy, or even a liquid biopsy, where you just take a serum or a fluid, biological fluid from the patient, and you get an array analysis of any cancerous tissue anywhere with a fingerprinted DNA for that particular tumor. That day, I hope, is not very far. With that, I come to the end of the thank you. Thank you, Tina.
Thank you so much, ma'am. Thank you so much, ma'am, for a brief discussion on the entire topic for the entire presentation. Well, moving ahead to the next speaker, I would like to introduce Dr. Abhijit Soni from Mumbai. Yes, thank you so much, sir. Can I request Dr. Suhas R. Otev, our chairperson, to please introduce our speaker?
Dr. Abhijit Soni is an interventional radiologist from Mumbai. He brings his vast experience in interventional radiology to today's topic, the role of interventional radiology for pelvic tumors. Dr. Soni, please.
Okay.
Sir, I request you to please share your screen.
Yeah, I'm just trying to do that. Yeah. Okay.
Yes, sir. Thank you. You may start.
Yeah, I'll start. Yeah. Massive vaginal bleed is one of the emergencies you gynecologists have to deal with. Also during your obstetric practice and in your gynec practice while treating fibroids or malignancies. When these lesions are not responsive to your local or IV hemostatic treatment, this bleeding can be stopped by uterine artery embolization. This procedure provides better visualization of the bleeding site and enables target embolization, thus giving minimal invasive therapy to achieve instant hemostasis. Jinal, I am not being able to see my complete slide. Hello?
Nitesh, maybe you can help him.
1 second, because this corner thing, no, I am not being able to, this is...
Nitesh, are you here?
Okay. Can you hear me and see the slides now?
Yes,
Hello.
Yes, sir.
Yeah.
Very well.
Yeah. So uterine tumors like benign tumors like fibroids and malignant tumors like leiomyosarcomas, and in conditions like CA cervix, endometrial CA, we can offer uterine artery embolization to control the bleeding PV and menorrhagia. In fact, it is a definitive treatment for fibroids, whereas it is a palliative treatment for other pathologies. After selective cannulation of the uterine arteries, the vessels are embolized with either gel foam or PVA particles, and sometimes we have to use liquid embolic agents like glue in specific conditions. This is an angiogram picture. You can see the abdominal aorta, common iliac arteries. Then we have the internal iliac arteries bilaterally. We have identified the anterior division, and from the anterior division, we identify the uterine arteries. We negotiate our catheter into the uterine arteries and then take an angiogram, and depending upon the findings, we use the PVA particles or glue to embolize the blood vessel. This is a case, a 36-year-old female who had a 5-centimeter fibroid, and she was unwilling for myomectomy, and she opted for uterine artery embolization. This is the angiogram of the right uterine artery. Here you can see the tortuous uterine artery with an abnormal blush. This artery was embolized with PVA particles, and this is the post-embolization angiogram, which reveals complete obliteration of the blood supply to the fibroid while preservation of the uterine artery. Then the catheter has been navigated onto the left side. This is the left uterine angiogram. Again, this is abnormal tortuous corkscrew shaped blood vessels supplying the fibroid. And this vessel was again embolized with PVA particles. And this is the post-embolization angiogram, which reveals residual 1 second, I don't know. Residual complete obliteration of the tumor blush with residual patent uterine artery. So the inclusion criteria include all patients in the age group of 35 to 49 years with symptomatic fibroids. However, the fibroid size has to be less than 10 centimeters, or if there are multiple fibroids, then the uterine size has to be less than 20 weeks. Further, if the patient is unfit for surgery or high risk for surgery, we can offer uterine artery embolization, or this procedure can be offered to patients who are not willing for surgery. The exclusion criteria include a pedunculated submucous fibroid or a pedunculated subserous fibroid for obvious reasons, because after embolization, this fibroid will get detached either from the endometrial cavity or may get detached into the peritoneal cavity. Further, a very large fibroid, more than 10 centimeters in size, or a uterine size more than 20 weeks is also a contraindication for uterine artery embolization. This is again an interesting case. This was a case of CA cervix who was undergoing radiotherapy. She suddenly presented with torrential bleeding PV, which was not responding to medical treatment. We performed an angiogram on this patient, and this is the left internal iliac angiogram. And you can see a well-defined oval structure. This is actually a pseudoaneurysm arising from the uterine artery. We see this quite often post radiotherapy. This is selective injection into the culprit vessel. And in this situation, we have to use glue. We want the complete obliteration of the pseudoaneurysm as well as the feeding artery. So a liquid embolic agent, that is glue, is being used in this case. Here you can see the microcatheter into the feeding artery. And this is the entire artery which is embolized with glue. And this is glue into the aneurysmal sac. These are basically wires of the vaginal packing which were given to the patient to achieve hemostasis. This is the post-embolization angiogram, which shows complete occlusion of the feeding artery and the pseudoaneurysm. Patient was treated of this pathology. One more interesting case, this is a case of a right head neck cell mass who suddenly presented with massive hematuria. And on angiogram, internal iliac angiogram, it was revealed that there was a fistulous communication between one of the branches of the internal iliac artery and the ureter, and the contrast was freely extravasating into the bladder. So this culprit artery was identified and the vessel was embolized. And this is the post-embolization angiogram, which reveals exclusion of the fistulous communication, and there was complete cessation of the bleeding. So what are the advantages of uterine artery embolization? Typically, the procedure is done under local anesthesia in hemodynamically unstable patients where surgery is risky. We are able to achieve rapid control on the hemorrhage. There is very low incidence of rebleeding. It significantly improves the general condition of the patient. Further, because of embolization, there is reduction in the tumor size, and this is because of reduction in blood supply to the tumor. Also, if the patient has to go subsequent surgery, there is significant reduction in the intraoperative blood loss. The most common side effects which are observed are severe pain, which is related to ischemia of the tumor tissue. However, these are all temporary, and this can be stopped by administering simple analgesic to the patient. Other indications or other places where there is a role of interventional radiology is because of the mass effect caused by the pelvic tumors. These pelvic tumors can sometimes compress onto the ureter, causing ureteric obstruction or hydronephrosis, and if they compress onto the pelvic veins, they cause DVT, and the patient is at a potential risk of pulmonary embolism. PCN, or percutaneous nephrostomy for ureteric obstruction. It is a very important life-saving procedure for patients with CA cervix who often present with obstructive uropathy and uremia with a risk of impendable irreversible renal damage. Percutaneous nephrostomy is useful because typically in these patients, retrograde ureteric stenting is often not possible because of invasion of the bladder neck and the ureteric orifices by the malignancy. Advantages are that this procedure is done under fluoroscopy and under ultrasound guidance under local anesthesia. It is minimally invasive, and further antegrade ureteric stenting is quite often possible through the PCN that we have done. This is an example of bilateral PCN carried out in one of our patients with CA cervix. You can see the drainage catheter through the inferior polar calyx on the right side and through the and similarly the infundibular of the inferior polar calyx on the left side. DVT. This again is one of the areas where the interventional radiologist can come to help to treat your patients in preventing pulmonary embolism, which can be life-threatening, and also to alleviate symptoms of DVT. There is high incidence of DVT and pulmonary embolism in patients with pelvic malignancy. In fact, our patients, if they have ilofemoral DVT, it is important to rule out any associated pelvic malignancy. The treatment offered by interventional radiology is placement of an IVC filter to prevent pulmonary embolism and mechanical thromboaspiration to relieve the patient from the symptoms of DVT. This was a 59-year-old female who presented to me with a left lower limb swelling since 5 days. She also gave history of bleeding PV intermittently for the past 6 months, and she was diagnosed with adeno-CA uterus. Her color Doppler showed extensive left lower limb DVT extending into the IVC. Since the DVT was extending right up to the IVC, it was imperative that we place a filter to prevent life-threatening pulmonary embolism. Further, mechanical thromboaspiration also was offered to this patient so that immediate relief from DVT could be achieved.
Sorry to interrupt, sir, but
Yeah.
can I request you, sorry to interrupt, but can I just request you to please sum up?
Okay, yeah. So this is the IVC filter which is placed, and this was the venogram which revealed complete thrombosis of the superficial femoral vein extending right up to the iliac vein and into the IVC. And this is the device. This is a rotating device through which we break the filter, break the thrombus, sorry, and the thrombus is aspirated through this sheath. The procedure is carried out throughout the entire length of the femoral vein. And this is the immediate venogram which is carried out, which shows complete patency of the superficial femoral vein, the common femoral vein into the iliac vein going into the IVC. And this is the immediate post picture which shows complete recanalization of the entire femoral vein. Lastly, we can do ultrasound guided procedures like like simple cyst aspirations. Usually these are done with when cyst is unilateral, more than 30 millimeter in diameter. There is no history of any ovarian CA, and CA 125 levels are normal. And quite often we accompany this simple cyst aspiration with methotrexate, cetrol, or tetracycline injections. So all these procedures which are carried out are percutaneous. These are all done under local anesthesia, and they are minimally invasive, and the results are immediate. Thank you.
Thank you so much, sir. Thank you so much for your time and a brief elaboration on the topic. Moving ahead, I would like to invite our next speaker, that's Dr. Geetu Prakash Badoria from Ahmedabad. So can I request you to please switch on your camera? Yes. Can I request our chairpersons to please introduce our next speaker?
Good afternoon. We are very happy to invite Dr. Lieutenant Colonel Gitu Prakash Bandoria. He is the Associate Professor of OBGYN and Gynaecology at Command Hospital, Kolkata. Sir will be speaking on how far we can go with ERAS to make surgery safer and faster. Over to you, sir.
Thank you.
So you may start now. Can I request you to please share your screen? Yes.
All right. Thank you, organizers, for the invitation. The topic that I've been asked to speak on is how far can we go with ERAS, is enhanced recovery after surgery, to make surgery faster and safer. The concept of enhanced recovery was given actually almost 3 decades back when Professor Henrik Kellett, who's a Danish surgeon, said that there could be multimodal interventions that may lead to major reductions in the undesirable sequelae of surgical injury with accelerated recovery and reduction in post-operative morbidity and overall costs. He proposed that we need to revise perioperative care regimes and we need to develop guidelines for perioperative care, which should be ideally based on scientific data and not conventional or traditional practices, which perpetuate the use of drainage, drains, tubes, catheters, and restrict oral intake and mobilization. So ERAS is nothing but it's a multimodal perioperative care pathway, which is designed to achieve early recovery for the patients who are undergoing major surgery. There are basically 2 ways that this is achieved. Firstly, it re-examines the traditional surgical practices and the perioperative practices and replaces them with the evidence-based best practices. And second, that it is comprehensive pathway in its scope, which covers all the areas of a patient's journey through the entire surgical process. So basically, the key elements involve reduction of the anxiety and fear about surgery, any optimization of perioperative existing organ dysfunction, reducing the surgical stress response, controlling the hypothermia during the surgery, reducing nausea, vomiting, and ileus, avoiding the semi-starvation status, controlling hypoxemia, least sleep disturbance after surgery, and least nasogastric tubes can be achieved by optimizing associated physiological dysfunctions, deficits, maintenance of oxygen.
Dr. Geetu, there's problem about the audio problem. Yeah, Dr. Geetu, please off your video and continue.
Hello, sir. I guess your internet is lagging.
Yeah.
Yeah, can I request you to please switch off your video and continue with the presentation? You might get a better perception.
Okay.
Yes.
All right. So the responsibility of implementation of enhanced recovery practices is not just only of the surgeons. The anesthesia colleagues have an equally important role in helping us achieve these outcomes. So this is by provision of minimal invasive anesthesia, pain relief, and collaboration with other workers like the surgical nurses, physiotherapists. So what elements constitute enhanced practices? So it starts with rehabilitation. The moment patient is decided for surgery and we start counseling the patient about surgery, we need to give realistic perioperative outcomes and possibly allay the anxiety and the fears associated with surgery as such. If the patient is a smoker or alcoholic, we should advise cutting it down. If patient has pre-existing anemia, it should be corrected either by use of hematinics or transfusion. There is a role of aerobic and resistance exercise, which ideally under a physiotherapist can achieve wonders. If patient has pre-existing hypoalbuminemia, it should be corrected. There is a role of immunonutrition, which is emerging. Obesity is associated with the adverse perioperative outcomes. So in case like patients who are waiting for surgery, they can be advised to at least start looking at possible weight reduction. Incentive spirometry, again, it's a very helpful intervention for enhanced recovery and better post-operative outcomes. Preoperative elements, the most controversial and the least used element is bowel preparation. No mechanical bowel preparation is recommended for any gynae or gynae-onco surgery, except if there's a planned rectal procedure. Otherwise, no peg leg or no bowel mechanical preparations are recommended anymore. Enemas may be given. Oral antibiotics have been suggested, neomycin and erythromycin, azithromycin series, often before the surgery. Then there are modern fasting guidelines. Again, this is an area which is not easily adhered upon. The clear liquids are allowed up to 2 hours before the surgery, and soft diet or semi-solids can be permitted up to 6 hours before the surgery. There's a good role of carbohydrate loading, that is 50 grams of glucose load that can be given as the clear liquid 2 hours preoperative. The role is controversial in diabetics. Deep vein thrombosis prophylaxis. All major surgeries, especially pelvic surgeries, cancer surgeries, are associated with the higher risk of DVT. So the prophylaxis needs to start preoperatively. Ideally, heparin can be given the evening before, that is 12 hours before the surgery. There are several SSI reduction bundles, so pre-op bathing, hair clipping. So these are essential parts. Usage of prophylactic antibiotics, and this is the only antibiotic that is recommended. No post-operative antibiotics are recommended, irrespective of the extent of surgery. Usage of chlorhexidine alcohol solution rather than iodine-based, that is betadine solution for skin preparation at the time of incision. Regional anesthesia, wherever possible, should be preferred compared to general anesthesia. Multimodal analgesia is an extremely important element. This helps in a lot of things. So this is the role of anesthetist. This is the intraoperative elements are mostly the anesthesia aspects. Then the talk nowadays is of euvolemia maintenance rather than hypo or hypervolemia. So this has to be achieved by a goal-directed fluid therapy. The goal is to maintain euvolemia. DVT prophylaxis needs to be continued during the surgery by usage of pneumatic compression devices. And it is crucial that normothermia is maintained by controlling the temperatures of the intravenous fluids of the patients, maybe some warm blankets around, controlling the temperature of the room. Post-operative elements. As I've already mentioned, that all tubes that are going in the patient should be preferably avoided. So nasogastric tube, all drains, as far as possible, they should be avoided. And if they have been used, they should be used for the least duration of time. Early feeding. Liquid should be started at the earliest. In fact, the recommendation is that patient can start taking clear liquid, that is water, immediately after surgery or as soon as the patient is not nauseous. The solids should be started within 6 hours, and the final aim would be a regular diet, that is a normal diet, within 24 hours of the surgery. Intravenous should be used for duration of opioids being renewed, again an extremely crucial element because pain complicates problem surgery. Actively ambulation are not just that you need to bed. So somebody who helps DVT prophylaxis to be continued after the surgery of time. Recommendation is 4 weeks after oncosurgery. Certain activities can be done in of cough.
Okay, I guess due to internet issue, he's been dropped out from the session. Can I request everybody to please be on mute till he is back?
Am I audible?
Yes, sir. Please go ahead.
Sorry for that.
So please switch on your full screen.
Just last few slides. So am I talking only theory? No, I've been using enhanced practices for almost a year now. So this is just a short data of 28 cases. I have not found any increase in post-operative complications or any increase in readmission rates. The duration of starting liquid solids have reduced. And we are able to ambulate the patients earlier. Catheters are removed earlier. This was an international survey that was conducted recently, where we found that throughout the globe, the implementation of enhanced practices is still variable. Asia and Africa, actually, the implementation is rather poor. Certain elements are adhered to well, that is DVT prophylaxis, catheter removal, and early ambulation. However, there is still poor adherence as far as nutrition guidelines, bowel preparation, usage of drains, and gastric tubes are concerned. There are enough guidelines available as far as our subject is concerned, starting from obstetrics to general gynecology, minimal invasive surgery, oncology, all sorts of guidelines are available. And it's not that it's only available for gynecology. There are ERAS guidelines available across all surgical specialties. There are over 30 guidelines available as we speak. ERAS Society was formed in 2010. A lot of regional branches have opened up in different countries. Unfortunately, none exist as of now as far as Africa or Asia is concerned. Hopefully that will come up soon. So the question that was posed was how far can ERAS be implemented? I think it can be implemented as far as one can take, or one is willing to take it. And it's high time that we start implementing it in our practice and not just talk about it. Thank you.
Yes, Dr. Niti, you're audible.
Thank you so much, sir. Thank you. Well, moving on to the next sessions, that is ovary, I would invite our chairperson, Dr. Lakshmi Shrikande from Nagpur. We also have other two chairpersons, but we couldn't get through them, and I guess they are not present with us today. So I would request Dr. Lakshmi Shrikande, ma'am, to please take ahead for the session. And our first speaker is Professor Dr. Shalini Rajaram from Delhi.
Yeah.
Yes.
Very good afternoon to one and all, and 3 cheers to the team for having such a wonderful conference, such a focused, dedicated conference. I first invite our first speaker of this session, Professor Dr. Shalini Rajaram. Dr. Shalini, I have very fond memories of you as AOGD president. She is professor. She is professor at Guru Tegh Bahadur Hospital, Delhi, and she has many awards, publications to her credit. Basically, she is very passionate about oncology. So, Dr. Shalini, stage is all yours.
Sorry to interrupt, ma'am. Can I just take your 1 second? I would also like to introduce our chairperson who has just joined with us. That is Dr. Sunil Shah from Ahmedabad. So thank you so much for being with us.
Can you
Yes,
hear?
over to you. Yes,
Thank
over
you
to
very
you,
much.
ma'am.
Please.
Can you hear me?
Yes.
Yes, ma'am.
Yeah, thank you, Dr. Lakshmi Srikhande, for that kind introduction. I do also have really lovely memories of you in Delhi and that EOGD meeting. So what I'm going to talk in the next 20 minutes is less common ovarian histologies. This actually came into fore in the last 10 to 15 years when we realized that these tumors, which are less common, do very differently from the high-grade serous carcinomas. They're prognostically, they're different, they're present differently. And there are molecular markers which characterize these tumors because they are relatively chemo-resistant. So the research is on to find the best treatment modality for these cancers. My slide is not moving. Yeah. So when we talk about...
Sorry to interrupt, ma'am. Can you please put your presentation on full screen mode?
It's on full screen.
No, ma'am, it is not yet. Can you please press Alt F5?
F5?
Alt key plus F5.
Only F5 is sufficient.
Yeah, this was not.
Shalini, just click on this button where I can't show her my arrow.
Yeah, I can click on it. Yeah. Is it full screen now?
No.
Not yet, ma'am.
Is it?
Not
put
yet.
it on slideshow. Like
yeah,
you
I put it on slideshow.
No.
Okay,
it's
just
not
a minute.
On slideshow.
Nitesh, are you here?
Yeah,
Can you please guide her
I'm
through?
here. Yes.
Yeah, guide her through.
Yeah. Madam, first you open your presentation.
Yeah, my presentation is open.
Yeah. Go to the share screen. Make it full screen. Yes. Now, yeah, it is.
Okay.
It's perfect.
So when we talk about less common ovarian histologies, in epithelial tumors, it is the borderline tumors, low-grade serous tumors, mucinous tumors, and endometrioid tumors, and clear cell tumors. These are at least form at least 15 to 20% of all epithelial ovarian cancers. And if we have time, I'll cover these two because it's quite a long list to cover. And I have 1 or 2 cases in between to make it a little more interesting. So we already said that the serous tumors are now classified as high-grade serous and low-grade serous, whereas the low-grade serous comes as a less common ovarian histology, mucinous, endometrioid, clear cell, and transitional. And also the germ cell tumors and sex cord stromal tumors are included in the less common ovarian histologies. So if you look at the presentation, we see that endometrioid, mucinous, clear cell, sex cord, and germ cell tumors, about 60% are seen in early stage, and therefore, if seen in early stage, their prognosis is better. Whereas most of the serous carcinomas are present in the advanced stages, that is about 70 to 80%. But we do have about 30% of these less common ovarian histologies presenting as advanced cancers. So the term LCOH was changed to less common ovarian cancers in the new NCCN version. Basically, they're the same, but the word carcinoma is used now and not histology. So low-grade serous ovarian cancers, there's a need to make a distinction about these tumors. They form about 10% of serous cancers. They occur de novo or sometimes after diagnosis of serous borderline tumors. They're characterized by younger age group at diagnosis. They are relatively chemo-resistant. So here we have to make an effort for complete cytoreduction because they don't normally respond to chemotherapy. But whatever you do, their survival is much better compared to high-grade serous ovarian cancers. But they're also present at advanced stages. So pathogenesis now is the mitogen activated protein kinase pathways. They have these mutations, and therefore targeted therapy for these mutations have started by the use of some drugs. And we also should know that 80% of LGOCs express estrogen receptors. So there is a trial going on in which people are put on hormone therapy versus chemotherapy, and let's see what the results are going to be. And serous carcinomas are positive for WT1, that is an IHC marker, and estrogen receptors. So low-grade serous ovarian cancers, they present similarly to other cancer, high-grade cancers like loss of weight, abdominal distension, abdominal pain, so on and so forth. They also have an elevated CA125, but not as high as in high-grade serous cancers. They are P53 negative tumors. So P53 negative tumors have a better prognosis. And you make a diagnosis usually after primary surgery. It is not usually made before the histopathological diagnosis is made. So management apparently is the same. It would be the same, a complete cytoreductive surgery. Primary is preferred. The goal is to remove all disease as possible because they do not respond to chemotherapy. But otherwise treatment is the same, adjuvant treatment like we do in high-grade serous cancers, either observation for early stage cancers or taxane platinum combinations, or now an endocrine therapy in the form of anastrozole, tamoxifen, etc. is going to come in soon once we get the trial results. And the overall survival is much better than high-grade serous cancers. So novel therapies, there's a trial going on. There was a Milo trial and a GOG 281 trial. The Milo study of the MEK inhibitor bimitinib was discontinued because it did not show a good progression-free survival. So that is out. Now the GOG 281 study of the MEK inhibitor trametinib has completed accrual. So we'll get results of this trial soon. But this is a more interesting trial, the NRG-GY019 of chemotherapy followed by hormonal maintenance compared with hormonal monotherapy alone in patients with newly diagnosed stage 2 to 4 low-grade serous ovarian cancers. So this is something we need to look forward to and see, because these women usually have a good survival, but they need some kind of adjuvant treatment when they recur. So recurrent treatments, again, anti-angiogenic treatment has been tried like bevacizumab, hormonal therapy like tamoxifen, leuprolide, and other chemotherapy regimens like pegylated liposomal doxorubicin, gemcitabine, weekly paclitaxel, etc. And these are off-protocol uses. Maybe in the next 5 years or so, we will see a change in the management of low-grade serous cancers. So if you look at low-grade and high-grade serous cancers, you see that the mitotic index is low, so they're not copy number high. Mitotic index is much higher. The precursors are serous borderline tumors, whereas these are stick lesions. Incidence is only about 10% of all, 4 to 10% of all epithelial ovarian tumors. This is 85%. Younger age at presentation, early stage at presentation. Clinical course is indolent, slow. It goes over years and years. Response to chemotherapy is poor. There is not much of chromosomal instability, unlike HGSC, and they are typically TP53 negative. But they have mutations in this. So when you have to type these tumors, you must use a P53 immunochemistry. 5-year survivals are better, much better than in high-grade serous tumors. So I'll go on to presenting a case of a borderline ovarian tumor in a young girl. This is a situation which most of you all see in your day-to-day practice, and let's see how this lady presented. So she was a young girl, unmarried, presented with dull, aching pain for 1 month, multiple episodes of acute pain, and she also had dysmenorrhea. She had no family history of malignancy. Her performance status was good, low lymphadenopathy, but she had a 10 into 10 centimeter mass in the right iliac fossa. And a PR examination, there was a cystic bulge. Tumor markers were almost okay, except CA19-9, and CA19-9 is also seen in endometriosis. So this was reported as an endometriotic cyst. There was endometriosis also, but let's see what happened. So this patient had a large endometriotic cyst, which was twisted. The endometriotic fluid came out, it was drained, and a cystectomy was done. But at the end of cystectomy, you can see this papillary projections in the ovary. So we were not very happy about looking at this, but we took a biopsy, we washed, took a biopsy and closed. And no, we sent it for frozen section. Frozen section had come as possible seromucinous borderline tumor. But right now, because it wasn't discussed with the relative, she was a young patient, we said we will wait for the final histopathology before taking a call. So the histopathology came out as a seromucinous borderline tumor. And we went ahead with a staging laparotomy, of course, a fertility preservation surgery with frozen section, with infracoelicomentectomy, with left pelvic node sampling and multiple peritoneal biopsies. So operatively, you had this ovary, which was large, 6 into 6 centimeters, left tube stretched over the ovary. They were all adherent to the posterior surface of the uterus and the rectosigmoid. The right tube was also dilated, but the ovary looked normal. There were no enlarged lymph nodes. We did only the same side pelvic lymphadenectomy, no peritoneal deposits. We took multiple peritoneal biopsies. We did endomentectomy, and there was no solid organ metastasis. So the final histopathology came as a seromucinous borderline tumor. We went in and did a staging laparotomy because there was a spillage of the tumor. We were not sure what we were dealing with. And this tumor was 2 into 1 centimeters. Tube was normal, regional lymph nodes normal, and she's now on follow-up. So you can be in for surprises even if you go in as a endometriosis. And endometriosis is known to occur with 2 other malignancies, that is endometrioid carcinomas and clear cell carcinomas. So borderline tumors, like all of us know, are low malignant potential tumors. They constitute 10 to 15% of epithelial ovarian cancers, age between 30 to 50 years, and majority are serous, mucinous, or seromucinous. I think WHO classifies it as seromucinous now, and we no longer have transitional borderline tumors. So they do look really malignant. When you open it up, you find these excrescences inside, and many people would think that it is a full-fledged cancer, but be careful when you are dealing with these tumors, because many a time they're borderline tumors and they're very well they're amenable to fertility preservation surgery. So basically, they lack stromal invasion. They can have areas of microinvasion, but now any borderline tumor with implants, invasive implants, are called low-grade serous tumors. They're no longer called borderline. So surgical treatment is definitely fertility sparing with unilateral salpingo-oophorectomy. Cystectomy has high recurrence rates, so be careful when you're doing a cystectomy. She has to be followed up. If tumors are bilateral, then a cystectomy on the side which looks better, and an oophorectomy on the side which looks worse. So they call low-grade serous cancer. So this was an example of another less common ovarian histology. So coming to mucinous carcinoma of the ovaries, these again carcinomas which are very, very difficult to manage, because majority of mucinous carcinoma of the ovaries are metastatic from other GI malignancies like upper GI or a colon cancer or a pancreatic cancer. So you have to be very, very careful for calling it a primary mucinous cancer by ruling out other cancers. So it is imperative that whenever you suspect mucinous carcinoma of the ovary, they must have a GI, upper GI and lower GI endoscopies. So these patients are younger age compared to high-grade serous cancer. They're very large cystic masses, unilateral ovarian involvement. If it's bilateral, think it's the metastatic tumor. Early stage at presentation and increased CA125 and CEA may be markedly elevated, but they do have a good prognosis because majority do present in the early stage. So these have a lot of molecular aberrations, unlike molecular aberrations which can be high microsatellite instability, which makes it a poor prognostic tumor. They have KRAS mutations, 26% can have P53 mutations, and HER2 new amplification is seen in 19% of cases. So this is again a transition from borderline to an expansile type of mucinous carcinoma to an infiltrative type. For these 2 cases, you don't need to do a lymph node dissection, but once an infiltrative subtype is detected, a lymph node dissection is warranted. But normally they say if mucinous carcinomas, the spread to the lymph nodes is not as much, so there is no need of a lymph node dissection. So this is basically the criteria on how you would manage, because whenever you find large tumors, the pathologist finds it very difficult to give you a histopathological diagnosis without IHC markers, especially if they're bilateral. So we need to see these IHC markers, CK7, CK20, and CDX2. CK7 is positive, is highly expressed compared to the other 2. CK20 is a marker of colon cancer, for colon cancer. So expansile type, it's surgery, cytoreductive surgery, followed by observation or adjuvant chemotherapy. Stage 1, you can have a fertility sparing surgery, even in mucinous cystadenocarcinomas, and you can observe or give adjuvant treatment. The treatment basically is similar to high-grade serous cancers, but except that they don't respond to chemotherapy, and therefore your surgical effort has to be maximal. So this was another patient, an unmarried girl, Again, young 24-year-old who came to us with distension of abdomen, loss of weight, and she had infrequent cycles. She was ECOG 1, but there was a large mass reaching up to the xiphisternum, non-tender, restricted mobility. Restricted mobility. So this patient had this large mass which had multiple nodular enhancing components. There were multiple septations. So again, mucinous carcinoma was thought of, and it was bilateral large tumors. And if you look at her tumor markers, you find CA19-9 was elevated, CA125 was elevated, and CEA was elevated. So all three were elevated, but none actually could tell us what is the kind of malignancy. So anyway, we went ahead. She was a young girl, unmarried girl with these bilateral tumors. And we thought we'll do a frozen section, a staging laparotomy, frozen section, and proceed with a bilateral salpingoophorectomy or mentectomy. There was a bladder deposit, was excised. There were peritoneal deposits. So anyway, we went ahead and we sent it for frozen section. The PCI index in this patient was about 7. And frozen section findings were query granulosa cell tumor, query endometrioid adenocarcinoma. And since she was again a young unmarried girl, we did remove both the ovaries, but we left the uterus behind. We did a complete cytoreductive surgery because we did not want to do a complete surgery based on the frozen section findings. Anyway, the moral of the story is don't always go by frozen section. But anyway, in young patients, doing a 2-step surgery is better than going ahead and doing a complete surgery in young patients. So anyway, this patient came out as primary mucinous cystadenocarcinoma of the ovary. We had ruled out upper GI and lower GI endoscopies. A pan-CK strong positivity suggests an epithelial tumor, so it was not a granulosa cell tumor. CK7 focal positivity indicates an ovarian tumor. CK20 focal positivity may be seen in mucinous carcinomas, but CK20 strong positivity seen in colon cancers. So anyway, because of ruling out upper GI, lower GI endoscopies, we had that mucinous material present, we had histopathology present. They said it was a primary mucinous cystadenocarcinoma of the ovary, which was stage 3C. So she was planned for 6 cycles of adjuvant chemotherapy, but she will have to come back for a completion surgery. So if you look at the characteristics of the 5 main histological subtypes, you have high-grade serous cancers in 70%, 10% are endometrioid cancers. These are of epithelial ovarian tumors, 10% are clear cell, 5% are mucinous, and 5% are low-grade serous. So you have 20, 10, 20, 30. So 30% of epithelial tumors are less common ovarian histologies, and we always keep talking only about the high-grade serous cancers. So prognosis is poor in this.
Sorry to interrupt, ma'am. Can I request you to please sum up to be in time? Yes.
Okay. So I won't go on to the other cases. So just let me finish this. The endometrioid, so the overall prognosis is poor, it's favorable, it's intermediate. So better than high-grade serous cancers. The tissue of origin is a distal fallopian tube epithelium. And whenever you have cancers with endometriosis, they are endometrioid or clear cell cancers, and they have a better prognosis than this cancer. Mucinous, it's poorly defined. We do not know what is the tissue of origin. Many of them are metastatic tumors, and low-grade serous is a serous borderline tumor. So the chemosensitivity of these tumors is very, very high, the high-grade serous, but they relapse also. Endometrioid, you have chemotherapy, which can take care of it, but clear cell, low sensitivity, mucinous, low sensitivity, LGS, low sensitivity. The associated hereditary syndromes are the germline mutations, and it is now imperative to do a germline mutations and somatic mutations for BRCA1 and 2 in all epithelial ovarian cancers, whereas endometrioid and clear cell have a Lynch syndrome molecular pathology, like with MSI instability. Typical stage of diagnosis is 80% advanced stage, 50% early stage, 60% early stage. So these are relatively early stage, 80% early stage, and typically advanced. So these are the various molecular alterations that you can find in these cancers. So maybe I'll stop here because it's beyond the scope of this to go on. And I would thank the organizers, Dr. Harshad and Dr. Parag Buniwale, Dr. Lakshmi Srikhande, for introducing me, and thank you.
Thank you so much, Dr. Shalini, for your informative talk. I am really happy that we have so many gynec oncologists amongst us, but majority of us, we are all routine gynecologists. I just want to give a one take-home message to all of you that we have to be very, very suspicious of cancer ovary because of its vague signs and symptoms. I regret to inform you all that we lost a gynecologist in my own city who was just 40 plus, who could not diagnose that she was suffering from CA ovary when everybody pointed out that look, you are looking, your abdomen is looking bulged out, please at least go for a scan. When she went for ultrasonography, it was stage 4 CA ovary. And we really lost her at a very, very early age. So whenever your woman, or at least we all doctors, we neglect ourselves at least once in a year after the age of 40, go for your own Pierce PV examination and transvaginal sonography. That is what I want to give the message to each and everyone. Yes, Dr. Shalini, you want to comment?
Yeah, that's what earlier we were taught that ovarian cancer is a silent disease, but it is not silent. It is a very noisy disease. You have distension, you have pain abdomen, you have all kinds of symptoms.
But we neglect that patient goes to routine physician or a GP, or we are in a stage of denial. We talk on antacids and other tablets.
I think we should educate ourselves that in a month, if you have 10 times or 12 times you have episodes of pain abdomen or distension of abdomen, you must see a specialist for it. So I think we cannot ignore even non-specific symptoms.
We should educate our women, our patients, and our own colleagues. So thank you once again. Dr. Suni, would you like to introduce the next speaker?
Yes, I would request Dr. Sunil Shah to please
just display the CV slide for him.
Dr. Sunil Shah? Okay, I guess he is he's taking another call.
It's a pleasure to invite a very young, dynamic, foxy person, Dr. Aswath Kumar. He doesn't look like professor, looks very young, but he is a professor at Thrissur and doing a lot of work in his field, a great academician. Dr. Aswath, floor is all yours.
So can I request you to please share your screen as your time starts?
Can you stop sharing your screen, then I can share my screen.
Yeah, you have to, MOC. Yes.
1 second, I will share my screen. Then only.
And if you don't want her to interrupt you, Aswath, you will have to finish, I guess, in 15 minutes.
They have given me 20 minutes.
I know, but you will have to because it is already 15:24.
I know.
So till 3:40?
By 3:40 I will finish. Okay.
Yes.
Today morning I called Chaitanya and asked correctly what time I have. Then only I should prepare the slides. Okay.
That is what I am telling you at the beginning only.
Thank you. 20 minutes. Within 20 minutes I will finish. No doubt, madam. First of all, I thank the organizers of Just Tumors and Foxy, especially the organizers, Dr. Harsha, Dr. Chaitanya, and all. And I miss all of you. It was a big occasion. I wanted to come to Pune and meet you all. Pune has always encouraged me. The POGS has always encouraged me. In my life, I will not forget that the first live workshop, the chance was given to me in Pune POGS long back. So that is all. My dream came true. I wanted to operate. Nobody was giving a chance to, because you are not a known surgeon at that time. And the POGS, they never looked back. They told me, Ashwath, you can operate in our hospital. So that is what POGS for me is. So thank you once again. I miss you all coming to, but I can this platform, big platform, you have given me a chance. Okay. So till now you are hearing, I am also a gynaecology fellowship person, but till now you are all hearing oncology, pure oncology. Here, Arshad has given me a topic, evaluation of an adnexal mass in point of a gynecologist and a oncologist point of view. So, actually, to evaluate, it's always, as we were discussing, Lakshmi Madam was rightly discussing, it's very difficult actually. It's not an easy, it's always uncertain, and you get many conflicting informations. For example, you don't see anything, ultrasound shows a mass, you don't, examination shows nothing. In a young patient, CA125 is very high, you are confused what to do. So the evaluation is very important. So many times you plan well, but many times your plans become useless. But planning is a must actually. And one more very important message I have to give you is that, see, even if without planning, nothing can be done. Action without planning is very fatal. I've seen many gynecologists going and getting operating on cases, laparoscopy, nowadays youngsters, and coming with the reports, sending to me with the reports of this ovarian cyst was removed, sir, laparoscopically, nothing, no bag, nothing was used, and now the report has come as borderline or malignant. So what to do? So these type of situations should never happen. That is why you should have an idea about how to evaluate an adnexal mass. Adnexal mass can occur in any ages, from fetus to elderly. So the main aim when you have an adnexal mass is to exclude malignancy and address acute conditions like ectopic or tall twisted ovarian cyst. Whenever it's often challenging, and most of the time it requires surgical intervention. Okay. When you have an adnexal mass, okay, it is guided by three main things. One is anatomic location, other is age, and other is a reproductive status. So these three things are very important. Where it is it adnexia? It doesn't mean that ovary alone is the adnexia. So don't have a feeling that the ovary and fallopian tube is adnexia. There are many other things. So, and what about the age? See, age is very important. When you get a solid ovarian mass in a postmenopausal age group, you have high suspicion of a malignancy. When, on the other hand, a young reproductive age group patient comes with a pain and bleeding, you should always keep in your mind of an ectopic pregnancy. So pregnancy has to be, and UPT should be one of your investigation. I'm making it very simple. Whenever you evaluate anything in any condition, you should have a differential diagnosis. Patient comes with any symptom, you should have differential diagnosis. The adnexal masses can be benign, or adnexal masses can be benign or malignant. So you can see the differential diagnosis. So ovary itself functions as corpus luteum, luteum of pregnancy, theca luteal cyst, sometimes even polycystic ovary can become palpable, endometrioma, cystadenoma, all benign germ cell and sex cord stromal tumors. On the tube, ectopic pregnancy, hydrosalpinx. Other thing, paraovarian cyst, paratubal, uterine, even a fecolith or a constipation, appendicitis, diverticulum, anywhere, pelvic kidney, peritoneal inclusion cyst, and even nerve sheath tumors we have seen like schwannoma. Malignancy, you know, ovarian malignancy of any type, either epithelial, germ cell, or sex cord stromal. Fallopian tube malignancy we have seen. Extratubal, extraovarian malignancy, metastatic, endometrial carcinoma deposits, and other malignancies of the bowel, you have to be careful. So patient, as correctly told, patient comes with different symptoms. Patient comes with, like madam was telling, annual visit patient comes. Patient is having no complaints. Suddenly you palpate a mass. Okay, mass. Recently I had a patient of, she did not have any symptom. When she came for a checkup, pap smear she came actually, a college professor. I did a pap smear. See, routine examination, kept the hand on the abdomen. She had a mass, an ovarian mass up to 24 weeks. So imagine. Mainly the patient have pain and pressure symptoms. Most of the time, you may not get anything. Imaging may show a mass. Nothing will be there. Imaging may show a mass. You may have imaging for some other reason. Recently, I had a patient with aphthous ulcer 1 week back and back pain. She went to an orthopedician where they did a scan and found out that it was a ovarian mass. So different ways it can present. Even you have in a postmenopausal age group, it can present with vaginal bleeding. You all know that estrogen secreting tumors are there, like granulosa cell tumor, theca cell tumor can present with endometrial hyperplasia and leading to. So we going fast. See how to assess this. It should be a focused. See, it should start from history. Everything should not be like do a scan and come, do a CT scan and come. That is not the way to category. Then you miss so many things. You have to work up at the history, physical examination, imaging should include primarily ultrasound. Then if needed, if needed only MRI, CT scan or PET CT. And coming to tumor markers. Why history is important? It's a long history is there. See, you should understand. I have a family who is having my friend is a doctor. His 3 sisters are having colon and ovarian cancer. One is ovarian cancer and others have colon cancer. One is having colon as well as ovarian cancer. So so they have a family history and they are now checking. Recently had a patient who came with a, they are very specific. See, they wanted to remove after 35 years, they came for removal of uterus and ovaries. Can you imagine that there was in the hepatic flexure, there was a ovarian mass cancer. They did not come. They came to remove prophylactic removal of the uterus and ovaries. They came on examination, and MRI suddenly showed a mass at the hepatic flexure. Then actually she went hysterectomy I did, but he had a bigger procedure, but it was a very early stage. So it was found out early. So BRCA status, Lynch syndrome, family history of ovarian, anything is there. Infertility patients, you all know ovulation induction. Then we have endometriosis. You know that endometriosis can lead to, there are certain protective factors also, OC pill, pregnancies, breastfeeding, and all found to be little protective also. Sorry that. Yeah. So protective also. So coming to history is the first thing. Then comes to physical examination. Physical examination, it is a size, consistency, mobility, all these things which you do in any mass over the abdomen. But when you suspect it's a solid, fixed, regular mass, there will be nodularities in the pouch of Douglas. See, that also doesn't mean that is always. If you take an endometrioma, it can cause, or a tubo-ovarian abscess has the same thing. But a tubo-ovarian abscess may have tenderness. So you have to, that is the importance. Even a rectal, per rectal examination is important. So you can palpate an ovary through the rectum. You can have a rectal primary, or you can differentiate between a presacral tumor, and if the ovary is anterior, the presacral tumor will be posterior to rectum. See, there are so many things, and many times when you examine, you should understand that ovary may not be palpable in a, usually not palpable in postmenopausal age group. You are able to palpate an ovary in a postmenopausal age group, means it should be an abnormal. So small things should be there. Many times, even if the ovarian allergy may not be able to palpate. Many times imaging may miss. So it's always a confusion situation. Once you have suspected that it's a malignancy, you see for the other findings like ascites, abdomen deposits anywhere where you look for the primary. That is the importance of looking for stomach, breast, colon, and all these things. I told you the importance. That is why I told the case of my friend Jairaj's sister. So it was moderate to high suspicious ovarian cancer. So you can see that anywhere it's a metastasis. So never see, I wanted to tell one more slide that the pregnancy also can ovarian masses. Common will be ectopic, luteomas, corpus luteal cyst. I had a patient with a corpus luteal cyst. See, 6 weeks when the patient came, it was 10 centimeter large cyst. But when the patient came after 3 months, yeah, I thought naturally we thought that anything, no, nothing to intervene. Patient is asymptomatic. After then 12 weeks when the patient scan was done the day before yesterday, it showed only 4 centimeter. So you should know which to intervene, which not to intervene. Theca lutein cyst, especially associated with gestational trophoblastic tumor or hyperstimulation, you can see get. Imaging studies is the most important. You would have heard many imaging talks by, so the transvaginal sonography and combined TVS TAS is our TVS plus TAS is what we all follow. So you have, when you take a pelvic ultrasound, see, pelvic ultrasound is choice, I agree. It is because it's less expensive, and most of the conditions can be diagnosed, and when you combine it with transabdominal, most of the findings can be. So the advantage of pelvic ultrasound is transvaginal sonography is that better resolution of the pelvic structures with less artifact. That is why, and we should all know that diagnosis is finally histology. So, but there are conditions which is having specific. So a sonologist usually never misses a simple cyst, hemorrhagic cyst, endometrioma, or a dermoid. Coming to Doppler, how much useful it is? You should know that it's just say that the increase in vascularity. Previously, we used to say RI less than 0.4, PI more than 1, and all these things, but they are all mixed actually. So nowadays we have a color score, which I will come to it after some time. The color score 1 means no flow is there, mild. What 2 means mild, 3 means moderate, and 4 means say high flow is there. So this is theory. Why it is tunica adventitia is not there in this. That is what that we leave it. You see, whom you will go for MRI whenever you are confused, or when you are going to plan a surgery, a malignancy is being suspected. So whenever there is, for example, hemorrhagic masses with a mural clot. See, many times if you, most of us are doing scan ourselves, solid or ultra features are there, or an ultrasound immature teratoma with a typical appearance is there, or all solid ovarian neoplasms, we ask when we are planning a malignancy, we do an MRI. CT is not as benefit as MRI is, because solid masses, solid tumors, MRI is the best. CT can, if by accidentally CT is detecting, CT can, staging for an ovarian malignancy, CT is enough. You can stage it. So imaging studies, because we have been a simple assessment of stratification profile and IOTA group and ORADs. These are the different methods. See, you should know what is a simple cyst. You can see the picture there. In a simple cyst, it's an anechoic fluid filled cavity, thin wall, and distal acoustic enhancement may be there. It's a simple cyst. See, whenever you have a cyst, okay, this is a simple cyst. Next, you have to ask in your mind, is it physiological? So that is what you have to show at a corpus luteum cyst. So you have to know that corpus luteum, a thick wall, uncrenated, that all these things, and the Doppler flow on the periphery. That is what. Then hemorrhagic cyst, that fishnet or reticular pattern, which is the classical of hemorrhagic cyst. 2-3 times if you have seen it, it has become so. You can see the picture which I have shown on the side. Once it is done, then you look for specific things like endometrioma, okay, ground glass appearance, teratoma with calcifications, and air fluid levels. So fluid level, not air fluid level, fluid levels are there. Pedangulated fibroid, where it's a heterogeneous hypoechoic mass and arising from the uterus. So all these are very classical. Coming to see what is IOTA, that simple rules mean. You won't be hearing it for last 2 days, but to a gynecologist, I will make it very simple. See, nothing is there. You are seeing an adnexal mass. First, you have to say that, okay, it's an ovarian or an extra ovarian. Second step is that you categorize the mass. It is benign or intermediate. Or third step is that categorize the patient. That means if it is a low risk, means it's a premenopausal patient with no high risk factors or additional factors are there, it's a low risk. And the postmenopausal patient with high risk factors are there. See, this is how it is. So ovarian or then USG, simple cyst, hemorrhagic cyst, endometrioma, all these things, classical things excluded. So we classically, I always say that when these are all so classical that I always tell my postgraduates, when you are asked an animal with 4 legs and having black and white stripes, which is that animal, there is no confusion, it is only zebra. So that is the classical picture that you get with all these things. Okay, so this is this IOTA Adnex classification. If you see this borderline, this is what it is. So see, it's a 3 clinical parameters and 6 ultrasound features are seen, like maximum diameter of the lesion, how much solid elements are there, cystic, the maximum size of the cyst wall, how many cyst locules are there, 10 or more, how many papillary projections are acoustic shadowing, or so all these things we take as B rules and M rules. So benign means uniocular, presence of solid elements, but it's not less than 7 millimeter, acoustic shadowing, less size of the cyst is less than 10 centimeter, and the no color score is less than 1. Or 1, there is no flow. Irregular solid, presence of ascites, at least 4 papillary. See, nothing less than 10, 4 than 10. No papillary, 4 papillary. Color score 1, color score 4. Ascites present, solid, irregular solid mass. This is how, and then we say that if there are 2 M rules are there, then it is malignant. 1 or more B rules are there without M rules, that is benign. And when it mixes, we have a suspicion of intermediate borderline tumors and whatever madam was discussing. So this is just, I want to highlight the similar. See, now it has come as ORADs. ORADs is stress stratification and management system. So here also what they take is ORADs also what they take, the physiological cyst they take. About the cyst, it is uninucleated or uniocular or multilocular they take. Size of the cyst they take. So physiological, type of cyst, size of the cyst, then they take external contour. So in that it's smooth or irregular. Same thing that is about the solid lesion, cystic lesion, same papillary projection is there, irregularity or not. Then they told the internal content, how is the fluid, then classical cyst. This is what is the color score, what I told, I'm not going to repeat, and the fluid cul-de-sac, fluid ascites. This is how. And what they do is that this risk stratification, that is the Adnex model, now it's gone into ORADs. Nothing. See, normal ovary, which was there, ORADs 1. Less than 10 centimeter, with a risk malignancy less than 1, ORADs 2. 1 to 10, which was there in Adnex classification, ORADs 3. ORADs 4 and ORADs 4 means intermediate, ORADs 5 means pure malignant suspected risk. These are all features. Lack of time, I'm not going into it. So ORADs category, just 1, 2, 3, 4, I will go. Follicle size, follicle, corpus luteum. Okay, see, these are the normal ovary. So 1 point, everybody, this less than 10, less than 3 centimeter is what is the most important. Less than 3 centimeter, less than 3 centimeter. So a follicle, you can see clearly a follicle being demonstrated here. So this is how a follicle look like, and never a follicle will more than be 3 centimeters. Okay, and a corpus luteum will be more than 3 centimeter, will not be more than 3 centimeter. So this is a classical corpus luteum. ORADS 2 means, see, here also the likelihood of malignancy is very less. Classical, a dermoid cyst less than 10 centimeter, endometrium less than 10 centimeter, hemorrhagic anything less than 10 centimeter. See, that is what you remember. Anything less than 10 centimeter. So for a gynecologist, you remember anything less than centimeter with classical features. Okay. Then coming to ORAD 3.
So sorry to interrupt, but
last
may I
2 minutes.
request
Last
you?
2 minutes,
Yes.
I will finish
Sir,
it off.
I don't have 2 minutes. Can you just
Sorry,
sum
I
it up
will be
in 1
finishing
minute?
it up then. Okay, these are all ORADs, and the final, this is the ORADs 5. That is what. So then this is all to get. Please, all of you go and click on the ORADs and learn today itself. So this is the classical features. Whenever a multiple cysts are there, then it directly goes into ORADs 3. And when there is the septa is thick and solid elements with vascularity is there. So vascularity means 3 or 4. Then it goes to ORADs 4, and finally the classical features of malignancy is there. Same with the MRI is there. MRI, the ORADs 1, 2, 3, MRI features is there. Please, it's a very big topic. Coming to last, tumor markers, we all know CA125 is the most non-specific. ACOG also has shown early ovarian epithelial malignancy. It is not used, not much use at all, and it is elevated in so many conditions. So sensitivity and specificity of CA125 alone is less. For the audience, there is something called CA125 2 now that is more specific, but superiority is not known. HE4 effective in early ovarian malignancy. So HE4 is an early epithelial ovarian malignancy is very effective. CEN 99, even recently you heard mucinous tumors and other tumors which I have marked here. And coming to see one biomarker alone, it is so that is why we have a panel of biomarkers. Okay, see this. My next speaker will tell about the markers in germ cell tumor. Panel means just one word on each slide. OVA1. OVA1 is a panel. That is means there are upregulated and 5 serum proteins are taken. Upregulated and downregulated proteins are taken, and that is what is the OVA1. So OVA1, when it is taken together, if the graph is and there is a put it in the computer, you get less than 5 for premenopausal, less than 4.4 for a. Then that sensitivity, then you can ask, you can go for the next evaluation is OVIRA. OVIRA means you add FSH to it, because then you don't mind about the postmenopausal status. FSH is added automatically, you get. Their cutoff is less than 5 and more than 5. And the last slide is OV. Let's leave it. This you can reflex. You can do. Roma means adding CA125 for HC4. And the last thing what I wanted to tell you is that RMI. See, please, RMI is ultrasound findings plus menopausal status into CA125. This is what it is done. So all of you, and the new RMI they add tumor size also. So for postgraduates you are listening, new RMI. And the last slide is that, see, this is the last slide. RMI calculator. See, all of you, please, those who are listening, just Google RMI calculator. It is there. Just add 3 things into it. You get the result. Okay. And then you know that you have to manage it, or you have to take the help of your gynae-oncology friend. Please, today itself, ultrasound finding, you type. Postmenopausal or perimenopausal, you type and just click it, you get the value, and the value is more than 200. See, if it is taking the latest RMI, if you are adding the size of the cyst, it is more than 450. Otherwise, more than 200 is enough. So this is how
So
you
sorry to
refer
interrupt, but
finish. Thank you.
yes.
It's such a big topic. I don't
I totally understand,
able
sir.
to.
We can't sum up.
I know.
Thank you so much, Aswat.
Thank you for
You did
taking
full
time.
justice to such a vast topic in the 20 minutes time. I just want to re-emphasize 2 points we really beautifully brought up during your talk. First and foremost, that whenever you are doing a sonography, it should always be combined with the abdominal sonography. As a gynecologist, we just put a transvaginal sonography and then we give and come up with the opinion. So it has to be combined with trans-abdominal. And second point, Aswat, you very well brought out about the freelancers, endoscopic surgeons. They go with their mobile unit to each and every hospital. Please be sure about the case you are operating before inserting your trocar. Aswat has beautifully highlighted the ORAD classifications and everything. Because apart from hysterectomy, adnexal mass surgery is the second most common thing for which you are called to operate in the freestyle, go to the gynec setup and operate. And please be liberal in using endo bag. If you are in doubt, if you are having the slightest bit of suspicion, please use endo bag. Because as an operating surgeon, you just can't shrink away from your responsibilities once it comes malignant or borderline. Remember, you are the operating surgeon and the ultimate responsibility is yours. So
Thank you so much, Dr. Lakshmi. Sorry to interrupt.
I invite
As we are
Dr.
already...
Sunil to introduce our next speaker. Dr. Sunil, are you here?
Yes, he's with us. And our next speaker is Dr. Alia Aziz. She's from Pakistan. Ma'am, thank you so much for being with us. Sunil sir, can I request you to please introduce her in a little short so that we can give her a perfect time to present her talk?
Can I have a brief, can I have her CV on the
right
screen,
here,
please?
sir, it's on the screen.
Okay. Okay. So, Dr. Alia Aziz is a master in health professional education. She is an associate professor and gynaecologist. Madam is a chair oncology committee SAFOG. She is a director of fellowship program of gynecology oncology, Department of Obstetrics and Gynaecology. And Madam is from Aga Khan University Hospital, Karachi, Pakistan. I invite Madam Alia Aziz. Madam, the session is yours. Please.
Thank you, Dr. Sunil, for your kind introduction. And I would like to thank the organizers. I hope you all can hear me.
Yes, ma'am, that's loud and clear.
We can hear you.
Yes, we can. Today I'm going to talk about the surgical treatment in malignant germ cell tumors of the ovary. And Dr. Lakshmi, I'll try to be in time. I do not have any conflict of interest. 20 to 25% of all ovarian tumors are germ cell tumors, but 3% of all germ cell tumors are malignant. And out of all ovarian cancers, about 5% are malignant germ cell tumors. It usually affects younger age group, that is less than 20, and 60 to 75% are affecting younger people. The people who are at high risk are those who have Y chromosome should have bilateral oophorectomy. The incidence is very low. It is about 1 in 500,000. Long-term survival is very good because of the high chemosensitivity of this tumor. So if we look at WHO classification, dysgerminoma, immature teratoma, and yolk sac tumors are the highest in incidence. Dysgerminoma is seen in 35%, yolk sac in 22%, and immature teratoma less common. If you look at stages, and stage 3 and 4 are less common. Bilateral involvement is very rare except in dysgerminoma, in which it is seen in 10 to 15% of cases. Adverse factors seen are if it is seen in age more than 45 years, if the stage is more than 1, if it is incomplete surgery and rupture intraoperatively, and if it is a yolk sac histology. The clinical presentation is usually by rapid abdominal distension and or a rapid growth of pelvic and abdominal mass. There is usually presentation with acute abdomen because of hemoperitoneum. Sometimes with dysgerminoma, there is HCG, suppressed breast tenderness, and suppression of menstruation. Dysgerminoma also has a parathyroid hormone peptide, which causes sometimes hypercalcemia. Preoperative workup, the first line is ultrasound in plus minus Doppler. And if you find a mass which is complex, then you ask for a CT. And if on CT you find some extra ovarian pathology, then you, for the delineation of that, you can ask for an MRI pelvis. If you find lung metastasis, then you should always ask for an MRI brain. Of course, the tumor markers are very important. You ask for beta-ICG, alpha-fetoprotein, CA125, and LDH. PET-CT is controversial, and I don't order it routinely. I reserve it for people with relapses, in which it will guide us towards which site has to be excised. Genetics have to be done because the most frequent chromosomal aberration is isochromosome P13, and there is a gain on the P arm of chromosome 12. So genetics do have a role. So how do we manage it? After establishing a diagnosis, the first line is surgery in early stage disease. For unilateral salpingo oophorectomy with frozen section should be preferred. In case of solid tumor, we should go for en bloc oophorectomy and avoid cystectomy. And in case of discouraged, and preservation of at least part of one ovary should be done. Staging the section of all peritoneal cavity, peritoneal cytology, infracoelicomentectomy. Biopsy of contralateral ovary should never be done unless that ovary is suspicious, because you don't want to leave a scarring on that ovary. Biopsy of any non-suspicious area as part of staging, and excision of any suspicious lesion. As far as locoregional lymph node sampling or systematic lymphadenectomy is concerned, it doesn't have any prognostic significance. And after this study by Leo, we should avoid it because these are such chemosensitive tumors that it doesn't add any benefit to it. So what if the original surgery was ovarian cystectomy and the final histology is malignant germ cell tumor? This is a story which we encounter every now and then. As benign gynecologist, we do an ovarian cystectomy and final histology comes as germ cell tumor. So if after final histology, it is a stage 1 and no adjuvant chemotherapy is indicated, markers normalize post-operatively, then additional surgery to remove the residual ovary is indicated. But if adjuvant treatment is required, then additional surgery to be avoided, because these are highly chemosensitive tumors and you don't have to expose the patient for resurgery. Reoperation for comprehensive surgical staging with lymphadenectomy when the diagnosis made postoperatively has to be avoided. All these are ESGO and NCCN guidelines. So then another important issue which we all have been discussing, what should be our route, laparoscopic versus laparotomy. Of course, laparoscopic is less invasive and it does play a role in very early stages of disease in which you are careful and you put it in a bag and remove the tumor without causing it rupture. But if usually if there are large tumors, there will be morcellation would be required. You have the risk of upstaging the disease to 1C. There is a risk of port site metastasis. And of course, the pathologist will have difficulty because you have morcellated the tumor, so they will have problem determining the capsule rupture or not. So that's why in large tumors, it is preferred to do laparotomy rather than laparoscopy. In advanced cases, cytoreductive surgery should be radical as it improves the prognosis, especially in non-dysgerminoma germ cell tumors. But what we have to understand is there is a rapid post-operative tumor regrowth, and if you are doing it for bulky abdominopelvic disease, then there is a rapid post-operative regrowth within 24 to 48 hours, doubling time, and by the time the patient is 3 weeks post-op, in which you are supposed to start chemotherapy, the tumor has regrown probably the same size. So that limits the utility of initial extensive surgery in cases of bulky disease, and that's where the role of chemotherapy comes. And if we are expecting that there will be increased morbidity, then chemotherapy should be given. And for those who are seeking fertility preservation, neoadjuvant chemotherapy should be considered in advanced stages, because with neoadjuvant chemotherapy, you would be able to preserve fertility in these women. So how would we do adjuvant treatment in stage 1A? There is no consensus. Cost is similar to surveillance versus adjuvant chemotherapy depending upon where we are working. Less toxic is surveillance, of course. If risk of non-compliance, for example, in our country, women who are coming from villages and uneducated, we feel that they will be non-compliant, they'll never come back. And if the histology is yolk sac tumor, then we tend to give them chemotherapy, and this is also based on the guidelines. If they are dysgerminoma germ cell tumor, then you give them carboplatin. If they are non-dysgerminoma, then you give them 3 cycles of beprigine. Long-term surveillance is of course required in both, and there is a protocol of surveillance which is very strict. So in the first year, you have to do monthly tumor markers and 6 monthly imaging. Surveillance versus adjuvant in a little advanced stages. So these are still stage 1, but they are the tumor has ruptured. So in stage 1C1, which is the iatrogenic rupture at the time of surgery, the situation is equivocal. Both options, that is chemotherapy maximum 2 cycles or active surveillance, can be considered. But if it is 1C2 or 1C3 in which the cytology is positive, or if there was a pre-surgery rupture, they should receive adjuvant chemotherapy maximum 2 cycles. Patients who are selected for surveillance only, patients should be surgically staged. Pathology should be confirmed by a gynecological oncologic pathologist. Normalize markers post surgery, counseling about recurrence risk, and they should be reliable patient in whom you are sure that they'll come back for regular follow-ups. So when it is safe to attempt pregnancy, if you are going for fertility preservation, ideal is to wait for 24 months. But if it is a patient who is like 30 and they don't want to wait for 2 years, then they should at least wait for a year before embarking on pregnancy, because majority of the recurrences occur in the first 12 months. So in summary, malignant ovarian germ cell tumors are rare but highly chemosensitive, thus high chances of cure. Unilateral oophorectomy or salpingo oophorectomy with preservation of contralateral adnexa and uterus is the standard surgical treatment. Benefit of systemic lymphadenectomy in cases of non-suspicious lymph node is not proven, so we should avoid it. In advanced stages, 3 to 4 cycles of neoadjuvant chemotherapy and then resection of residual tumor can help in fertility preservation. And fertility seems to be good after chemotherapy. Thank you for patience listening.
Dr. Sunil, you want to comment? Are you here? Dr. Sunil? Thank you so much,
Dr.
Dr.
Lakshmi,
Alia.
Dr. Lakshmi.
Yes, Darshad.
Yeah, I just wanted to, before we go on, I just wanted to thank Dr. Alia for actually participating in this Congress. I know she has got a very busy schedule and she's also involved in a lot of activities in SAPOG. In spite of that, she has accepted our invitation and actually graced to come and deliver this lecture. I must appreciate that the points that she has brought out for management of germ cell tumors are very valid and very pertinent. And I think most of our delegates would benefit from that. Thank you very much.
Thank you, Dr. Arshad, for your invitation.
Thank you, Dr. Alia, for such an informative talk. So if there are no questions, we will wind up this session. And thank you, Harshad, Parag, and the team for giving us this opportunity to chair the session. Thank you all. Thank you very much.
Thank you,
Thank you
Lakshmi.
so much. Thank you so much. Well, moving on to the next session, that is fibroids. And I request our chairpersons to be present with us in the entire session. And I welcome Dr. Avinash Bhutkar from Pune. So do we have you here? Okay, moving on. Dr. Sunita Tandulwadkar from Pune. And to accompany them, I also invite Dr. Chaitanya Ganpure from Pune again. Thank you so much for being with us. I think, yes.
Hello.
Okay, well, hello, sir. Thank you so much for being present here with us today. I would now invite our first speaker, that is Dr. Kundan Ingle from Pune. Dr. Chaitanya, sir, can I request?
Yes.
I think Dr. Bhutkar is also there in the.
Yes, sir. Yes, sir. I can just see his name here.
Yes,
He's
yes.
present. Yes.
Yeah, Chaitanya, you may start.
Sir, would like to introduce Dr. Kundan.
Chaitanya, you start the session here. Maybe he will join.
Okay, fine. Okay, fine. Good afternoon, everyone, and I welcome you all on behalf of the organizing team of Just Tumors for this wonderful conference. On the first day, then we are in the afternoon session, and we have our own Dr. Kundan Inge, who is going to speak on medical management of fibroids.
For larger reason.
Hello. Zinel, can you mute rest of the people?
Yes, sir. I can do it right away.
Yeah.
Yes. Dr. Kundan Ingle, sir, can I request you to please share your screen and start the presentation?
So let me introduce Dr. Kundan Ingle. He is our
Yes.
fourth person from Pune, and he has completed his fellowship in.
Have you got my phone?
Fine. He has completed his fellowship in endoscopy from Germany, and he is the current chairperson of FOGSI Infertility Committee 2020-22. He is director at Nirmiti Clinic and Center for Assisted Reproduction and Endoscopy in Pune. He is an ex-general secretary of POGS 2019-20. And and he has presented numerous papers in at various conferences, and he has got publications to his credit as well. So without spending more time, I would request Dr. Kundan to start his session on medical management of fibroids. Kundan, the stage is yours.
Thank you, chairpersons. Thank you so much for those kind words of introduction. Good afternoon, everybody. It's early good evening, I can say. The task which has been allotted to me to deliberate on medical management of fibroid, I think it's one of the very important area where there are lots of newer developments, and that is what I'm going to focus today in my talk. Rather than telling you all the drugs and mechanism of action of those drugs for the fibroid, I'm going to touch upon certain important updates in the medical management of fibroid today. So friends, we know that these are the monoclonal tumors, and it is basically composed of lots of myofibroblasts which are disordered, and they are basically buried into the extracellular matrix, and that is completely contributes into a tumor volume. And we know that if you look at the age of around 45, 50 or 55 age around, we'll see almost 70 to 80% of the women, they have a presence of fibroid in their uterus. And when we discussed about around younger patients, like around 30 years age, we come across around incidence by around 20 to 50% in these age group. So this is the classification which we follow normally to decide about type of fibroid. So this is FIGO classification, where S stands for submucosal, and in submucosal we have three sub-classifications, where 0 is a pedunculated intracavitary fibroid, so absolutely no myometrium around it. Then stage 1 is less than 50% of the part which is intramural, more it is into the cavitary part. And sub-classification 2 is somewhere where the majority part of the or more than 50% of the volume of the fibroid is in the myometrium and lesser in the submucosal area. There are other types of fibroid like class 3, which comes in contact with the endometrium, as you can see it here. Then in stage 4 is completely intramural from all 360 degree, it is covered by myometrium. Then stage 4 or class 5 is something which is subserosal, but here more than 50% of the volume is inside the myometrium. Stage 6 is something which is more subserosal and less in the intramural part. And then 7th is a subserosal pedunculated. Now, why we discuss this? Because when we talk about medical management, we are going to understand certain strategies or certain drugs into certain particular location of fibroids, which we'll come to in the next few slides. Now, we know pelvic examination is sufficient some majority times to diagnose that yes, there is a fibroid presentation, fibroid presence, that is enlarged uterine, and typically we see the irregular outline. There are boscillations on the uterine surface. But transvaginal scan is the gold standard test to diagnose uterine fibroid. And we can go for a hysteroscopy. Typically, hysteroscopy will help you to differentiate submucosal fibroid from a large endometrial polyp. Or office hysteroscopy is complementary to TVS and pelvic examination. It just gives you a complete idea about the location, especially related to the submucosal fibroid. MRI is typically restricted to the situations where you are planning a myomectomy. So you want to know in cases of multiple myomas or in case of large fibroids, what we call as a fibroid mapping, then it definitely helps. Or in a selective surgical removal of fibroid, particularly you want to remove a certain number of or certain location fibroid only, their MRI will help you. Now, as I said, we need to first understand about the newer concepts of fibroid growth. So the first concept which has been come up in recent or in last decade, that is the role of progesterone in fibroid growth. So it has been documented that there are increased expression of both progesterone receptor A and B in fibroid tissue, and they are in more concentration into the fibroid than the surrounding myometrium. And it has been documented that higher proliferative activity is been seen there because of the proliferating cell nuclear antigen in that area and the multiple mitotic indexes which are observed in the leiomyoma. So there is a proliferative activity continuously going on, and because there are presence of progesterone receptors there, so progesterone is actually causing rapid membrane initiated effects that is actually altering the production of second messenger, and that is involved into cell signaling transduction pathways. It has been documented that protein kinase pathway is actually mediated by progesterone, and it basically quickly activates this pathway, which is increasing considered to be the potential promoter of leiomyoma growth. So now it has been documented that in fact giving progesterone, we used to give progesterone previously to control the menstrual blood loss or uterine bleeding. Now it has been by evidence that it says that even by giving progesterone you are actually increasing the leiomyoma growth. Now there is a second new hypothesis where, which is called as a catechol O methyl transferase, that is COMT, something which you can remember. So it has been documented that there are elevated COMT levels in uterine fibroid compared to the adjacent myometrium. Now where exactly this COMT plays a role? So this is 2,4-hydroxyestradiol, which acts as a estrogen antagonist that gets converted into estrogen agonist, which is 2,4-methoxyestradiol. And this particular conversion is mediator or catalyst is a COMT. Now, if there is increased COMT, then estrogen antagonist gets converted more into a estrogen agonist, and that is why we have an increase in the uterine fibroid. So increased COMT will have an increased uterine volume. So inhibition of this activity will probably help us to reduce the uterine fibroid. So this is one of the property we have to keep it in mind when we talk about medical management. Third hypothesis is a transforming growth factor beta. Now this is also documented to be increased by almost 5 times in fibroid compared to myometrium, and we know there is a direct action of TGF beta 3 on extracellular matrix, which is a major component of the fibroid, and it also plays an important role as a regulator in a cell growth and differentiation. It also causes inflammation in that area. It increases the blood flow to the uterine fibroid, and it decreases the apoptosis. So ultimately, transforming growth factor beta also increases the uterine fibroid size. Now, so these three expression of increase in expression of progesterone, COMT and TGF beta expression is actually causing an increase in the uterine fibroid size. Now, when we talk about management and especially the medical management, which is my role today to give you the deliberation. So there is a choice of therapy, like we have surgical, then we have medical, and then we have a non-surgical. So these are the, any indications probably we have to consider when you choose the therapy. So age we have to consider when it is like, suppose a young patient and she's in a reproduction, she deserves a reproduction, then we go for a medical therapy or conservative management. Go for childbearing aspiration. Does she have severity of the symptoms will help you to choose size, number and location of the fibroid. I think it is one of the very important area which we choose our medical line, whether surgical line, on this particular factor. What is the risk of malignancy, proximity to menopause? So all these things basically will help us to choose the treatment. Now, advantages of medical treatment, we have we can recover the preoperative anemia phase into a normal scenario so that we can plan our surgery. Then it will help us to decide the surgery at any time. So according to the probably some social problems, we'll select the surgical time period. So to prolong the surgical planning, it will help to prolong the surgery for more time. It will decrease intraoperative blood loss. It will help to decrease uterine and myoma volume, and then other things like decrease intravasation, improve surgical field, reduce the need for two-step surgery. Sometimes it is multiple fibroids, sometimes it is too large fibroid, and you have to do it in 2 sittings. Then it also decreases the post-operative complications, and ultimately it helps to improve quality of life. So that is what are the advantages of medical line of therapy. Now we have this big list of drugs for fibroid. I think these are since beginning, like oral contraceptive pills, progesterone, NSAIDs. Now, why so many drugs are coming? Because we have many disadvantages with each drug. I need not tell you how GnRH agonist acts for reduction in fibroid. but especially the selective progesterone receptor modulators, they have a direct action on fibroids. They reduce their size through the inhibition of cell proliferation and induction of apoptosis. Then it has got a direct effect on endometrium, so it causes amenorrhea and causes significant reduction in the blood loss. So symptomatically it improves, and also it acts on the pituitary, where it inhibits ovulation and keeps the estrogen levels low. So selective progesterone receptor modulators has a many actions which ultimately collectively help us to improve the quality of life for the patient. Now, as I was saying, there are many limitations with medical therapy like NSAIDs. It has got a side effect on GI, and we have a lack of supportive evidence from clinical trials that it ultimately cure completely. Like antifibrinolytic like tranexamic acid, it will reduce the symptom, but it cannot reduce the size. GnRH agonists, we know that it causes a severe hypoestrogenic conditions. We cannot use it more than 6 months because risk of osteoporosis sets in. Androgens, again, the incidence of hyperandrogenemia is too high. It is associated with the liver toxicity. Progestogens, we have lots of breakthrough bleeding, and now we know that in fact sometimes it increases the size of fibroid. Combined oral contraceptive pills is one of the option, but again, it is not safe for a long-term use. It has got associated with breakthrough bleeding. Again, it has got a progesterone. It can increase the size of the myoma. Aromatase inhibitors can cause a hypoestrogenic side effects, but insufficient use to support these molecules for fibroid. And a bit about facts of GnRH agonists. We know it is a good drug. Uh, Previously, we have discussed whether should we give it before surgery for uterine fibroid. So it does says that the evidence of this meta-analysis or review by Cochrane says that if you compare GnRH agonist versus no treatment or placebo, these treatments were associated with reduction in both uterine volume, but it is with the low quality evidence. But we have a moderate quality evidence where it reduces the fibroid volume and it increases the preoperative hemoglobin. So we can use these drugs before the surgery just to buy time so that we can improve the blood, improve the hemoglobin status. But we know that we have the moderate quality evidence that it is associated with a very high incidence of hot flushes. And it also appeared to reduce intraoperative blood loss during myomectomy. So it has got advantages, especially GnRH agonist. Now, regarding those other factors where we say that it makes a plane of dissection during surgery is really, we find it difficulty. But when it comes to a subserosal fibroid or subserosal intramural fibroid, where dissection or a plane will not matter, there we can use this and reduce the size, and then we can do the surgery. So here probably the location of the fibroid will help us to decide to give a GnRH agonist prior to the surgery. Now, when it was compared GnRH agonist versus other medical therapies, it is associated with a greater reduction in uterine volume, almost by 47% when it was compared with other SERMs, that is ulipristal 5 milligram, 10 milligram, it reduces by 20 to 22%. Now, it has been documented that whatever strategy you use, like GnRH analogs, so you see a significant reduction in the menstrual blood loss as well as the uterine volume. But when you stop the treatment after a few months, everything comes back to the same level. So that was a disadvantage where it is not helping us for a long-term purpose, probably for a short-term purpose. Few updates about ulipristal. We know it is a selective progesterone receptor modulator, and especially the European Medicine Agency, they have documented in February 2018 for the first time that there were 4 cases of severe hepatic injury that actually required liver transplantation to save the life. And this was the triggering factor to that European Medicine Agency started thinking that, should we use this drug or should we ban it? So they did a 1500 patient study, that is phase 3 clinical trial, where 5 or 10 milligram ulipristal acetate was used for 8 multiple 3-month courses, and they could detect it that it is having a direct hepatotoxic effect, though it is not in a high incidence, but whenever it causes a severe liver damage, and then that probably leads to a hepatic failure and need a liver transplantation. And that is why they said that you measure liver function test at the beginning and every 1 month when you are using ulipristal. But even Indian DCGI Association, they clearly said that we go by the European Medical Agency, and they have now directed the state licensing authorities to directly manufacturers to suspend the manufacturing of these drugs or sale or distribution of ulipristal acetate, especially related to this indication. So they are now, this drug is not supposed to be used for reduction in the uterine fibroid. The next drug, which is in last 4 years we are using, is mifepristone. Again, it is a progesterone receptor modulator, and it has got a primarily antagonistic property. So it antagonizes, it attaches to the progesterone and antagonizes the progesterone hormone effect. So it binds strongly to the progesterone receptors, very minimally to estrogen receptor, and it also increases the androgen receptor, which actually helps us in a as an anti-proliferative action. So it has got a dual action. It has got a direct effect in reducing the number of progesterone receptors, and it also inhibits ovulation. It also causes amenorrhea. So basically reducing the stromal VGF, and that is why reducing the menstrual blood loss. So it is one of the good drug. Now let us see how it works. So this was a study in 2013, randomized double-blind clinical trial of 124 patients, where they have documented when mifepristone 5 milligram was daily given and it was compared with placebo daily for 3 months, there was 28.5% reduction in the fibroid volume in the mifepristone group. Not only that, 93% patient had a complete amenorrhea with mifepristone, but the side effect trend was little higher in comparison with placebo. The next drug was again the similar low dose mifepristone, where it was compared from 10 milligram versus 25 milligram, and they have shown that the reduction in the pictorial blood loss assessment score was significantly higher with 25 milligram, and with mifepristone 10 milligram it was slightly on the lower side. But amenorrhea wise there was not much difference, and but mean myoma volume reduction was more, significantly more, with when 25 milligram mifepristone was used. Again, there was not much difference in terms of side effects between 10 milligram and 25 milligram. So then the conclusion was drawn that if it is a fibroid which is more than 3 or 4 centimeter size, then let us give mifepristone 25 milligram, because we are getting a significant volume reduction. If it is a smaller fibroid, we can use a 10 milligram mifepristone. Now, when it was compared whether mifepristone is better or GnRH agonist is better. So this was a study, again a randomized control trial in 2017. One group received mifepristone 10, one second group received mifepristone 25, and third group received GnRH agonist depot injections. Now there was no difference in the mean volume of largest leiomyoma. That is, it was significantly reduced in all three strategies, but there was nothing was superior than each other. Like they were all same in reducing the size of the fibroid. But significant elevations in red blood cell count, hemoglobin and hematocrit, and significant reductions in prevalence of dysmenorrhea, pelvic pressure, non-menstrual abdominal pain in each group. So it means that all these three drugs are better. Means either you use mifepristone 10, you use mifepristone 25, or you use GnRH agonist. All effectively works. The only problem with GnRH agonist was that it significantly reduces estrogen level. So the hot flushes is a common problem with GnRH agonist. So side effect profile of GnRH agonist is little on the higher side, and it is not able to prevent the osteoporosis. So it has got a significant effect, and that is why there was a need of non-hormonal therapy. So these are the recent developments in non-hormonal therapy for fibroid. So this particular drug, which is Triptoterigium wilfordi, which is a kind of a plant extract. It is a Chinese herb, and it is known there in China as a thunder god vine. So basically it lowers the progesterone receptors in fibroid, and that is why it allows the shrinkage of the fibroid. Not only that, even consumption of these kind of herbs, they inhibit the ovarian function, they inhibit the cell proliferation, and they promote the apoptosis, and also inhibit the aromatase, because of which it reduces estrogen in the uterine fibroid. Because of this multi-core activity, it has been seen that, which is even documented by Cochrane review in 2013, that compared with this mifepristone, which was, we have seen the effect, but Triptoterigium wilfordi extract, they are associated with a greater reduction in the fibroid volume as well as in the uterine side. But even this trial has said that they need still further high quality trials, But whatever trials they had reviewed, it is shown that it is better than the mifepristone. Even
Sorry to interrupt, sir, but can I
yes,
request you to sum up as I've already given
sure.
5 minutes extra, please?
Okay, fine. So last, just to touch upon the green tea extract, it is again one of the very important. It inhibits the action of COMT. We have seen that how it promotes the estrogen agonist. So it inhibits the COMT, and that is why it can reduce the size. This is a study in 2013 where we can see that there is a significant reduced fibroid specific symptom severity, and quality of life is improved with the double tree extract. Even vitamin D3 is also documented that it downregulates the PCNA, and it downregulates the TG alpha beta 3 induced fibronectin, and it is one of the combinations to be used. And when you use vitamin D3, leiomyoma sites significantly decrease. So last, but the future drug about elagolix, I want to say this. This is my last slide. Elagolix is a GnRH antagonist. There are a lot many trials happening around the world. This is recent trial in 2020, and both trials says that elagolix along with advac therapy, it definitely improves the reduced menstrual blood loss into 68% patients in comparison with the placebo. So it is one of the future drug which we are looking at. It is given orally 300 milligram twice a day. So only problem here with the decrease in the bone mineral density, when it is even adding the advac therapy is not helping us to improve it. So that is the only one thing which is associated with elagolix. This is a very recent evidence, but very effective drug. So thank you very much for inviting me. I want to thank Dr. Harshad Parasnis and Dr. Ashwini Kale, President and Secretary POGS, for inviting me. I'm sorry for the 5 minutes delay, but thank you very much for that extra time. Chairperson, over to you.
Thank you, Dr. Kundan, for that nice presentation. Before moving on to the next speaker, I have a couple of questions. You said that mifepristone, of all, mifepristone seems to be the drug of choice as of now, right?
Yes.
So how long would you like to give it before you do an embryo transfer in a woman who is undergoing ART? Since you are an ART person, I am asking this question to you. And second question is that we said that there is a loss of plane when we are using GnRH agonist. So is there a similar situation arising even after mifepristone? So if we are giving it to reduce the size and then go for surgery, do we face a similar kind of a situation which we face with GnRH?
Yeah, it's a good question. The answer to your first question, first of all, currently the practice for, especially when we are tackling the infertility patients, see, there are very selective situations where we use actually a medical management in fibroid. So especially a fibroid which is probably a significantly, it is intramural part, that is completely intramural fibroid, and which is deviating to the cavity. I will prefer giving them a mifepristone drug for 3 or 6 months maximum. I achieve the at least say 40 to 45% reduction in the end of 6 months, which will help me to reduce that uterine compression or endometrial compression, and I can safely go ahead with the embryo transfer or IVF treatment if at all that is planned for her treatment, or fertility treatment anyhow. But I reduce that particular size for some time. But especially when I talk about submucosal fibroid, I think medical line of treatment is not my first choice. Again, the surgical will be my first choice, especially when it is infertility patient. Now the question to your
so the line of the treatment, for how long you will continue the treatment will depend upon how much size reduction in the size you are getting. So it may be 3 months, it may be 6 months, depends upon how much size reduction you are getting. Till the time your displacement of the endometrium is not taken care of, probably you will continue with that.
Absolutely.
Right?
That's right. And the second question answer is, see, that's the advantage of mifepristone, that the estrogen suppression is just not like a menopausal, which happens with GnRH agonist. So, fortunately, we have a lesser side effect of hypoestrogenemia with mifepristone than GnRH analogs. So that is why even if we continue for a little longer time, will not have a severe side effect. So I think we have a little advantages over GnRH agonist, especially about mifepristone. And now, as I said, the non-hormonal therapy, I think unless and until we use it, because the incidence, even the Cochrane review is in favor of this combination of non-hormonal therapy over mifepristone. And because they are Chinese herbs, they are absolutely having a significantly less side effect, and they are more safer, non-hormonal. And I think probably these are the good combination which are helping us to reduce the size without using any hormones.
Thank you, Dr. Kundan.
Thank you, Chairperson. Thank you.
Zinal, over to you.
Thank you so much, sir. Just a small request. We have an announcement to make. Dot at 5 p.m. We will be having a short quiz. The link will be displayed on your screen, and I want you to click on that link. The quiz will be for 2 minutes. You have to answer all the questions. The fastest reply and the correct answer is gonna get the gift. The gifts are going to be distributed in the valedictory session. So please take a note of that. 5 p.m. we will be starting with the quiz. Over to you, sir.
Okay. Thank you, Zinal. Looking forward to that quiz at 5 p.m. Meanwhile, may I request Dr. Avinash Budkar sir to introduce our next speaker, Dr. Prashant Mangeshikar, and he is going to speak upon morcellation at myomectomy, to do or not to do. I would request the mice person people to display the slide of Dr. Prashant Mangeshikar.
Nitesh, can you please change the slide? The next speaker. Yeah.
Yes. Avinash sir.
I guess he's not between us.
He's not there.
He's not there.
Okay. So let me introduce Dr. Prashant Mangeshikar. He needs no introduction, to be honest. He's a consultant gynecologist and professor of obstetrics and gynecology, and he works at present at Bombay Hospital, Mumbai. And he is going to speak on morcellation at myomectomy, to do or not to do, $1 million question. And I hope we get an answer, clear-cut answer from him at the end of the session. Sir, nice to have you today. The stage is yours.
Yeah, can you see my slide? Okay, I think you got my wrong introduction because I last operated at the Bombay Hospital maybe more than a decade ago, and I'm not connected with the hospital anymore. Theoretically on paper, yes, but practically I visited the hospital last about 12 years ago. So thank you, Dr. Parasnis, for your kind invitation to be here on discussing about morcellation. And just as I was getting ready for my talk today, what's happening here? Hold on. I just saw this, and I want all of you all to look at this slide, which came on my Facebook from one of the FOGSI senior gynecologists. And look what it says. Benign tumor in the uterus, non-cancerous, present in 70 to 80% of the women. Mr. Chairman, do you agree with this statement? Mr. Chairman. Hello?
Hello.
Mr. Chairman, do you agree with this slide?
Benign tumor in the uterus.
Benign tumor, non-cancerous, present in 70 to 80% of women. This is what has been put on the Facebook today by a senior gynecologist from FOGSI. Do you agree or you do not agree? Because then I can continue talking.
Yeah, I agree.
You agree? Do you think that it is present in 70 to 80% of women? I don't think so. Do you think that it is non-cancerous? Well,
not every time.
We'll see it. Yeah. Okay. So now let me continue with my talk, which is on morcellation and myomectomy. The only reason why I showed this slide is because a lot of mumbo jumbo is coming up on social media, where people are making all sorts of claims. All types of medication are being touted around, including Patanjali and holy water from the Ganges to reduce the size of the fibroids, which is totally bullshit. Okay, but anyway, I will discuss morcellation. And like my teacher, where I was trained, Professor Sen, he was considered to be a madman, a surgical gymnast. He was put in a psychiatric ward because he attempted to do laparoscopic appendicectomy, and he was frowned upon, but he was then found to be normal and retained back to his chair many years ago. So looking at laparoscopic surgery and fibroid, yes, it is already an established procedure, that it is minimally invasive and should always be the preferred option, as has been quoted in this issue of 2019 by Dubisson, right? So myomectomy, surgical myomectomy remains the treatment of conservative treatment of choice. And of course, we will talk about the challenges that are there, laid down more so by this stupid organization called the US FDA. And I don't know why we have to believe them, because I will show you how they were wrong. Not me, but I will show you the work of 48 reviewers, which were highlighted by Dr. Gautam Alabadia in the FOGSI Journal editorial 2017, saying that FDA is bullshit. Okay, so don't get carried on why just because it's American. Neither Trump could impress India, nor is Biden going to impress them. But why was this problem? Because of power morcellation. What was the hype? The hype was all because this poor lady, an anesthetist at Harvard Medical School, underwent surgery. Now, she went on with her surgery, got back to work. 5 days later, she gets a call from the pathology department telling her that, look, your hysterectomy was done all right, but the uterus, which was morcellated, has actually been found to be a leiomyosarcoma. So this was found to have been morcellated and disseminated, upstaging her to stage 4. She approached the American College, the AAGL. Nobody listened to her. Well, she then decided to take the matter up onto this onto the road, and went and did a lot of publicity via the Wall Street Journal. And then December 2013, they filed a complaint with the state medical board. Right? So the question then is that, do you want to morcellate or not? Right? So this is not something that is new. These are ideas that are borrowed from the butcher, how to morcellate. But Harry Rich was bold enough to say that he had not appreciated until recently that few gynecologists use vaginal extraction as opposed to power morcellation. It should be the choice of the surgeon and not the patient, driven by evidence and not dictated by the ramblings of a sensational zealot. Very powerful words coming from a very powerful surgeon. So the balance of the equation is, what are the benefits from morcellation? And you weigh them against the risks of morcellation. So we come to William Parker. In 2018, he said, whether you morcellate or not, myometrial cells are always found in the abdomen and the pelvis, whether you do open surgery or whether you do laparoscopy. So following morcellation, careful inspection for and removal of tissue fragments with good lavage. And Professor Sen said, you flood the pelvis up and down, turn the position of the patient, and do a good lavage to see that you're not left any residual tissue behind. And this can be done without the use of any containment bags, right? So the question is that a lavage must be done properly, right? Sometimes you even use up to about 10 liters of fluid because you want to irrigate and drain all that fluid off to see that there's no small tissue left behind that could be lurking behind to create a parasitic fibroid, right? So Tulandi, in his JMIG article, found that that laparoscopic hysterectomy or myomectomy with unconfined morcellation was associated with a 1.4% risk of iatrogenic endometriosis, a 0.57% incidence of adenomyosis, a 0.9% of parasitic fibroid, and very rarely a disseminated peritoneal leiomyomatosis. So their study showed that the benign sequelae of morcellation could be found in up to 1% of the cases, which is much higher than the prevalence of uterine sarcoma after morcellation. Benign conditions have less consequences than malignancy, yet they are more common and might require another operation. So accordingly, if morcellation is required, he said that maybe confined morcellation should be considered. But this again has been found to be controversial by other speakers, other authors, like, for example, Janssen from Amsterdam. His group found that in women who are undergoing open surgery myomectomy were included in the studies. Peritoneal washings were obtained during the procedure immediately after opening the abdomen, and the second one after resection of the myoma. And then the cytology of this fluid was evaluated, and that they found that the tumor tissue spillage from myoma occurs during conventional open myomectomy. So this is therefore an open and shut case not to use that myoma bag, endo bag, because if you have already removed that fibroid and parked on, you have already caused a spillage. So therefore, it is questionable whether morcellation in specially designed containment bags after laparoscopic myomectomy guarantees any additional oncological safety. Right? So I bring you then to Sari Dogan, the article from England, and this is the JMIG 2017, where he talked about 514 women who underwent laparoscopy. 2 were converted to open because of a bowel injury in one at entry and the other suspected cancer. In summary, after having looked at all this, they found that there was no case of undiagnosed uterine carcinoma after myoma morcellation. So the morcellation was done without a bag in all these 512 patients, as also they showed that tissue spillage occurs during conventional myomectomy, that is questionable whether morcellation is required in containment bags. So tradition is, well, we have always done it that way, so I'm going to do it that way. Convention says everyone does it that way, so I shall do it that way. Evidence-based medicine says evidence supports this way, and I will do it this way. Right? So there are many ways to bell a cat, and there's no need to always morcellate using a power morcellator. You can always use the Changung technique to remove the fibroids or the uterus through this, and you have a wound expander, that is the applied medical extra small wound extractor, that you go through the umbilicus. It's a 2 centimeter incision, and when you expand it, it goes to 4 centimeters, and you can remove as large the morcellation through this. There's no upstaging of the disease. And the other point that one needs to understand is the vagina. It belongs to us. We are gynecologists. That makes us different from the general surgeon. So use your power as a pelvic surgeon to do your myomectomy, or for that matter, if you want to even debulk the uterus through the vagina. If you have done a hysterectomy, the vaginal circumcision has an incision of minimum 4 centimeters. If you're doing a posterior colpotomy with a CCL ball, you have a good 2 centimeter incision by which you can grab the large fibroid and bring it down and do a quick debulking. There's no spillage, no upstaging, no fragments left behind, and therefore there is no problem even for the pathologist if you are doing a morcellation of the uterus. Now, in contrast to myomectomy, if you are doing a hysterectomy, you can do a myomectomy on the hysterectomized uterus, or you can bisect it, trisect it, the wedge debulking of the uterus, or the Changung method. Seen this many, this is something that you guys practice. So just bring the uterus down and go on debulking, right? And for that, we developed a knife with stores. We call it the endostake knife, and you hold the handle with your forefingers, so that it's easier then for you to make your cuts. You can go on making your cuts. You can see that as you cut, you can really carve around very well. And I will forward this ahead. Of course, this is for a large uterus that was being morcellated now, and you see as I go down, I can hold my handle very well, and then go on making my cut, and then the entire uterus comes out. Okay, so this way you're avoiding a morcellation, and you can remove large pieces of meat from that small incision, right? So this is basically what you would do. Of course, you don't want to have any complications. So if you look at the ACOG, that is the American College Committee opinion that was published in March of 2019, before considering open morcellation of the uterus, a woman should be evaluated to determine if she is at an increased risk of cancer of the uterine corpus, right? So therefore, if it's a cancer, obviously morcellation is contraindicated, but the gynecologist and the patient should engage in a shared discussion with good decision making, with informed consent, explaining the risks and the benefits of each approach to surgery for presumed leiomyomas, and the risk of morcellation and the benefits of morcellation, and what are the alternatives to morcellation, right? So William Parker again looked at the future of open intraperitoneal power morcellation. So what did he do? He said that in November 2014, the FDA said that 1 out of every 498 women would have an open leiomyosarcoma. with 46 other scientists. They submitted the data that the FDA directive was flawed and misleading. The analysis was all wrong. And the prevalence of LMS amongst women operated upon would be approximately 1 in 2,000, significantly much lower than the estimate of the FDA 498. Therefore, I say the US FDA is a bunch of bullshit, right? So if you look at this wonderful article by my good friend Gautam Alabadia, editorial Foxy 2017, he quotes Rodriguez, and it's a brilliant article where they looked at almost 14,000 women between 25 and 64 years of age over an almost 10-year period. And the incidence of occult myosarcoma developing within 1 year following a supracervical hysterectomy was 9.8, 10.7, 33.5 for per 10,000 for women between these three age groups. The overall incidence was 13.1 per 10,000, and in the cases following a myomectomy, it was 17.3. So the overall risk of being diagnosed with occult leiomyosarcoma was 12.9 per 10,000 in LASH, and myomectomy for women for patients younger than 49. And there was no evidence of occult leiomyosarcoma 1 year after operation for patients undergoing younger than 40 who underwent laparoscopic myomectomy. So take your endo bag, blow it into a nice balloon, and let it float in the air so that your children can enjoy flying balloons, right? Rather than trying to use these balloons in the abdomen. Morcellation, he further says, is an acceptable option for retrieval of benign uterine specimens and may facilitate a minimally invasive surgical approach, right? So every patient should be counseled at about the possible risks associated with the use of morcellation. However, further research on uterine morcellation should be based on decision and cost-benefit analysis to determine the ideal candidate in whom uterine morcellation during a minimally invasive hysterectomy or myomectomy would facilitate more good than harm, right? I'd like to end my talk with the lessons that we always learn from leaders like Einstein. Follow your curiosity. Perseverance is priceless. Focus on the present. Imagination is powerful. Make mistakes. Live in the moment. Create values. Don't expect different results. And knowledge comes from experience. And learn to learn the rules and then play better. Right. So I'd like to end that. People are going to question and say, why don't you use an endo bag for morcellation? I have my reservations. One, it is painstaking to put a bag inside. It is very clumsy, like trying to put a condom on a flaccid penis. And if you do a myomectomy laparoscopically, the very incision that you make, be it with a knife or be it with a harmonic, you can see a lot of cells flying around. So if it is a leiomyosarcoma, you have already upstaged the disease before you're even enucleated, just as you're making your incision. Number two, after you enucleate, every endo bagger puts that myoma on the bowel. And if it is a leiomyosarcoma, he has already caused upstaging already. So he's trying to cover his sins by putting that myoma inside a bag and then trying to morcellate and trying to show off how he can morcellate. This is like having sex and then you want to avoid a pregnancy, then you put the condom on. It doesn't work. The pregnancy is going to happen anyway. So similarly, you're going to upstage that myosarcoma even if you use that bag. And that, ladies and gentlemen, I rest my case about morcellation to do or not to do. Thank you.
Thank you so much, sir, for that wonderful presentation. And we got the answer to the question what was posed in the beginning of the presentation. A small question that when we say that posterior colpotomy is one of the ways or methods to retrieve the specimen after myomectomy or hysterectomy, what is your take on post-operatively the patients quite times complain of dyspareunia? Does it really hold true?
In my 20 plus years of experience, having used the CCL ball, which has been developed by the Center of Chirurgy Lausanne, which is basically a polyurethane ball that is put on a trocar cannula, inserted vaginally. You do a laparoscopic colpotomy. The colpotomy is done laparoscopically, not vaginally. So therefore, your incision is high up in the vagina, and you then take you close vaginally. Now, the patient does not get dyspareunia because of that, nor is there going to be infection. This was the first thing that my referring gynecologist was screaming at, saying, oh, you know, we used to do tubal sterilizations vaginally. We used to have patients complaining of dyspareunia post-vaginal sterilization. Well, they've actually missed the bus, because the incision, when you do a vaginal colpotomy, is at a much lower level than when you do a laparoscopic colpotomy. And when you're shooting up into the apex, so there's no way you're going to get any dyspareunia. And we have done this very effectively with good closure that is done vaginally. It's only because it's easier to finish, because you're sitting down vaginally, removing the fibroid. Why then go up again and close vaginally from above? You might as well you might as well close the vagina from the vaginal end in this case. And you can get a good full thickness bite. You don't have to take the peritoneum, you only have to take the full thickness of the vagina.
Thank you so much, sir.
Thank you so much, sir.
To interrupt, as we have the next speaker present with us, sir, can I request you to please introduce them?
Sure.
Yeah. Thank you, sir. Thank you for that wonderful presentation. Dr. Avinash Budkar is here. He joined us. Budkar, sir, would you like to introduce our next speaker, Dr. Jaideep Tank?
Yes, before that, I would like to thank Dr. Mangeshikar for his excellent oration. Now, Dr. Jaideep Tank, I know for many years now. He is a consultant gynecologist and professor of OBGY in Bombay Hospital, Mumbai.
No, Dr. Jaideep, can you start sharing your screen so that your first slide would be visible?
Will be speaking on adenomyoma, a clinician's dilemma.
So you have to unmute yourself.
Okay. Am I audible now?
Yes.
Yes.
Sir.
Yeah. Okay. And I hope my slides are also seen.
Yes, sir.
Yes.
Please go ahead.
Lovely. Thank you very much. So let me thank first the president of the Pune Society, Harshad, my good friend, and Ashwini, the secretary of the Pune Society, along with the organizing chairs, Parag, the organizing secretaries, Kiran, the scientific committee chair, Dr. Chaitanya, and the treasurer, Dr. Prakash, along with the chairpersons of this session, Dr. Avinash Budkar, Dr. Sunita Tandulwadkar, and Dr. Chaitanya again, for inviting me to give this presentation, and also not only inviting me to give this presentation, but also for including me in a session which features my good friend Kundan and seniors, Dr. Prashant Mangeshikar. I understand Dr. Trivedi is unable to make it, but it's a pleasure to have shared a stage with him potentially. I'm going to speak about adenomyosis, a clinician's dilemma, and I'll try not to talk too much about the theory, as it were, of adenomyosis, but rather focus on what we need to do, or what we want to do, or what we should do when we have a patient with either a confirmed adenomyosis or a suspected adenomyosis sitting in front of us in our clinic. But let me begin by saying that, like so many topics in obstetrics and gynecology, one of the problems really with adenomyosis is what this article headlines: an abundance of studies, but a dearth of evidence regarding both endometriosis and adenomyosis. And this is exemplified by this PubMed search which I have done. So if you look at the PubMed search, and then you look at that green graph on the side, you will see that adenomyosis follows a pattern where the amount of literature on it is increasing year by year. The graph shows you the number of articles that have been published on the topic that you're searching for every year. So the number of articles on adenomyosis is increasing every year. However, look at the quantum of articles. In the last year, 2020 so far, 259 articles which mention adenomyosis, may not directly touch adenomyosis, but mention at least adenomyosis as a keyword. But look at the paucity of literature before that. And it quite clearly points to what, again, I'll reiterate, an abundance of studies, but a dearth of evidence. And why is this so? This is so, and I will get into that after I tell you the talking points of the presentations. We're going to talk about pathogenesis, diagnosis, particularly in relation to imaging. We'll focus on fertility and adenomyosis, talk a little bit about medical treatment, and land up rounding it up with some discussion on conservative surgery. I'm not going to focus on hysterectomy and adenomyosis because we know that hysterectomy is the definitive treatment of adenomyosis that is more or less self-evident and also proven beyond a doubt. And we also know that if you're going to do a hysterectomy for adenomyosis, you should prefer the vaginal, followed by the laparoscopic, followed by the abdominal route. Let me then start with the problems on this so-called dearth of evidence on adenomyosis. One of the first things is that we still don't know why adenomyosis occurs. There are various hypotheses ranging from invagination of the basalis or the basalis invagination along the lymphatic system or even a metaplastic process. But it is quite likely that the invasiveness of this complex disorder is not driven by a single mechanism of migration, but a time-dependent combination of more than one process. Because we are not very sure of the etiology and the pathogenesis, we are also not very sure of exactly what definition to use. So many of these definitions have been proposed. You can look at the definitions starting from, let's say, 1987, 1962, and 2000, and all of them seem to be quite convincing. However, again, no consensus on exactly how you will define adenomyosis. And all this leads to this, what I like to call alphabet soup, if you will, of histopathologic adenomyosis classification systems, and even the diagnostic criteria for adenomyosis. Moreover, we have still not established a system or technology which could be a clear utility to aid the clinician regarding the prognosis or the impact of medical or procedural interventions across a spectrum of disease phenotypes. So what does this all sort of mean, or how do you tie all of these facts together? You essentially tie all of these facts together by understanding that because of all the complexities which surround definitions, classifications, subclassifications, and even histologic subtypes of adenomyosis, there is no uniformity in literature. You will have one study defining adenomyosis one way, another study defining adenomyosis another way. And obviously, if you don't have a uniform baseline of definition, diagnosis, or classification, it becomes quite impossible to compare the outcomes between studies. What is true, however, is in the symptomatology of adenomyosis, reports seem to suggest that approximately 20% cases of adenomyosis only involve women younger than 40 years, and 80% are from 40 to 50 years old. Now, this is an important clinical point because there has been a lot of discussion about what to do in patients with young adenomyosis, and particularly with regard to fertility. We will be talking a little bit about that, but the point I'd like to make here is that adenomyosis and infertility are not as common bedfellows as one would think. The most severe symptoms are typically associated with the older group, that is the 80%. Adenomyosis is completely asymptomatic in approximately 1/3 of cases. And let me say right here that if you find a patient who's got an adenomyosis detected accidentally on checkups or on those routine body checkups which patients tend to undergo nowadays, you could very well just leave it alone. There is no need to operate on every patient who's have a diagnosis of adenomyosis. However, when it is symptomatic, the most frequent symptoms are menorrhagia, dysmenorrhea, and metrorrhagia. And if dyspareunia is also a complaint, you need to rule out associated endometriosis. In fact, there is this correlation, if you will, between adenomyosis and endometriosis, which actually further muddles the clinical picture, particularly when it comes to infertility. So we do need a comprehensive, user-friendly, and clear categorization of adenomyosis, which includes pattern, only limited to ultrasound, but also bring a little bit of hysteroscopy into this. Let's go a little further into the imaging of adenomyosis. And essentially, when you're doing a transvaginal ultrasound, and this is something which I would like to tell particularly the juniors, that when you are doing a transvaginal ultrasound, keep the TVS probe active as you put it into the vagina. Don't put it all the way in, feel the cervix, and then switch the probe on. This will make sure that you find it easy to image the cervix. You will image the posterior pouch quite immediately, and also you will find it easier to image the uterus from top to bottom, from cervix to fundus. Once you have gone in, image the uterus from top to bottom, turn it, look at the coronal view, and look at the position of the endometrial cavity and see whether anteriorly and posteriorly the endometrial cavity is equidistant. Those are all important features which will which will help you in making a diagnosis of adenomyosis. And essentially, what you will see if there is adenomyosis are the manifestations of the ectopic endometrial glands and stroma, which will look like echogenic nodules and striations. When these glands contain fluid, they may be visible at ultrasound. And most importantly, or one of the most important features is the blurring of the endometrial border, or what is typically known as the junctional zone. So a asymmetry between the anterior and the posterior wall, the presence of cysts, and a poor definition of the junctional zone are quite typical of most sonographic criteria. You should say that there is a good chance that this patient has had adenomyosis. Why do I say good chance? Pathological. So whatever diagnosis you make will be more or less tentative, or will be more or less temporary till you don't achieve a histopath diagnosis. A surprising finding was that the combination of TVS and MRI have the highest sensitivity, but surprisingly, it also had the lowest specificity. So, should you use MRI for the diagnosis of adenomyosis? Quite clearly, as the first line, no. You should use MRI only and only if the transvaginal ultrasound is inconclusive. To wit, I would like to point out here that the use of MRI for the diagnosis or even mapping of the adenomyosis should be an extraordinarily rare event in daily practice. This was an interesting article I found, and this basically says that gynecologists are better at detecting adenomyosis compared to radiologists. It's a heartening finding, but please mind the word an expert gynecological sonologist. And therefore, whenever there are patients of AUB, or whenever there is some abnormality reported by the radiologist, I tend to repeat that ultrasound for that patient, because I do believe it gives me a mental image of what to expect. Of course, adenomyosis can be correlated or can be present along with abnormal uterine bleeding. And because of its complex pathogenesis and variable presentation, it's actually one of the most difficult parts of the FIVO palm coin classification to treat. We will move on now to infertility. And let me begin with a statement which says that we do not know why adenomyosis may be responsible for infertility, or even if adenomyosis is indeed responsible for infertility. And this is what I was alluding to earlier about the relationship between adenomyosis and endometriosis. Because both, we are not sure that it causes infertility, and two, we may not always be certain that there is endometriosis or not. Please remember not to be very aggressive when you suspect adenomyosis in a patient with infertility. There is very limited data concerning the efficacy of the different treatment options of adenomyosis purely on fertility outcomes, and the only published ones are retrospective evaluations or small case series. So this is a rule of thumb of what to do when you're faced with a patient of adenomyosis and infertility. You could either take the approach, if the patient is young and has a good ovarian reserve, of first giving her a GnRH analog for 3 months, let her come out of that GnRH analog, and then do a stimulation with fresh transfers. If, however, you have a patient who has a severe disease, which is so severe that it will come in the way of doing the egg pickup, or if the patient is of advanced age, with or without a poor ovarian reserve, you would then tend to give the GnRH first, wait till the patient escapes from the effect of the GnRH, and then do pickups and transfers. I'm sorry, if there is a patient with poor ovarian reserve, do the pickup and transfer first, then suppress the disease with GnRH, and then do the embryo transfer. We also do not know really about the obstetric outcomes of patients with adenomyosis. There have been suggestions that adenomyosis is associated with poor obstetric outcome. However, we do not know for sure. So if we are looking at medical management of adenomyosis, then these are all the options which are available. There's GnRH analog, progestins, LNGIUS, combined oral contraceptive pills, and the NSAIDs. It has to be said that as of now, for purely medical or conservative treatment, the LNGIUS, as is shown in this table here, does seem to be the method of choice. What is important to remember when you're doing a conservative management is what is your goal of therapy. It should include symptom relief, and if required, increase your fertility. If fertility is a concern, LNGIUS is not a good option. If fertility, however, is not a concern, then LNGIUS for relief from dysmenorrhea, excessive bleeding could be your method of choice to treat adenomyosis. There is good evidence to show that the LNGIUS decreases or even eliminates dysmenorrhea, decreases menorrhagia, and causes a rise in the blood count. GnRH is also a good treatment. However, it is very short term compared to the LNGIUS. A stratifying kind of a feature to identify which patient will do well with medical treatment is that higher failure rates are noted if the adenomyosis has penetrated more than 2.5 mm from the basalis layer. So if you are considering cytoreductive conservative surgery for adenomyosis, do it for the symptoms. Don't do it for the fertility. To it, in the absence of symptoms, there is no place for cytoreductive surgery for infertility. High frequency ultrasound, again, insufficient data. Uterine artery embolization for symptomatic, the word symptomatic is important, seems to be quite effective. Again, data is limited, but in this small study with around 27 patients, it showed that it seemed to work quite well, and 82% of patients could avoid a hysterectomy. Always keep in mind that if you're not doing a hysterectomy and you're doing a cytoreductive surgery, you must keep in mind that the management is complex and controversial, and there are complications. So these are all the various methods that have been suggested for the treatment of adenomyosis. Remember that adenomyosis surgery is not as simple as a myomectomy, and really the evidence for myomectomy is much better than the evidence is for adenomyotic surgery. So the age-old question, laparoscopy or laparotomy for adenomyosis? It seems now, and this is from March 2018, Fertility and Sterility, that focal adenomyotic lesions can be treated laparoscopically. However, diffuse adenomyosis must be treated by laparotomy or even a laparoscopically assisted laparotomy. Open surgery is safer than laparoscopy for diffuse adenomyosis because you can thoroughly excise the lesion to prevent the recurrence, properly reconstruct the defect in order to prevent uterine rupture. And one of the reasons why laparoscopic surgery could be responsible for a slightly higher incidence of rupture could be the use of powered instruments. So if you look at the data on uterine rupture and post-adenomyomectomy, you will see that post-adenomyomectomy patients seem to have the risk of uterine rupture at as high as 6%. And this is considerably higher than the risk after a myomectomy or a previous cesarean or any other form of uterine surgery. So again, I just want to reiterate that it's not that you cannot do it, but keep in mind the fact that all these complications can occur, because if you look at the data which is available now, look at the recurrence, the follow-up hysterectomy rate, and the complications. They aren't really quite insignificant. So consider doing cytoreductive surgeries for adenomyosis only and only if you feel that you really have no other options. So
sorry to interrupt, sir.
Yeah, this is the last slide.
Okay, sir. Thank you.
Thank you. Yeah. So this is just a slide which talks about the algorithm of managing adenomyosis. And let me skip to the slide of conclusion, which essentially says that the medical therapy for adenomyosis should be the first treatment option. The LNG IUS is effective extremely. I mean, this has become my treatment of choice, especially in moderate disease. There are alternate medical treatment options and secondary treatment options, but quite frankly, if your LNG IUS does not work, these are unlikely to work over a long period of time. We aren't very sure about the effect of adenomyosis on fertility, and the effect of cytoreductive surgery of adenomyosis needs to be evaluated and should be restricted and mainly performed in research protocols. Thank you very much.
Thank you, Dr. Tank. It was an excellent presentation.
Hello?
Hello.
Yes.
Yeah, thank you, Dr. Jaideep, for this wonderful presentation. I think we have a plenary session to be started. So let's move on to the next session. I would like to thank all the speakers from this session. And I thank the organizers for giving us an opportunity to chair this session. Thank you so much.
Sorry to interrupt, sir,
Yeah.
but there's a small quiz that will be happening right now.
Yes.
So if you see all the attendees, if you can see, there is a on the right side, you will see a button called live quiz. Am I right, Nitish?
Yes, you are absolutely right.
Yes. So this is a quiz. This quiz, there will be 5 questions, and for every question, we'll be giving you 20 seconds. You have to choose the correct answer, and the fastest reply and the correct reply is going to get a prize at the valedictory session. Quickly, we just have 20 seconds for each question. Your time starts now. Okay, next. Nitish, are you taking care of time or it's me?
You can take a time.
Next. 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 Last question.
Yes, last question. Welcome.
That's it. Done. Time up. Okay, thank you so much, Nitesh. Thank you so much, chairpersons. Thank you so much, speaker.
Thank you, Jinal.
Yes. Moving on, we'll proceed for the plenary session. Thank you.
Request the chairpersons for our plenary session to please switch on their camera and also unmute themselves, starting with Dr. Parag Biniwale sir, who is the organizing co-chairperson. I also request Dr. Ashwini Kale, who is the organizing secretary, and Dr. Parikshit Tank, who is the joint treasurer, FOGSI.
Thank you, Nikhil. And at this point of time, let me welcome President FOGSI, Dr. Alpesh Gandhi, who just joined. We are starting with a plenary session which has two excellent speakers who are going to talk to us about different aspects of ovarian cancer. The first is, of course, our own President, Dr. Harshad Parasnis. Harshad, may I request you to start sharing your screen?
Yeah.
Dr. Harshad Parasnis is currently President of POGS and is the organizing chairperson of this conference. He's a gynae oncologist practicing at his own hospital and also at Bharati Vidyapeeth Medical College and Sassoon General Hospitals and BJ Medical College. He was formerly chairperson of Oncology Committee of FOGSI, and he is author of first textbook on gynae oncology in our country, which was released about 25 years ago. And now, Harshad, we are looking at the second edition of the same book. We are looking forward to it eagerly. Over to you, Harshad.
Thank you.
Harsha sir, we can see the slide. Good to go.
Thank you, Parag, for that kind words. I bring greetings from Pune Society. At the outset, let me welcome you all for today's conference, Just Tumors. And my topic today is surgery for early stage ovarian cancer, standard of care. Early ovarian cancer is always been a clinical dilemma for a gynecologist. Either we face with an apparently benign looking ovarian tumor where ovariotomy is done and then we find that the histopathology shows malignancy, or we have a young female desirous of future fertility who comes with a suspicious ovarian mass, and in this case there is the question, what should be the optimal surgery? In both these situations, we are in a dilemma situation whether to go in and do a conservative surgery or go in and do more extraoperative or radical surgery. In this case, the dilemma continues. And here, explorative laparotomy is the only answer, or surgery is only answer that is going to tell us about the ovarian masses. One of my colleagues at Tata Memorial Hospital always used to say, ovarian masses are like Pandora's box, and you won't know about them unless you open them and get them out. So surgery for disease apparently confined to ovary or pelvis is comprehensive surgical staging. And the goal for comprehensive surgical staging is to remove all the cancer tissue and evaluate the extent of the disease that is there inside. Because based on that, our decisions are going to rely on this comprehensive surgical staging, whether this patient needs further treatment or not. So there are certain questions that need to be answered when we are actually doing a surgical staging. That itself will explain to most of my gynec colleagues why, how, when, which route, whether fertility spotting needs to be done, and by whom. All these questions, if when answered, I think a lot of things would be cleared about how surgical staging for early stage ovarian cancer. So let's come to the first question. Why do we have to do? If you look at the independent predictor for survival, it is basically the residual disease or the adequacy of the surgery that actually is going to decide about the prognosis. And residual disease will actually have an impact on the disease-free and the overall survival. So this is a very important point which has to be kept in mind when you are actually doing the surgery. The second point is that whenever we do an inadequate surgery, it leads to understaging, and understaging leads to undertreatment, and therefore there is going to be a poor prognosis. A study which was done early on by MS Piver also showed the same things, that poor inadequate surgery led to poor prognosis. So surgical staging in the first place, if it is properly done, would give rise to upgradation of the stage of the disease. That means we will come to know that it was not a stage 1 disease, but rather it was a stage 3 disease in 1/3 of the patients who were apparently stage 1 tumors. Secondly, when we do a early stage ovarian cancer surgery, we assign a risk to this patient after the surgery is done, either a low risk or a high risk. And based on that, our decision of whether to give her an adjuvant chemotherapy will be based on that. And as has been shown by many trials, that adjuvant therapy is necessary for high-risk patients to have a good outcome. Now, how do we do this surgery? Well, this is again a well-documented and well-prescribed method. We must take a vertical incision. Peritoneal fluid or lavage should be sent for cytology. Thorough examination of serosa and all visceral structures should be done. Biopsy of any suspicious area should be taken. If not, random peritoneal biopsy should be taken. The commonest, now here, the commonest sites sometimes which are missed are in between in the small bowel mesentery. That is where you must also look at whether there are any further deposits or not. Also, if she has completed her childbearing, then bilateral salpingo-oophorectomy and hysterectomy should be done. Now here again, effort should be done to remove the tumor intact. Unilateral salpingo-oophorectomy can be done in select patients where we are trying to preserve the fertility. Omentectomy should be done because omental metastasis would be the first thing that would be seen in these patients. Para-aortic and pelvic lymph node dissection should be done, and frozen section will help in pathological evaluation in case you are not sure whether these patients are actually cases of malignancy or not. Then come to the third question, when should we do it? Now this is a very important question, because we need to actually assess preoperatively, and we must try to see whether this is a suspicious tumor or not. if it is a suspicious tumor clinically, or if it is on a CT or a ultrasound based characteristics of tumor characteristics, or by size, or by tumor markers like CA125, alpha ketone, beta HCG. Now these are all the markers that were there, but the typical markers that we usually use is CA125. Now on CT or ultrasound, the features that would suggest are very well documented by the IOTA simple rules. And if again here, these rules, if followed, we would be able to actually identify those subset of patients who do need to be, in which we need to be careful. And in the other group of patients who actually are low in score, these patients can be actually gone ahead and just done a conservative surgery. Coming to tumor markers in assessing whether this tumor is malignant or not, or suspicious tumors, we must remember few points. Just by having a CA125 which is raised doesn't mean that these patients are going to have a diagnosis of ovarian cancer. Mind you, there are also certain physiological conditions in which CA125 is going to be raised. At the same time, if the levels are less than 200, then endometriosis, tuberculosis, even these must be kept in mind. I think most of the gynecologic oncologists must have had her case in their lifetimes when they have opened it and found that it was a case of tuberculosis rather than a case of ovarian malignancy. Another point that needs to be kept in mind is CA125 is highly associated to serous tumors, but not to other histotypes. And that this is a very important point. Many times you can have a cancer in evolution, and you could have other types like mucinous would be present, and that has to be kept in mind. And the last thing is that CA125 is raised in only 50% of the FIGO stage 1. So in the rest of the patients, the tumor expression may take time, or you are catching this tumor in a very earlier stage, wherein the rise in CA125 is not that much. And so you have a false sense of security that you are dealing with a benign tumor. Now, in order to allay this problem of having physiological increase in CA125, HE4 has been used rather well, and we have had a lot of scoring system that can help us to identify and get us out of this situation. But the bottom line remains that we must individualize every case and evaluate and then proceed. Few important points that I must share with you when we are doing a sonography is, whenever you have a sonographical picture of a simple cyst, many times ultrasound sonologists do tend to actually do a fine needle aspiration or take a biopsy. Please avoid that. Please do not upgrade the disease. There is no role for neoadjuvant chemotherapy in early stage ovarian cancer. So even just by the look of it, if it looks like malignant, don't give neoadjuvant chemotherapy. And this is a very important statement that all of us must remember. Tissue diagnosis is must prior to comprehensive surgical staging or prior to initiation of chemotherapy for any stage of cancer. I think in this today's world of medical legality, this is very important, that we must be pretty sure that this is malignancy before we do take any radical steps in either surgically or by giving her any chemo or radiation or any other therapy. Here, frozen section can come to our rescue when you are having a tumor which you feel that appears to be suspicious. Go ahead, do a frozen section. It will confirm malignancy, though your pathologist may not always be able to tell you about the type or the grade of the tumor, but at least for sure he can tell you whether this is malignancy or not. Next is, which route do we follow? Now, here either should we follow an abdominal, which is an established route, or the newer routes that have now coming up fast, a laparoscopic or robotic. Now, in laparoscopic, the role is as it is very much increasing nowadays. But the learning curve is most centers is still not complete. You need to be actually very good at your surgical skills if you are doing a laparoscopic surgery for ovarian cancer. And as of now, it is not recommended as a standard of care. It can be used in few centers. I know there are a few centers in Italy who are still using it very effectively, but it cannot be there as a routine, as a standard of care. I went to find in the Cochrane review about laparoscopy versus laparotomy for FIGO stage 1 ovarian cancer. And here the conclusion of the study showed that there was no good quality evidence to quantify the risk and benefits of laparoscopy for management of early stage ovarian cancer as routine clinical practice. That means we still need more studies to substantiate the use of laparoscopy. When we are doing laparoscopy, there is cosmesis, yes, but cosmesis at what cost? Are we actually spreading the disease? Yes. Vergot et al. Clearly showed this, that rupture during surgery will lead to decreased disease-free survival in a multivariate analysis, which was done in a multi-institutional study. And therefore, rupture should be avoided during primary surgery of ovarian cancer confined to the ovaries. Next is, can we do fertility sparing? Yes, we can do surgery only as a fertility sparing method, where either it is a unilateral malignant germ cell tumor like a dysgerminoma or immature teratoma, stage 1A, that is confined to one ovary, or unilateral sex cord stromal tumors, or unilateral borderline tumors, or stage 1A grade 1 epithelial tumors. Unilateral salpingo-oophorectomy may be performed, but mind you, when we are doing this fertility sparing surgery, comprehensive surgical staging must be done to identify this small subset of patients. When you do this comprehensive surgical staging, you will find that in 1/3 of the patients, you still are dealing with a higher stage disease. After doing conservative surgery for early stage disease, we must follow these patients with tumor markers and ultrasonography for the remaining residual retained ovary till her childbearing is complete. And after her childbearing is complete, then the uterus and the remaining ovary should be removed at completion surgery. The reason for that is there is a 9% chance of recurrence in these patients. And lastly, who should be doing this surgery? Again here, an independent predictor of survival is actually the performance of the surgeon. That means the knowledge, skill, and the training of the surgeon is very essential when he or she is trying to do these type of surgeries. Everything requires training in medicine. Early exposure in the curriculum is essential. I think there is a lot of lacunae on this count, and I think a training which is now being imparted in most of the institutions is actually overcoming this lacunae. On training issues, a study was done to understand whether specialist gynecologist or somebody who's trained in gynae-oncology surgery, what is the outcomes when the patient is done, operated or treated by a surgeon, a general gynecologist, and a specialist. It was found that a specialist, that is the person who is trained in gynae-oncology, will have a much better outcomes. That means the patient's survival data will have much better progression-free and overall survivals. This was a study which is a Scottish national study. And here again, the relative risk will be much less with a gynae-oncologist treating the patient. In short, someone who's trained in gynec cancer surgery, rather than a general surgeon whose risk would be 1.33. So, to summarize, for a better outcome, guidelines for comprehensive surgical staging must be followed. Frozen section needs to confirm malignancy before proceeding to staging laparotomy in cases of dilemma. Fertility sparing surgery can be performed in select cases, and surgical training in gynecologic oncology is essential for a better outcome. Thank you all for a patient hearing.
Thank you very much, Harshad. It was indeed a comprehensive presentation. Thank you. May I request Dr. Parikshit to introduce Professor Kazunori Ochiai?
Thank you, Dr. Beniwale. It's indeed a pleasure to be introducing Professor Kazunori Ochiai. He is the president of the Asia-Oceania Federation of Obstetrics and Gynaecology, and he's a professor at the Department of Obstetrics and Gynaecology at the Jiki University School of Medicine, Tokyo. He's what one would associate with the word world authority when it comes to gynecological oncology and especially ovarian cancers. So it's indeed our pleasure and a privilege to be hearing from Professor Ochiai today at this conference on just tumors. Professor, please.
Parikshit,
Thank you.
before
Thank you very
Professor
much. I
takes,
would like to, yes, and I'm okay. Can you see my screen?
Yes, sir. Good to go.
And
Yes.
can you hear my talk?
Perfect, sir.
Yes.
All right. Good evening, esteemed members and distinguished guests. Ladies and gentlemen, I am honored to be invited to deliver a plenary lecture today. Today, I would like to discuss some primary debulking surgery in advanced ovarian cancer patients. As you are aware, the primary debulking surgery is the most important part of the treatment of advanced ovarian cancer. I have nothing to disclose on this lecture. Here is the content of my lecture. Ovarian cancer is the most common death among female genital malignancies. Advanced stage is considered an important prognostic factor, and the prognosis of patients with stage 3 and 4 is very poor. In addition, the ovary is an organ in pelvis. Even if a tumor develops, subjective symptoms are rare at an early stage, and about 40 to 50% of cases are stage 3 and 4 at the time of diagnosis. In other words, improvement of treatment results for advanced stage patients is an incidence and mortality, and it's in other words, improvement of treatment results of advanced stage patient is at most the urgent issues for our as an gynecological oncologist. And the incidence and the mortality of ovarian cancer in the world are reported as 6.6 and 3.9 respectively. Looking at the ovarian cancer morbidity and mortality rate in the world, you can see that it varies from country to country. Furthermore, looking at the trend in the incidence, it can be seen that UK and Japan is on an upward trend, but the France or the USA are clearly on a downward trend. The number of ovarian cancer cases in Japan is on the rise, as shown in previous slide. And it was reported as 10,438 cases, and the incidence rate is 11.7 in 2015. The number of deaths from ovarian cancer is also increasing, with 4,745 cases, and the mortality rate is 2.9 in 2017. Ovarian cancer treatment is an utmost issue in gynecological oncology in Japan. Since the development of and approval of cisplatin was in 1978, and the survival rate for the 5-year survival rate for ovarian cancer has not been improved significantly despite the development of breakthrough drugs such as paclitaxel, bevacizumab, and PARP inhibitors. 5-year survival rate was reported to be 47% in 2015. Therefore, it is clear that the surgery still plays a crucial role, especially in the treatment of ovarian cancer. The primary surgery is the first step of ovarian cancer treatment, and it ensures accurate diagnosis and ensures tumor tissue for additional testing. The other purpose of the operation is to perform surgical staging and reduce tumor burden. Next, I'd like to consider the significance of site reduction. Disease-related symptoms, such as abdominal pain, increased abdominal growth, abdominal discomfortness, dyspnea, and satiety are related to tumor burden. Removal of bulky disease rapidly improves symptoms and quality of life. Ovarian neoplasms produce multiple cytokines, at least some of which are immunosuppressive. Interleukin-10, vascular endothelial growth factors. Thus, removal of tumor bulk may improve or restore host immune competences. The degree of completion of surgery is a particular important prognostic factor. The volume of residual tumor remaining after cytoreductive surgery correlates inversely with survival. And the important impact of site reduction of survival has been reported repeatedly. That the goal of surgery is to remove all macroscopic disease. This is level 1 and grade A evidence. So why does site reduction improve prognosis? The mechanism for the survival benefit with site reduction is that the chemotherapeutic drugs exert their maximum effects on small tumors that are well perfused and therefore mitotically active. While large-sized tumor is associated with polar perfusion and a greater chance of sublethal cellular damage, as well as the emergence of multi-drug resistant clones. Optimal response to post-operative systemic chemotherapy is achieved in the setting of minimal disease burden. Prior to an attempt at debulking, predicting which patients will be able to have at least an optimal site reduction can be useful, given the importance of an optimal site reductive effort on outcome and the potential morbidity associated with performance of major abdominal surgery. Clinical evaluation is taking into account the general condition and nutritional status of patient. PET is not recommended as part of the standard workup for stage 3, but it is optional for some cases of stage 4. There is a limit to examining resectability in diagnostic imaging in laboratory examinations. Thus, it should be considered surgical staging, surgical evaluation. There are two keystone reports. One is Sugar-Baker's peritoneal cancer index, and the other one is laparoscopic evaluation by Fagotti score. For Sugar-Baker peritoneal cancer index, 12 parts of abdominal organs will be checked through median laparotomy and scored by the size of the lesion from 0 to 3. Peritoneal cancer index scores above 17 should not offer aggressive surgery because they do not provide any survival benefit to those patients. This is level 2 grade A evidence. And Fagotti laparoscopic scores that evaluate abdominal organs laparoscopically at the site for omental cake, peritoneal carcinomatosis, diaphragmatic carcinomatosis, mesenteric retraction, bowel infiltration, stomach infiltration, and liver metastasis. Each parameter is attributed a score of 0 to 2. Site reduction is incomplete in 100% of patients with a score above 8. This is also level 2 and grade A evidence. The laparoscopy is a better way of assessing initial resectability because it is less invasive than open surgery. This is level 2 grade A. And primary debulking surgery must include at least complete hysterectomy with bilateral salping oophorectomy, infragastric omentectomy, appendicectomy, pelvic and aortic lymphadenectomy, and debulking tumor tissues. You may perform lower anterior resection of the rectum, splenectomy, partial hepatectomy, diaphragma resection, and peritoneal resection if those organs are involved. And many methods have been reported for para-aortic lymph node dissection procedure. I start from the treating the right ovarian vein. And while following the right ovarian vein, check the inflow to the inferior vena cava and ligate and cut. Then remove lymphatic tissues or parainferior vena cava. Next, the renal vein on both sides are exposed and lymphatic vessels are ligated at the upper edge, which will be the upper limit of lymph node dissection. Hereafter, the lymph node tissues is systemically cleared in this order. However, in the dissection of aortic lymph node, special attention should be paid to congenital malformations of blood vessels. Perhaps many of the audience has experienced 2 or 3 times of these anomalies. Particular attention should be paid to the persistent left inferior vena cava and horseshoe kidney. Now, assessment of lymph node metastasis is crucial to define stage of disease. Therefore, lymph node sampling or lymph nodectomy is essential for diagnostic purpose. However, its therapeutic role has been controversial. Many studies to date have shown that the frequency of lymph node metastasis increases as the disease progresses. Lymph node metastases are observed in more than 60% of patient P23. Our study found that lymph node dissection had a better prognosis than those who did not. But this was a retrospective study. My dear friend Benedetti Panici of Italy conducted a prospective randomized study to see the significance of systematic lymphadenectomy on survival of advanced ovarian cancer patients. What he found was that there was a significant difference in progression-free survival, but not in overall survival. He interpreted that post-progression treatment dilute the difference in two groups. This is also our study. Although there was no difference in overall survival between with or without lymphadenectomy, the difference of survival became significantly if you look at drug-resistant cases. These results suggest that surgical removal of possible metastatic site will contribute to improve prognosis in drug-resistant cases. However, it also suggests if sensitive and strong drugs are developed, aggressive surgery may not be needed in future. This is a famous Lion study. A total of 647 advanced ovarian cancer patients randomized to with or without lymphadenectomy group. The median number of removed nodes was 35 from pelvic area and 22 from para-aortic area. And 57 nodes are removed in total. And survival and complication were compared in two groups. This illustrates survival curves of lymphadenectomy group and non-lymphadenectomy group. Those are almost identical, and overall survival and progression-free survival are not statistically different. However, post-operative complications, such as incidence of repeat laparotomy and mortality within 60 days after surgery, was much higher in lymphadenectomy group. In patients with advanced ovarian cancer who underwent complete surgery intra-abdominally and had normal lymph nodes, systematic pelvic and para-aortic lymphadenectomy did not prolong survival, but it was associated with a higher incidence of post-operative complications. Therefore, they did not recommend systematic lymphadenectomy to advanced ovarian cancer patients as a routine practice. Thus, the systematic pelvic and pelvic lymph nodectomy is are part of debulking surgery. So we have to remove enlarged ovary, enlarged lymph nodes. But what about normal looking lymph node? How can we distinguish abnormal lymph node from normal lymph nodes? By MRI, PET scan, or just palpation? New measure is expected. In order to improve overall prognosis of advanced ovarian cancer patients, the quality of gynecological oncologists should be improved. The trained gynecologist is in qualified center, and the qualified teachers is essential. This is an example of board certification of gynecological oncology in Japan. In conclusion, site reduction is the only but significant prognostic factor you as a surgeon can contribute. But it should be performed by a well-trained gynecologist, since achieving optimal site reduction depends on the judgment, experience, skill, aggressiveness, and passion of the surgeon. Since advanced ovarian cancer involves most of all the abdominal organs, surgical team should be prepared to undertake potentially extensive surgery, such as splenectomy, bowel resection, partial hepatectomy, and diaphragmatic resection to achieve an optimal procedure. Such extensive surgery should be utilized only in a setting where optimal site reduction is determined feasible. So I would like to stress again, training gynecological oncologists is an urgent need. And you as a teacher saw and encounter difficult cases and unusual cases. But you could handle it, and it is more important than anything else that teacher sweats with the trainees. And you learn by teaching, and trainee will learn from the case and from your attitude. I would like to extend my acknowledgement to Dr. Harshad Aparasnis, POGS President, and Dr. Alpesh Gandhi, FOGSI President, and for organizing committee of FOGSI POGS International Virtual Conference, Just Tumors, and also to my fellows and colleagues. And last but not least, I would like to dedicate my talk to patients suffering from ovarian cancer. Thank you very much for your kind attention.
Thank you very much, Professor. It was an enlightening talk, and I'm sure this enriching knowledge and insight is something which will be of value to each and every delegate who has logged in today.
Thank you very much.
Thank you, Professor Ochai. And let me tell everybody that today we have an attendance of about 2,400. So I'm happy that the deliberations which took place in last 45 minutes are being watched by 2,400 people. And the take-home messages that you gave are so relevant and so very important in these days. And I think President Alpesh will also agree that gynaecology is something which we, the FOGSI has to take up as a subspecialty and maybe give our contribution in developing it. Thank you very much, Professor. Thank you, Harshad. And we move on to the inauguration. We have our president who's right here.
For the inaugural ceremony, we have a very talented MOC who has a wonderful smile as well. We've got Dr. Ashwini Kale, who is the General Secretary at POGS as well. I request Dr. Ashwini Kale ma'am to get started, and I would also like to just update. We had a word with Dr. C.N. Purandare, and the sir is just going to be joining in about a minute. He's just switching on his computer.
Good evening, everybody. On behalf of Pune OBGYN Society, it's indeed my privilege to invite you all for this inauguration. And as Parag sir already mentioned, I would like to place it on record that we have a total of 6,000 registrations for this conference and about 120 oral papers and more than 300 posters. To begin with the inauguration, please change the slide. You can play the slide. A very warm welcome to Dr. Alpesh Gandhi, sir, President FOGSI, for the inauguration. Dr. Harshad Parasnis, sir, President POGS. Dr. C.N. Purandare, sir. I also welcome Dr. Robert Coleman, President, International Gynaecological Cancer Society. I would like our FOGSI office bearers to join us for this inauguration. Dr. Shanta Kumari, President-elect. Dr. Nandita Parshetkar, immediate past president, and our 5 vice presidents, Dr. Anita Singh, Dr. Atul Ganatra, Dr. Ramani Devi, Dr. Archana Baser, and Dr. Ragini Agrawal. I also would like Dr. Jaideep Tang, Secretary General, Madhuri Patel, Deputy Secretary General, Dr. Sunil Shah, Joint Secretary, Dr. Suvarna Khadilkar, Treasurer, and Dr. Parikshit Tang, Joint Treasurer, to join us for this inauguration. I hope Dr. C.N. Purandare sir has also joined us.
Robert Coleman is also joining.
Yeah, could you please change?
Nirav, can you check if he's in the waiting room?
Yeah.
No, Purandare sir is still not joined.
Okay, we'll wait for sir to join. In the meanwhile, I would also like to place on record our academic partners, Professor Ochiai, President AOFOG, Dr. Alpesh Gandhi, President ICOG, Dr. Vijay Ahuja Agoy, and Dr. Sanjeev Mishra, who's the President ISO, who have been partners in this conference on just tumor. The conference is endorsed by our partners, SAFOG, Professor Firdausi Begum, who's the President of SAFOG, Professor Dr. Somshekhar SP, the Secretary of ISPSM, Dr. Parag Beniwale sir, President Pune Menopause Society, Dr. Govind Babu, President ISMPO, and Dr. Nandita Parshetkar, President AMOGS. Could you change the slide, please?
Just one second. Dr. C.N. Purandare sir is in the waiting room. Nirav, could you please take him in?
I would now invite Dr. Harshad Parasnis, President POGS and the organizing chairperson for this international conference, Just Tumors, to give his presidential address.
Is my screen seen?
Yes, sir.
Yes, sir.
Can you hear me, Ashwini?
Yes, Purandare sir.
Okay.
Very warm welcome to you.
Thank you.
Yes, sir. We can hear you loud and clear.
Good evening, distinguished guests, friends, colleagues, and delegates. On behalf of Pune Obstetrics and Gynaecological Society, I welcome you all to the FOGSI POGS International Virtual Conference, Just Tumors. Just Tumors, Benign to Malignant, is a dream come true for me. Way back in early 90s, when I was at Tata Memorial Hospital for my gynaecology training, gynaecological oncology did not have an independent existence as a branch. Over the years, it has developed by leaps and bounds to be recognized now as a separate entity and a much sought after super specialty. Throughout my clinical practice, it became evident to me that patients' outcome could be significantly improved by enabling all gynecologists to detect tumors early and provide quality care. This conference does just that. It unites all organizations to help share their knowledge and expertise with us, and thus brings with us one step closer to visualizing our ultimate goal of quality care. To this effect, Team POGS had planned Just Tumors conference in July 2020. But the global pandemic foiled all the meticulous planning done for this conference. The conference could no longer be held in the physical format. If it was as if someone had changed the exam format the night prior. My team felt dejected, and that is when we realized you never know how strong you are until being strong is the only choice you have. We decided to face it and take it as a challenge. After successfully organizing the first virtual conference by any Gynec Society of FOGSI in July 2020, we decided to undertake the Herculean and the mammoth task of organizing the FOGSI POGS International Conference on a virtual platform. Here, I must acknowledge our academic partners, AOFOG, SAFOG, AMOGS, AGOI, ISPMO, ICOG, ISPSM, and PMS for believing in us. The unique feature of this conference are the 5 scientific halls which run simultaneously with 3D virtual lobby, interactive 3D pharma lounge, separate oral presentations halls, and e-poster halls. We wish to give you a wonderful experience that could be unique and would leave you enriched with knowledge. I'm happy to share that we have 5 simultaneous virtual halls running, 4 workshops and 1 IOTA 5 workshop, 22 foreign faculties, 256 national faculties, 7 orations, 46 lectures, 8 panel discussions, 121 oral papers, and 218 e-poster, which was itself a humongous task performed by 56 esteemed judges. We received 5 MMC credit points, 14 ICOG points, and more so, we had 6,000 registered delegates for a super specialty conference. And these delegates were from 47 countries. My special thanks to Dr. Alpesh Gandhi, our FOGSI president, Dr. Jaideep Tang, Secretary General FOGSI, and office bearers of FOGSI for giving us this opportunity. Team POGS 2020 has relentlessly worked to ensure that you enjoy this scientific bonanza in the comfort of your home. Special mention must be made of my team members, Dr. Ashwini Kaye, Dr. Chaitanya Ganpule, Dr. Prakash Kothave, and my dear friends Parag and Kiran, who have worked day and night to make this surreal concept into reality. My dear friends, Dr. Yogesh Kulkarni, Dr. Chetan Deshmukh, Dr. Bhagyalakshmi Naik have been a great help too. And of course, my past presidents, your support and guidance has been profound. All this has been possible thanks to our industry partners who have been a huge help to us. We hope you have a memorable conference and experience in this academic feast. It has been a pleasure. Thank you.
Thank you so much, sir. We now move to the e-inauguration. I now request Dr. Alpesh Gandhi, sir, to e-inaugurate this conference. Nirav, can you share the screen, please? Thank you, sir. I now request our President FOGSI, Dr. Alpesh Gandhi, sir, to give his presidential address.
Thank you, Dr. Ashwini. Professor Dr. Kazunori Ochiai, President AOFOG. Professor Dr. Fardosi Begum, President SAFOG. Today's guest, Dr. C.N. Purandare sir, patron of FOGSI and past President FIGO. And today's guest, Dr. Robert Coleman, President of International Gynaecological Society. Esteemed faculties, international and national. All the office bearers of FOGSI and ICOG, presidents and secretaries of 258 FOGSI societies, all the dear delegates, dear friends, very good evening to all of you. I extend a warm welcome to all of you on behalf of FOGSI. And I am thankful to my friend, Dr. Harshad Parasnis, President POGS, Organizing Chairperson, Dr. Parag Biniwale, Organizing Vice Co-Chairperson, Dr. Kiran Kurkoti and Dr. Ashwini, Organizing Secretaries, Dr. Chaitanya, Scientific Chair, and Dr. Prakash, Treasurer, and Team POGS for inviting me to inaugurate the FOGSI POGS International Virtual Conference on Just Tumor, Benign and Malignant, with a special focus on Gynaecological oncology. My sincere regards to all the patrons and advisors of this organizing team. We are happy to see so many academic partners, as Dr. Harshad has mentioned, AOFOG, SAFOG, Association of Gynaecological Oncologists of India, Indian Society of Oncology, Indian Society of Medical and Pediatric Oncology, ICOG, AMOX, and others. FOGSI believes in respectful, strong, impactful partnership. It is delighted to know that we have 600 delegates who have registered from 47 countries, and we have more than 120 papers and more than 250 posters. This itself speaks about the hard work done by Team POGS and about the success of the conference. We have 7 orations with FOGSI, ICOG, Dr. Usha Saraiya oration. We have so many talks. The conference will appraise practicing gynecologists of the latest and best practices in various important tumors of women's reproductive tract. It will provide an excellent opportunity to interact and network with the expert faculties and leaders across the world. It is also delighted to see that this conference has been awarded 5 MMC credit points and 14 ICOG credit points. I hope the delegates will definitely take benefit of it. I am happy to see today the dream of my friend Dr. Harshad is coming true. Since long we were discussing about this conference, and as he has mentioned, this year all the plans we have to change the platform because of the COVID-19 pandemic. But I am happy to see that he has taken this challenge, and his team has done excellent work. And today we can see the results of their hard work. I am sure this CME will update the knowledge of our members, which will be useful to them in their routine practice. It's a great teamwork. Congratulations to Team POGS. And many times I usually tell them that many times I feel that I am a part of Team POGS, like it is my second society, and like I am an honorary member of Team POGS. I salute you all for doing great work for the upliftment of women's healthcare in India and continuing the great work even in this difficult and unprecedented time of COVID-19. I wish grand success to this webinar. I wish happy learning to all the delegates and safety to all of you. Once again, congratulations to Team POGS, and we are thankful to all the international, national faculties and all the partners. Thank you very much for the patient hearing. Thank you.
Thank you so much, Alpesh sir. Your words of appreciation really mean a lot to us. Now we would play the clips of our partners. We have Professor Ochiai, President AOFOG, Dr. Mandakini Meg, Chairperson ICOG. Dr. Could you just please play the slide? Yeah, Dr. Rupinder Shekhon, who's the Honorary Secretary General of AGOI, Dr. Dhairyashil Sawant, who's the Secretary of ISO, Dr. Govind Babu, President ISMPO, Dr. Nandita Parshetkar, President AMOGS, Dr. Somshekhar SP, who's the Secretary of ISPSM, and Dr. Parag Biniwale, President Pune Menopause Society, and Professor Firdausi Begum, President CEPHOG. Could you please play the clip?
Good evening, distinguished members and esteemed guests, ladies and gentlemen. I am Professor Kazunori Ochiai, the President of Asia-Oceania Federation of Obstetrics and Gynecology. On behalf of AOFOG, I must congratulate Dr. Harshit Paranis, President of POGS, and Dr. Alpesh Gandhi, President of FOGSI, to organize international virtual conference, Just Tumors. I dare to say that we are still in the pandemic of COVID-19. Of course, it is natural to prioritize severely ill patients with COVID-19. But we have gynecological cancer patients waiting for the treatment. We are concerned that delayed treatment of these patients will have a negative impact on the prognosis. It is our mission to learn the front lines of current screening, diagnosis, and treatment, and give it back to our patients. I would like to extend my greetings in the hope that these 2 days will be a fruitful meeting. Thank you very much.
Good afternoon, everyone. I am Dr. Mandakini Meg, Chairperson of ICOG. It's a great pleasure to welcome you all to this very prestigious conference on oncology, that is Just Tumors. At the outset, I'd like to thank Dr. Harshad Parsanis and his entire team who draw such a wonderful program for the benefits of the delegates. A large number of delegates, around 5,000, have registered from 40 countries all over the world. It's also an honor that we are having around 125 international faculty for the scientific deliberations. It's a great pleasure that ICOG has credited this conference with the 14 ICOG credit points. I wish to thank Dr. Harshad Parsanis, President of POGS, to invite me to chair a very prestigious Usha Saraya oration in this conference. I wish this conference a great success. All the best. Thank you very much.
Dear friends and dignitaries, this is Dr. Rupinder Sekhon, Honorary General Secretary of the Association of Gynaecologists of India. It gives me great pleasure to deliver this inaugural speech from the Association of Gynaecologists of India on behalf of the President, Dr. Vijay Ahuja. The word just tumors, though sounding benign, very nicely encompasses most of gynaecology. And I'm grateful to Dr. Harshad Parsanis and his team for bringing something so important to the forefront in this amazing conference, which has, I believe, more than 1,500 registrations already. I wish you the best for all the academic deliberations from which I am sure we shall be enriched in knowledge and gain a tremendous virtual experience while getting a whole new perspective on tumors, their diagnosis and treatment. Wish you all the very best for the conference. Thank you so much.
Hi everyone, I am Dr. Dhairashil Sawant. I am the Secretary of the Indian Society of Oncology, and I am very pleased to be with you here. The Indian Society of Oncology is an academic partner to this meeting. The FOGSI POGS Just Tumors meeting from benign to malignant, I know is going to be a huge success. It's been organized by my good friend Dr. Harshad Parsanis in this new virtual format, as is the sign of the times. And I think this niche meeting will definitely help in addressing the demands of people who are working in this particular field, whether it be surgical oncology, whether it be gynaecologists, whether it be gynecologists who are seeing these type of patients. I know all you members who are attending this meeting are going to be here for a huge, big feast, and I wish the conference all the best. Thank you very much.
Hi, good morning. I'm Dr. Govind Babu. I'm the president of ISMPO, which is one of the endorsing societies. So I'm very happy to endorse this meeting, which is all tumors. And I'm glad to see that you have covered interesting topics starting from the benign to the malignant. And this is going to be on 11 to 13 December. This is the FOGSI POGS International Virtual Conference. I'm very thankful for you people to organize this, and specifically I must thank Dr. Harshad Parsanis, President POGS and Organizing Chairman, Dr. Alpesh Gandhi, President FOGSI, and the Organizing Secretaries, Dr. Kiran Kurtakoti and Dr. Ashwini Kale. I see that you put up a wonderful program. I'm hoping that it will be a great success and everybody who is going to attend will be benefited. It's very important that we educate the members of the society, because most women with these malignancies first meet the gynecologist, and therefore we need to see that they're able to diagnose those early, because ultimately that reflects on the outcome for these patients. So with that, wish you all the very best. Hope you have a successful meeting. Thank you.
WHO, via its SDGs aimed at NCDs, actually highlights that cancer in women still continues to remain a significant challenge in spite of all the therapeutic advances. Hence, the key to better outcome is undoubtedly preventive strategies like universal screening and early diagnosis. Of course, cancer awareness in the community will maximize the effectiveness of healthcare providers. Indeed, this focused conference, aptly named Just Tumors, organized by Dr. Harshad Parsanis, who's a highly competent and a passionate gynecologist, will be an invaluable platform to discuss, deliberate, and decipher key issues in our quest to conquer, control, and possibly cure cancer, and will certainly benefit all the attendees. My best wishes and congratulations to Team POGS and FOGSI.
Dear friends, colleagues, senior, students, fellows across the India, I am Professor Dr. Somshekhar. On behalf of ISPSM, Indian Society of Peritoneal Surface Malignancy, we are extremely happy to partner with FOGSI POGS International Virtual Conference 11th and 13th December under able leadership of Dr. Alpesh Gandhi and Dr. Harshad. This is a very great event. Had this COVID pandemic not been there, it was supposed to be a very mega event in person with a lot of international faculty. Nevertheless, the same hard work has carried on here and fantastic work has been done, and there is an array of very high quality international national faculty and a beautiful program, video sessions, lot of original talks, recent advances, also representation to students, young scientists, best paper awards. So it's a pleasure to be part on behalf of ISPSM, Indian Society of Pattern Surface Malignancy, to partner with this just tumor, benign to malignant. I extend a warm welcome to all of you on this inauguration day and wish a great success for everybody. There is something for everybody to take care, senior most to junior most to students. So I thank the entire team and then Dr. Alpesh Gandhi and Dr. Harshad on behalf of ISPSM. Welcome all of you to Just Tumor, Benign to Malignant for this extra bonanza of the academic event. Thank you very much.
Namaskar. I'm Dr. Parag Biniwale, President of Menopause Society, Pune. It gives me immense pleasure to join hands with Pune OBGYN Society in organizing conference Just Tumors, from benign to malignant. This conference is organized under the aegis of FOGSI, and I'm also happy that this conference has received 14 ICOG credit points. I'm sure the delegates will be enriched by knowledge not only in malignant tumors but also in benign tumors during this conference. Thank you and welcome to Pune.
Respected dignitaries, colleagues and friends, I'd like to convey my greetings to all of you. As President of South Asian Federation of Obstetrics and Gynaecology and President-elect of Obstetrical and Gynaecological Society of Bangladesh, I congratulate FOGSI and Pune Obstetrical and Gynaecological Society for organizing the Just Tumor Conference. As we know, that SAFOG comprises of Afghanistan, Bhutan, Bangladesh, India, Nepal, Maldives, Pakistan, and Sri Lanka. I am glad to say that today 4 of these countries are participating in this occasion. Tumors, be it benign or malignant, has to be taken seriously as both are important for patients and clinical perspective. I like to see this conference from 5 different angles. First, it has pooled the resource person and facilities available for the management of tumors in the region and globally. Second, it has brought the opportunity to share and learn most updated clinical practices, facilities, and protocols. Number 3, it will highlight the programs for prevention, screening, and treatment of various cancers and tumors of female genital tract. Number 4, it will showcase the progress of elimination of cervical cancer, which causes deaths of thousands of women. And finally, it will bring the opportunity for sharing the research experiences, which not only will generate data, but also will build evidences. I thank the organizers and resource persons from core of my heart and express my gratitude for inviting me. I convey just best wishes for the Just Tumor Conference. May Almighty keep everyone safe.
Thank you so much to all our academic partners for endorsing this conference and being with us. I think Meg Madam has just joined. I welcome Dr. Mandakini Meg, Chairperson ICOG, and Dr. Shanta Kumari Madam, President-elect FOGSI. I now request our guest of honor, Professor C.N. Purandare, to give his blessings. Over to you, sir. Sir, you have to unmute yourself.
I'm indeed very happy to be here today, even though a virtual Congress, but happening from Pune, which is the city of knowledge as far as India is concerned. Happy to see many of my friends there. I see Ochai, I see Firdausi Begum, I see Rob Coleman, and many of people there on my screen attending this inauguration as well as participating in this Congress. I bring you greetings from FIGO, and you are well aware that many of these things, the oncology, the FIGO's staging has taken place for such a long time as far as support from FIGO is concerned. I remember the time when in 1983 when I returned to India and having worked a lot on oncology and came back here and started in JJ group of hospitals and doing private practice. Very little was done by gynecologists on their own as far as oncology was concerned, and the oncologists were more or less doing most of the work. At Tata Cancer, we have been insisting for a long time that, and as Harshad mentioned, it was urology and gynecology, which was oncology was together. And the urologist was the head of the department of gynaecology. And we kept on pushing and pushing that, saying that it's time that the gynecologist should be heading the gynecology oncology. And we're happy eventually to have a separation between the urologist and the gynecologist, to have gynecology as the gynecology oncology as the separate wing in Tata Cancer. And since then, we have seen a lot of changes. As far as FOGSI is concerned, we have done a lot of innovations as regards the committees from oncology committee, then even a separate breast committee during my tenure as a Secretary General, so that we would have more and more involvement of the gynecologists in early diagnosis and treatment and the post-treatment availability of all the facilities. I was fortunate enough then, from being a FOGSI president, to go over to FIGO as FIGO president, and I'm very happy to tell you that India has contributed a lot in the representation on the oncology committee of FIGO, and even chair of the oncology of FIGO, which Nirja Batla held during my tenure as the president of FIGO. And a lot of things have happened, and I still remember the time when we went to the WHO meeting in May, and we had a full session from FIGO there, which was attended by Tedros as well as all the other officials of FIGO, and which has culminated now in the 2030 eradication of cancer cervix, which I think is a great progress as far as early detection, now that we know that the vaccines are available and so on and so forth. When I look at the entire program which Harshad has put up, I think it's a phenomenal program. We have 6,000 delegates with so many 125 foreign faculties. And believe me, in the last 1 year, due to the COVID era, the number of meetings that I've held, Alpesh has been the really key person as far as the FOGSI's virtual congresses are concerned. But the attendance has been enormous, because people who could not attend otherwise have been attending on virtual platform, and which has really made a lot of difference as far as the attendance and knowledge receiving as far as all the delegates are concerned. I wish Harshad and the entire team a great success, and I'm sure there is a lot of learning there will be in all the lectures that are going to be held. A great tribute to a great gynaecologist as far as we are concerned, by naming one of the orations as Usha Saraya oration, which Harshad, I compliment you for. She has put in so much work in cytology and cervical cancer management that I'm very happy to see the recognition being given in this international congress by having an oration in her name. And it's a great pleasure to be with all of you, and I'm sure it will be a grand success. I wish you all the best.
Thank you so much, Purandare sir.
Thank you.
I would request Dr. Robert Coleman, President of IGCS, to give his blessings. Over to you, Robert sir.
Thank you so much. I am incredibly honored to be part of this society. When I was first invited and saw the engagement of so many academic centers and endorsement by so many other societies, it was really humbling to see. It's humbling, and even more so because of the importance it is that there is international collaboration to tackle a problem that affects us all. And that's how we care for patients with gynecologic disease. So I'm so honored to be here. And as has been mentioned, it is so nice to see the faces of my friends. Even if it's just this big, I still enjoy seeing my friends, and I miss you dearly. This kind of rescue of a meeting that's so important to disseminate information is a great undertaking. As many of you know, we had to do a similar scramble at the last minute for the International Gynaecological Cancer Society meeting this past September. I know the work that was involved to pull this off. I am incredibly impressed with what you've been able to put together in this in this current environment. I pray that that all of you are healthy and safe in this current environment, and look for a quick resolution to the pandemic. But I just want to congratulate the leaders of all these academic societies and other conferences for coming together to develop this common mission to provide a venue for dissemination of important information at all levels of need, and to do so in such a friendly environment. So thank you so much for having me. It's my honor to be with you today. And I really look forward to these sessions. Thank you so much.
Thank you so much. It's indeed a pleasure to have all such galaxy of speakers here and so many societies together. I now request Dr. Kiran Kurtakoti, Organizing Secretary of Just Tumors, to propose the vote of thanks.
Yeah. Thank you, Dr. Ashwini. May I be allowed now to share the screen?
So you can share your screen now.
Yes, I am sharing my screen. Just give me a minute. Well, on behalf of the organizing committee of the Just Tumors conference, I welcome you all for this final round of remarks, that is vote of thanks. One second, just give me a...
Kiran sir, make it full screen.
Yeah, I'm trying to make it full screen. Just 1 second. Anyway, chalo. We'll begin. This is the organizing committee. On behalf of the organizing committee, I would like to thank all of you for being with us, standing solidly behind the Pune OBGY Society. The FOGSI office bearers, Dr. Alpesh Gandhi and his entire team of FOGSI for endorsing this conference and being an academic partner with us. The ICOG office bearers, Dr. Mandakini Meg, Dr. Parul, and my friend Parag Biniwale for being again associated with this conference, giving us ICOG credit points and being with us to guide us for the scientific content and the academic content of this program. We also would like to thank all the FOGSI committee chairpersons, Dr. Bhagyalakshmi Laik, who has played a major role in this conference, Dr. Kundan, Meenu, Manish Mache, Vaishali Chauhan, and Sneha Bhuya for their contribution and association in this conference. Well, coming to the academic partners, Now, friends, as you all know, this is for the first time probably in the history of the Pune Society that we have been associated with so many academic partners and being endorsed by about 5 other international bodies. So special thanks to Professor Ochai of the President of POGS and his team. Special thanks to Alpesh Gandhi, President of ICOG. Thank you, Dr. Vijay Ahuja, President of AGOI, Dr. Sanjeev Mishra, President of the Indian Society of Oncology. We also would like to thank those who have endorsed this conference, international bodies, Professor Firdausi Begum of CEPOC, Dr. Govind Babu of ISMPO, Professor Someshekar, the Secretary of ISPSM, Dr. Parag Beniwale, the President of the Indian Menopause Society, and of course our close friend, Dr. Nandita Palshetkar, ex-President FOGSI, current President of the MOGS. We also would like to thank our international faculty because they have added a lot to this particular conference, and I acknowledge the presence of Dr. Robert Coleman as one of our international faculties. So thank you very much, and of course Dr. Firdausi Begum, thank you very much for being with us. We have national faculties, over 300 national faculties, so thank you again very much for being with us. As you know, this conference had a huge number of free papers and posters with over 123 papers and about 80 to 100 free posters. So it is very difficult for us to manage, but thank you all the judges. We had more than 50 judges and 75 people who judged the free papers and posters. So thank you for thank you for giving your valuable time and energy and your inputs in judging the free papers and posters. Now, any conference cannot be successful without the support of the partners. So we would like to thank our partners, Zuventus, Sun, Periwinkle, Acumentis, Zydus, and Encure for being there with us in this difficult COVID times. A very much big thank you to MICE, who are MICE Ideas, who are responsible for doing this conference live, on a virtual platform. Their cooperation till today has been great, and we expect them to cooperate in the future also. Thank you so much. Now coming to the delegates. As we all know, we have over 600 registrations, 6,000 registrations, and delegates from over 53 countries have taken part in this conference. So very big thank you to all the delegates. Now, friends, we all know that these 53 countries have got different languages, although the Queen's language is united to us all. But I have gone to a bit more extent to say gracious thank you, shukran in Afghani, Saha in Algerian, Messi in Antiguan, and various language, Medici in Ghana. So these are all the countries whose delegates are a part of our conference. Dhanyawad in Nepalese, and Esose in Nigerian, Salamat in Filipino, Shukran again in UAE, and so on and so forth. So we have taken a great effort to thank you all in your native languages. Hope those grammatically are correct. So thank you so much, dear delegates, for being with us. I think, yeah. And thank you so much, all of you, for being with us in this inaugural function. And I request that all of you be logged in to, today and tomorrow also to enjoy the academic feast. Thank you.
Thank you, Kiran sir. Thank you all the dignitaries on the dais for attending this inauguration. Over to you, Nikhil. We would begin with the plenary session.
Ashwini ma'am, Nikhil is not there. Might be he has logged out.
Okay. So can we begin the
Yes, sure, definitely, yes.
Yeah. I would request our chairpersons, Dr. Firdausi Begum from Bangladesh, Dr. Shanta Kumari Madam, President-elect FOGSI from Hyderabad, Dr. Krishnendu Gupta from Kolkata, and Dr. Milind Dugard sir from Pune to chair the next session.
Thank you very much. And this is Krishnendu Gupta. At the outset, let me place on record my grateful thanks to the Pune Obstetric and Gynaecological Society, my dear friend Dr. Harshad Parasnis, whom I know for a very long time, Parag, Kiran, of course, Ashwini, and whole host of my dear friends from Pune. Thank you for this wonderful opportunity to chair this very, very prestigious session. And we have none other than our, I think he's become omnipresent now, Alpesh. Dr. Alpesh Gandhi is everywhere. And you kind of, I don't know how he manages, what he's eating, when he has time to even have a glass of water. I mean, I think introducing him is going to, take away more time than what is kind of really, required. Although it's customary to do so, but as our President Fogsy, he has made this pandemic, the COVID pandemic, into a humongous opportunity to really galvanize webinars and education throughout throughout the length and breadth of this country. So thank you, Alpesh. Really grateful for all your efforts. You've been ably supported by by the entire team of Fogsy. I must, hats off to them as well. But it's your dynamic vision, and you've just shown the capabilities of a true leader, Alpesh, and we are extremely proud of you. And you're going to speak on something which is dear to my heart. Although I'm not a gynec oncologist, but prevention of cervical cancer is my passion, and you're aware of it, how much we are doing it, not on a personal basis, but also through Rotary and stuff like that. So I think I would request you to kindly speak on Fogsy's vision for elimination of cervical cancer. Dr. Alpesh Gandhi, please, President Fogsy.
Please let me allow screen
Sir,
sharing.
you can allow to share the screen. You can do it, sir.
Okay.
Yeah.
Thank you very much, Dr. Krishnendu, for the kind words, for the appreciation, for the support, and for the generous introduction. I'm going to speak on a topic which is, I'm not going to speak on a scientific aspects of how we can prevent, what we should do when patient is having cervical cancer. I'm going to speak on a topic regarding Fogsy's vision for cervical cancer prevention and elimination. I think we have eminent faculties who are doing exclusive work of cervical cancer, and I wish they all will cover the scientific aspects of this talk. The latest figures from the International Agency for Research on Cancer, IARC, show that an estimated 570,000 new cases of cervical cancer were diagnosed worldwide in 2018. It is the fourth most common cancer in women globally. Every year, more than 310,000 women die from this preventable disease. About 90% of these deaths occur in low and middle income countries. And the estimated new cases of cervical cancer, India stands second to China with a huge number of 96,922 new cases, accounting to 17% in Asia with 68,000 deaths in 2017. And that is why it touches us a lot and our responsibility increases a lot. Unless preventive measures are implemented promptly, the burden of cervical cancer is expected to increase to almost 460,000 deaths per year by 2040, an increase of nearly 50% over the estimated number of deaths in 2018. And the greatest relative increase will occur again in lower middle income countries. In lower middle income countries, challenges in implementing vaccination programs and efficient screening and control policies are major hurdles to the decline of the disease. Cervical cancer affects seriously, it has a serious impact on the women's health. Cervical cancer affects women of reproductive age who are also caretakers in the family. The disability and death due to the disease causes enormous emotional and financial trauma to the family. Cervical cancer remains one of the major causes of death and disability. And the percentage of women dying from cervical cancer is much higher at 61.9% compared to breast cancer at 53.6%. If we look at the estimated number of new cases in 2018 in India, among all cancers in female at all ages, cervical cancer is at number 2 after breast cancer. But the good side is that it is a preventable cancer. And it is a sad part that if any woman is dying from a preventable disease, when we believe that when it is detected and managed at the very earliest stage, it has over a 93% cure rate. And POGSI believes to work to achieve SDG goal for India. And SDG goal 3 is ensure healthy lives and promote well-being for all at all ages. And target of SDG goal 3.4 is by 2030 reduce by 1/3 premature mortality from non-communicable diseases through prevention and treatment and promote mental health and well-being, which covers cervical cancer also. Once American past President Barack Obama declared that we did not come to fear the future, we came here to shape it. And POGSI believes to save the health of women of India. POGSI is the Federation of Obstetric and Gynaecological Societies of India. It is the professional organization representing practitioners of obstetrics and gynecologists in India. With 258 member societies and over 38,000 individual members spread over the length and breadth of the country, POGSI is probably one of the largest membership-based organizations of specialized professionals. POGSI came into existence in Madras on January 6, 1950, before our first Republic Day. And POGSI takes care of 50% of population of India, female, from the adolescent health to teenage health to reproductive health to menopausal age to geriatric age. And the theme for this year of POGSI is safety first for Indian women and POGSians. And we cannot achieve safety of Indian women if we cannot save our women from preventable diseases. So this is must to work for all of us to save our women from the preventable diseases. POGSI believes that it is our responsibility. Reduction of cervical cancer rate lies within our hands. And POGSI supports the WHO call to eliminate cervical cancer as a public health problem. And POGSI also supports Government of India for the elimination of cervical cancer, all its programs and projects. The vision for the elimination is a world without cervical cancer. And the goal is below 4 cases of cervical cancer per 1 lakh women per year. And we believe that 90% of girls, if fully vaccinated with HPV vaccine by 15 years of age, we also support the vision of 70% of women screened with an HPV test at 35 and 45 years of age. And if they all manage appropriately, then we can achieve the target, we can achieve the goal, we can achieve reduction in mortality from cervical cancer. Like SDG, POGSI has its own mission, but like SDG, we should also have our targets, we should also have our plans for the next 3 years, for the next 5 years, and we should make our own targets, own plans, and own strategy for improvement in like MMR, NMR, mortality due to breast and cervical cancer, and other NCDs in India. And we will try to prepare roadmap for the next 5 years with the support and help and cooperation from incoming presidents, Dr. Santa Kumari, Dr. Rishikesh Pai, and others. Yearly targets can be decided and planning can be done accordingly. FOGSI will execute the project during 2020 through Oncology Committee and Public Awareness Committee of FOGSI. It will be achieved by working collaboratively with cancer institutes in the country, Government of India, NMC, WHO, NITI Aayog, ISCCP, NGOs, and other organizations, and ICMR, and with media. FOGSI believes to work for advocacy at different levels and authorities. We wish to publish our position and vision statement. We have our own GCPR. We want to make it more accessible and popular. We want to organize more and more awareness and educational CMEs on preventive and screening modalities for our FOGSians. We want to, FOGSI this year is popular for its community connect programs for spreading public awareness. We wish to organize, and we have organized many screening camps for mass screening even in this difficult time of COVID-19. And we wish to publish a list of referral centers to be sent for further management. And we wish to work collaboratively with other organizations who are working for the elimination of cervical cancer. For advocacy, we would like to advocate at government level to make HPV vaccine a part of immunization, central immunization program, and will continue for the persuasion for it. We wish to advocate for making HPV test easily accessible and affordable in India. We wish to advocate, we will advocate at NMC level to make at least breast and cervical cancer screening clinic and facility mandatory for a permission to start or to run any medical college in India, because we may be wrong, but it is our observation that still in 40% of the places or 50% of the places, this facility is not available. And to start specialized fellowship courses for or DNB courses in gynaecology. And we would also like to work to do advocacy in media by organizing press conferences. We want to identify the challenges for cervical cancer elimination in India, and biggest challenge is lack of awareness. Another challenge is the stigma associated with visit for a gynecologist for the purpose, and there is always a fear of being asked uncomfortable questions regarding sexual practice. And there is a lack of healthcare infrastructure for screening programs still at many some of the parts of India. And another biggest problem is availability of vaccines and cost of HPV test and vaccines. Of course, inadequate trained personnel, poorly developed and accessible cancer diagnosis and treatment facilities at some of the parts of India, and enough budgeting is also a problem. So these are the challenges, and wherever possible, we would like to work from FOGSI. We have our own GCPR prepared in 2018. It is nicely prepared. It is covered all the aspects from urban population and to the rural population, how we can manage for cervical cancer. It is nicely covered all the aspects, and we want to make it more accessible, more popular, and more our members are using. We want to see that more and more our members using this GCPR, very useful GCPR. We wish to publish a position and a vision statement. Federation of Obstetrical and Gynaecological Societies of India reiterates its commitment to fight the disease of cervical cancer and unequivocally confirms the role of HPV vaccine, the role of its screening for prevention of cervical cancer for women of India, irrespective of any caste, any religion, any economical status, and any educational status. We will discuss this in incoming managing committee meeting. We will refine the statement if required and pass it in the managing committee, and then we will publish it, and we'll also like to send it to Government of India and all the state governments. We want to promote a pragmatic approach for elimination of cervical cancer in India. We want to see that vaccinate girls aged between 10 to 13 years with 2 doses of HPV vaccine at 6 months apart. We want to provide a single HPV screen or a VIA screen at ages 35 to 40 years, repeat HPV screen at 7 to 10 years interval, or repeat VI test screens at every 5 years may be considered depending on the availability of the resources and setting, and early diagnose cervical cancer in stage 1 disease among symptomatic women and treat them adequately to reduce mortality. Of course, we would like to do lots of mass awareness programs to make the common people aware about the risk factors for cervical cancers, and we also would like to make them aware about its signs and symptoms, and we would also like to make them aware about that this is a preventable disease and this is a curable disease. We want to make them aware about the vaccines, so many aspects. We want to make them aware that when there is a multiple sexual partner, when there is unprotected sex, when there is having sexual relation before the age of 18, or when there is a history of habit of smoking, or when there is a history of family history of cervical cancer, these are the high risk, and these are the average. These are the women may develop cervical cancer, and we also would like to inform them about the symptoms like postcoital bleeding, postmenopausal bleeding, foul-smelling discharge, weakened immune system. So if they have any such complaints, they can contact their gynecologist. And we want like this in a simple way. Cervical cancer is caused by a virus that is spread sexually. Having many sexual partners is a risk factor for cervical cancer. Like this, we would like to make them aware by a simple measure, simple take-home messages. And we also would like to have public awareness programs to spread the message that it's a preventable. If awareness increases, more and more women will come for vaccination and screening, and small videos will be prepared which can be demonstrated in our waiting room for public awareness. And to increase number of girls coming for vaccination and women for vaccination and screening, we may need something very effective like TV ads with clear message. In adolescent health education, POGS is doing lots of activity, lots of work in adolescent health education, and we have already incorporated and added information of risk factors for cervical cancer and role of vaccination in prevention. Training of FOGSI members in preventive oncology will be the one priority, as we believe that all gynecologists are preventive oncologists, though they may not be a oncologist, they are not the surgeon, but they all are the preventive oncologists. We can counsel, we can screen, we can give vaccine, we can identify patient, we can we can do suspicious, we can refer the patient. So we all are the preventive oncologists, and because of our heavy work in routine OPD, just this is forgotten. We want to sensitize all of them, and we want to update them with the latest development, and we want to see that they all work as the preventive oncologist. We will plan CME's workshop for our FOGSians to update the knowledge of our FOGSI members. We have prepared scientific modules of 3 to 4 hours with proposed faculty banks, and we also would like to have TOT for all our faculties zone-wise, and we can organize it collaboratively with the other associations also. And once we have suspicious, or as when we are working as the preventive oncologists, and if we come across any patient when we are suspecting cervical cancer, we need to refer them. So we also would like to have a list of such referral centers. We may be published on our, it may be published on our website for the benefit of FOGSians and Indian women, specially focus on diagnostic referral and facilities available in the country. It can be done with the support of state governments, medical colleges, public hospitals, volunteer private setups ready for free or low cost care. All regional cancer centers can be referral centers. And the most important thing is our commitment. All FOGSians should resolve to counsel their own patients, to screen their patients, to vaccinate, and to screen based on resources as per the FOGSI GCPR, to have uniformity all over country. And to this is also, we will like to request all our FOGSI affiliated 250 societies to adapt one PHC or one wellness center near to their area to counsel, to screen and to refer women for cancer of breast and cervix once in each month for the next 3 to 5 years, just like many Foxians are providing their free services for antenatal care under Pradhan Mantri Matrusha Suraksha Yojana once a month on 9th. Similarly, we can also add up few centers, at least one center per society. If we can add up, then also we would be able to add up 258 centers where we can provide this facility. And Foxy is already doing a lot of activities. I'm happy to share that we had organized first time in India cervical screening on wheels in trains, and the name was given to the train was Lifeline Express. We have set up all the infrastructure for the screening in the train, and we had decided with Impact India Foundation, Foxy has done this program last year, and we selected a remote centers where facilities are not available. Through this train, we decided to reach to Jharkhand, Chhattisgarh, Bihar, Assam, West Bengal, Bihar, Odisha, Arunachal Pradesh, Tripura, and some of the centers already are covered, and we provided services for the screening and reaching this. The intention is to reaching to unreached places by train. Places covered: Sahibganj, Korba, then Forbisganj, Dhubri, Itanagar, and here we can see a Chief Minister inaugurating Lifeline Express at Korba. And similarly, on 8th March this year, 2020, on International Women's Day, we had organized a screening camp for the females working in police department and in CRPF families. And though it was a beginning period of COVID-19, we were able to screen more than 40,000 women in police and CRPF families. We have received a great support from police department and received a great support from all our Foxians, all Foxy members. More than 210 societies participated in this program, and there was a great enthusiasm. And here we can see this. Here we can see Dr. C.N. Purandare Sir's clinic and all our Foxy members, office bearers, and member from the police department who were there during the camp. These are few photos, these are few memories, these are the support which we have received across India. You can see a great support, great enthusiasm, and great encouragement. We have received so many photos and so many compliments for this program. And at the end, we believe that Foxy can use its vast number of resources by accumulating information about gynec cancer in our country, like it's kind of a registry which in itself be a huge contribution to cancer data of our country. This year we have started a COVID-19 registry, national registry for the COVID-19 with pregnancy. And I'm again happy to share that we have received nearly 2,600 data from across India. And of course, this looks a very difficult task, but we may try for this studies and to collect this data. And at the end, I would like to mention that we want to start a pilot project to prevent and eliminate cervical cancer in the 8 north states of Northeast with our partners. And we are in discussion with WHO for this. In India, the incidence is highest in Northeast states, and so we selected these states for the pilot project. And we wish to conduct the pilot project under the able leadership of our dynamic Vice President, Dr. Anita Singh, who has conducted this mega screening camp on 8th March, World International Day, Women's International Day for Women's. And Dr. Bhagyalakshmi, Chairperson, Gynaecological Oncology Committee, Foxy, and Dr. Nirja Batla, who is the FIGO Oncology Committee Chairperson and member, and convener Dr. Gokul Das for the Northeast area. We have selected one coordinator for each of the 8 states, and we have started to work on it. And we are going to call a meeting of all the coordinators in next week. So women are not dying because of a disease we cannot treat. They are dying because societies have yet to make the decision that their lives are worth saving. This was declared by the then president in 1997 during the World Congress of FIGO. And still, this is true, unfortunately, for some of the parts and some of the countries. Let us work together to eliminate cervical cancer, which is preventable cancer. So in conclusion, cervical cancer is preventable. The onus of cervical cancer prevention lies on us, the gynecologist, as we may the only health personnel the women may contact in her lifetime for this purpose. Let us sincerely make a roadmap for the next 5 years and then for the another 5 years, and to commit to all the call for elimination of cervical cancer by the WHO, by screening women and vaccinate girls every day in our clinics. Our prompt action is required. Cervical cancer elimination strategy offers a major opportunity for FOGSI to champion this in India, to show that our champions can do this, FOGSI can do this, and this is a doable. We can develop a roadmap for elimination of cervical cancer, a mass awareness community connect programs by organizing mass awareness programs, by advocacy and support for HPV vaccination, by doing advocacy for HPV based screening, and then treatment for pre-cancers, diagnosis and optimal treatment of invasive cancer. Palliative care are components that FOGSI can advance. A digital solution can be considered to support the screening programs, as outcome monitoring is critical. A big section of society in our country is still unreached and underprivileged, deprived of benefits of life-saving infrastructure and technology. Let us work together to eliminate the preventable cervical cancer from India. Thank you very much for the patient hearing, and thank you for giving me this opportunity. Thank you.
Thank you very much, Dr. Alpesh Gandhi, for this wonderful, wonderful presentation. Very comprehensive, and it's amazing to see that your vision, FOGSI's vision, is in line with WHO to have a world free of cervical cancer, just like we would want an India free cervical cancer. So I think, since we are running a bit late, I would request our esteemed chairperson, Professor Firdausi Begum, to kindly introduce the next speaker and go ahead with the session. Dr. Harshad, would you like to say a few words?
Thank you.
I think with paucity of time, let us move ahead. I think that will be much better. Thank you.
Okay.
Professor Firdausi.
Thank you. Wonderful, Dr. Alpesh. I salute you. It's wonderful. But let's move on. Dr. Robert Coleman, President, International Gynaecological Cancer Societies, Chief Scientific Officer, U.S. Oncology Research, Texas, USA. It's a man with immense experience. So I invite Dr. Coleman to present his presentation on changing paradigm in managing recurrent ovarian cancer. Over to Dr. Robert Coleman.
Thank you so much. I will share my screen here. Okay. Thank you. Let me just start by saying I want to congratulate Alpesh and your efforts across the FOGSI unity as you approach cervix cancer. The last time I was in India, I had the pleasure to visit many sites, and I've always been impressed, and really have directed people to monitor how India has responded to this crisis for cervix cancer, both for prevention and for early identification. So thank you for your efforts. You really are providing a roadmap for the rest of the world. And I applaud you on your efforts by engaging the health ministry. And I know how much they've been involved in this, in tackling this from a central. So thank you, congratulations. It's really terrific to see. So I'm going to talk on a different venue. Another, what we see as a crisis in our country is ovarian cancer recurrent disease, because this is something that we're having quite a bit of difficulty in getting out of what feels like a ultimate decline in the patient. It is an area where there's been a lot of development. And there continues to be a lot of development, and much of that development is spurred by our increasing knowledge about the biology of this disease. And so I'm going to talk about recurrent ovarian cancer, not just second line, but also some other, further downstream interventions. These are my disclosures. So what I'd like to do today is talk a little bit about what recurrent ovarian cancer is and how it's being redefined. So many people are familiar with the terms platinum sensitive and platinum resistant. I'm going to talk to you a little bit about how we're starting to relook at that terminology, and then to show you how the options for care have continued to migrate and what our future interventions will ultimately turn out to be. This is a slide I use frequently that kind of can outline in a timeline, essentially, what the natural history of ovarian cancer is. So as many of you know, ovarian cancer starts with symptomatology, which unfortunately for most women antedates the diagnosis by 6 months to a year, even in the presence of good and accessed medical care. It's not usually a top of mind cancer for most general practitioners. And until patients come in with symptoms of metastatic disease, is it actually interrogated further to find the primary diagnosis. But once that diagnosis is made, then our decision is then switched to our primary tools, which are surgery and adjuvant therapy, which is largely defined by chemotherapy. You can see there are a number of different nuances along the way in the frontline setting, including whether or not there's a role for surgery in this process, how neoadjuvant chemotherapy is being used across the country, the idea of primary maintenance. And then there's this spring in here before when most patients go through their primary treatment and get a response to the time that the tumor progresses. And then there's this progressive utilization of chemotherapy for multiple lines. Recently, there's been some information about surgery, which I'll talk about briefly in this discussion. But one of the things that's been very interesting to monitor since I've been doing this business, which has been 25 or 20 or so years, is that it used to be that the most gain that we saw in a woman who was diagnosed with ovarian cancer was attained in their primary progression-free survivorship, and that what happened after the patients recurred was very short. But what's happening now is that over the last, maybe 10 years, post-progression survivorship in women with ovarian cancer has started to increase. And this will drive a statistic that many people aren't really all that familiar with, which I'll share with you in just a couple slides. But what we're seeing is that it's at least as long as what we see in the primary for women who've recurred. The duration of time from progression to death is about the same or better than it was from initial diagnosis to first recurrence. And that's really an impressive statistic when you think about the patients that present here are chemo naive. So we don't even know that they're what they have in terms of induced drug resistance, but the patients here have all progressed. So they've been at least educated. Their tumors have been educated against chemotherapy at this point. And so that is actually quite impressive. Now, one of the things that has come to change our approach to this and why this is occurring has to deal with not only the identification of better agents that fall into these chemo boxes, but really it's been about the role of maintenance and concomitant therapy. So the drugs I think most people need to remember that paclitaxel was the newest chemotherapy drug to enter into the ovarian cancer space in 1996. And to this day, it still retains its role as a primary drug to give with platinum in patients with primary disease and in patients who have platinum amenable or platinum sensitive recurrent disease. Okay, so the only gains that we've made here have been in adding something to this drug, which is biologically based. one of which which I'll talk about, is bevacizumab, or the anti-VEGF based strategies, and the other is the use of PARP inhibitors. And you can see now the role and the benefit of these agents across our treatment paradigms has started to become even more prolific. And so as we start to utilize these agents more often and in several different settings, what we find is that we're actually increasing the value. So the main kind of two drivers for this has been the identification of how angiogenesis is important to ovarian cancer cell survival, and how PARP inhibitors can be utilized under restricted conditions for which tumors are vulnerable. And I'll talk about that a little bit. Now, as I mentioned, in the United States, this is still considered a rare disease because it doesn't affect that many women as an incident tumor. And remember, incidence is the number of new cases of a disease that occur over over a time frame. So the annual incidence of this per 100,000 women has actually decreased slightly over time. And you can see the mortality from ovarian cancer in the United States has also decreased slightly over time. Now, this represents nearly, almost 2 decades worth of observation. So it's not something that's changing very quickly, but it is changing. And you can see that the proportion of women who are diagnosed with this, the proportion of women who ultimately die from this disease that are actually diagnosed, that fraction has been basically the same all along. So we really have not made a tremendous amount of gains in the expectations of mortality. But what we have made a huge gain in is a statistic that most people don't talk about, and that's prevalence. So prevalence is the number of women at any one time that actually have the diagnosis. So this is a very interesting statistic, because if you think about this, these are the number of people that enter the pool of new cases, right? So every year you have another, let's say 20,000 women that enter the pool. At that same time, you have about 16,000 or so of them that exit the pool. But even though those numbers are continuing, what's happening is that the women that are diagnosed, let's say in 2008, instead of expecting to die in 2011, they're actually dying in 2013. And so what's happening is that you're having this kind of like accumulation of patients that are surviving longer. And so the way that you check that is to monitor how many people actually have a diagnosis at any one time. And if you monitor prevalence, you can see it's been slowly increasing, and then something happened in 2014. Something happened in 2014. First of all, it was a big change in the rate of this acceleration of prevalence. But secondly, we crossed this 200,000 total prevalent line, which in the United States is very important, because that's a line that designates whether or not a tumor is considered orphan, meaning it's rare. So in 2014, ovarian cancer's prevalence got it out of the quote unquote rare category, and it's continued to accelerate. So the question is, what happened in 2014? So one of the major things that came up during this process, as many of you know, was the development of the PARP inhibitors and the approval of the anti-angiogenesis inhibitors. And those have essentially been very important because they have played a role not only in the concomitant administration of drugs, but also in the maintenance. So today's focus is really on second line, recurrence, and predominantly in second line, because that's where this all starts. And so one of the questions that comes up, as I mentioned early on, was how do you classify these patients? And while it seems very easy, because people will say, well, we've used this terminology in the past, and somehow 6 months emerged as the discriminator. And the thought was that if a patient, presented with disease less than 6 months from their previous treatment completion, and that being platinum, then they were considered either platinum resistant or refractory, and they got non-platinum based therapy. And if they had magically, 6 months or longer, they were considered platinum sensitive, and then they were treated with platinum. So I always tell the story that I had a patient who came in on a Thursday when my clinic was, and she was about 3 days shy of her 6 month window, and we had a protocol that was open for her because she was platinum resistant. And as part of the screening criteria, she was required to have a CAT scan. but I couldn't get the CAT scan scheduled until Monday. So when she came in Monday to document that, yes, indeed, she had recurrent disease, she was now 6 months and a day, and she magically became platinum sensitive. So obviously that's not how it works, but it is the problem that we have with trying to use these hard endpoints as to describe the patients that we're trying to deal with. The problem is that this particular line in the sand is like how people create treatment algorithms in their head. And I want to try to break that down, because I think it's clear that when we think about what the opportunity to respond to platinum again is, it is actually more of a continuum. And this is a graphic I've used for years that shows in these gray bars the anticipated response rate due to treatment, and the progression-free survival in red, and the overall survival in yellow. And so you can see that when you use the categories as they were originally described back in 1989, you can see that there's actually a relatively linear relationship between the time of away from platinum and the anticipated response to any therapy. So this variable is not about 6 months. It's really about what is the best treatment based on the treatment for interval and their most prior exposure to platinum. And just to put this into some more context, this is a study that was published a couple of years ago that actually shows that in patients who would be considered platinum resistant, so less than 3 months or 3 to 6 months, the best drug, if you're considering platinum or non-platinum, looks like it might be platinum. So just let me share with you how this looks. So these graphics that are unfortunate, this is right out of the manuscript, so it's kind of, it's not the best way to present the data, but let me just share with you. These blue bars reflect response rate. And these are patients who were given platinum, and this is their platinum for interval. So you can see in patients that are less than 3 or 3 to 6 months, the likelihood of responding to platinum when it was given again, somewhere around 40%. And the likelihood of responding to a non-platinum in that same type of interval was about 25%. So at least in this kind of scenario, it looks like platinum may be an actually good drug to give in platinum-resistant patients. So again, I just caution you to think about the characteristics of the patient you're thinking about treating based on these metrics that don't clearly define who is platinum resistant and platinum sensitive. And over here, you can see basically for that 3 to 6 month cohort, this group of patients, this is the PFS curve for patients who got platinum after platinum. And this is the group of patients who got a non-platinum after platinum. So just an interesting observation. So a couple years ago, we decided to write about this, and we thought that maybe instead of using the platinum-free interval as the main discriminator for patients with recurrent disease, is that we ought to take into account histology, their molecular signature, particularly the BRCA status. The treatment-free interval, we went back to the traditional allocation, which was actually first purported by Blackledge in 1989, and the number of prior treatment regimens, so 3 or less or greater than 3. These seem to be very strong predictors for our anticipated response to the next line of therapy. Now, these are made on easily attainable factors. Probably the most restricted would be understanding molecular signature, but now there's concerted global effort to understand the BRCA at least the germline BRCA status of our ovarian cancer patients. And in most of the guidelines where the testing is available, it's recommended that that knowledge be known. But this is continuing to morph, as you can imagine, as more and more science emerges. We've learned a lot more about ovarian cancers that all look the same. So if you take a patient, for instance, that has a high-grade serous ovarian cancer, and you start looking at ways that the tumors are different, you can see there's at least and there's several of these out there, but there's at least this 4-term classification based on different genotyping that shows these other categories which have prognostic value. So we're not quite there yet to be able to do this kind of subdivision, but it's already happening in endometrial cancer. So I can tell you that as the world gets more complicated, this will change. And the other thing I would like to just kind of highlight when you're thinking about patients with recurrent disease is that in addition to the factors that I mentioned already, there is a strong potential impact of what's available in the line just previous. So this would be the frontline setting. And the question is, how do these decisions impact these decisions? And one of the things that we've learned in this process is that maybe if these patients had access to PARP inhibitor, we should add that as a fifth category. So in addition to histology, their BRCA status, the treatment-free interval, and the number of lines of prior therapy, if one of those lines was a PARP inhibitor, it has a dramatic effect on what our anticipated response to treatment would be. So so again, I just wanted to highlight that the idea of platinum sensitive and platinum resistant is very difficult. And at the regulatory level, in other words, at the FDA level, it's very difficult for us to make a convincing argument that a patient is either platinum sensitive or platinum resistant unless the immediate line of therapy was platinum. So this is becoming a very real part of our daily lives. Now, for patients that are considered I'll say platinum not amenable. So this would be patients who have been treated with platinum and progressed on it in the recurrent setting. This is the space where most of the single agents that are available to you have been studied. And I've just listed here the numerous phase 3 trials that have been done in this setting, including those that have FDA approval for this, and that's weekly, topotecan and pegylated liposomal doxorubicin, which were approved by these big phase 3 trials, which actually didn't show any benefit. They were for a time to progression overall survival. There was no actual survivorship benefit. There are 2 positive trials in this setting. Both of them involve drugs like treosulfan and canfosmide. And both of these trials are essentially positive for the control arm. So the novel drug versus the control arm, these were negative trials. So that's why I highlight them. But otherwise, you can see that all of these drugs essentially have performed the same when put head to head. So when you look at the NCCN guidelines, what you see is a laundry list of drugs that are acceptable. It doesn't mean they're great options, but they are definitely acceptable because they've all been interrogated in these head-to-head competitions, of which we've not seen any distinction between the two. So the next thought was, well, we've got these fancy new biologics that were emerging, and we thought, okay, well, maybe we can either combine drugs together or we can add a biologic. And you can see here that the biologics have appeared to provide some benefit. Trebananib and bevacizumab both were studied and found to have at least some benefit on progression-free survival. But the one I think that's gained the most traction has been bevacizumab, and this was approved in many places around the world on the basis of this trial, the Aurelia trial, which was taking a physician's choice chemotherapy that was non-platinum based and taking that same chemotherapy with bevacizumab. Relatively small trial, given the number of drugs. So you could use weekly paclitaxel, one of 2 schedules of topotecan or liposomal doxorubicin, and you threw in bevacizumab to that, either yes or no. And basically what it showed was that the overall objective response rate was dramatically increased if you added bevacizumab. And if you gave, and if you looked at the PFS, you can see there was a big difference in the progression-free survival, essentially doubling at the median, with no real difference in overall survival. But you can see the treatment benefit, the treatment arm for the combination here. And you can imagine the crossover that was seen in this type of trial. But I think what was really caught a lot of people's attention was the subgroup of patients who actually got paclitaxel given weekly. Now, this was brought a lot of attention, not only because you can see there's a big effect in both progression-free survival and overall survival, but when paclitaxel is administered in this weekly format, it has a different kind of anti-angiogenesis effect. And because of that, we have essentially 2 anti-angiogenesis drugs being administered at the same time, as well as a cytotoxic agent, paclitaxel. So this was obviously of great interest, and it's been a reference point for most of the trials that we've been doing. And because of that, in 2014 in the United States, this was FDA approved. So in platinum non-amenable or platinum resistant patients, we have like as I mentioned, we have a laundry list of drugs that can be good. None of them are great. there's, at least under the restrictions of bevacizumab, it's bevacizumab's approval, which is 1 or 2 prior therapies, it seems to augment chemotherapy response. What about the other group of patients, the platinum amenable patients, let's say, that, or the platinum sensitive patients? So the first question that should be entering your mind is whether or not this is a group of patients that have that are good candidates for surgery. This has been obviously something that we've been debating for quite a long time. At this year, last year, this time we published GOG 213, which is this curve here, which showed that there was no benefit to surgery in patients who were platinum sensitive and were randomized to surgery versus no surgery. At ASCO this year, we saw this trial, Desktop 3, and this trial, SOC1, and you can see they came to different conclusions. In Desktop 3, we saw a benefit to surgery versus no surgery. And in the SOC1, we saw no benefit to surgery versus no surgery. So it's very much debatable. One point I'll highlight here, though, is that if you look at the median survival for overall surgery, you can see that these numbers are very close to each other. And if you actually align the curves on top of each other, they look very close to the same. So more to come about that. We don't have time today to debate that topic, but I'm happy to. In terms of adjuvant therapy, the first kind of maneuver we made in this setting was to add something to platinum as a backbone. So you can see these 4 trials we're looking at, or 3 trials, we're looking at something added to a platinum. We had a non-platinum doublet here that was also positive. And then we had the Calypso trial, which was looking at 2 platinum doublets compared to each other. And overall, what you saw is that all of these trials showed a benefit to giving a platinum doublet. Now, a question that comes in is like, if you have a platinum sensitive patient, can you make them more platinum sensitive by giving something else? So this was an idea that was been around for a long, long time. I can tell you, we talked about this by trying to take platinum resistant patients and give them something to make them a longer than 6-month platinum-free interval. And this is a study that was just published about 2-3 years ago that looked at this in a prospective trial. And they basically showed that if a patient was given platinum first, followed by non-platinum, versus non-platinum followed by platinum, the patients who got platinum first did better for both their overall survival and for their secondary exposure to platinum. So, so if you have a platinum amenable patient, give them platinum. Now, as I mentioned, in the frontline setting, there had been a lot of work done in adding these novel therapies to chemotherapy backbones. And bevacizumab was the first of these to be evaluated as well in the platinum sensitive setting. As I just showed you, it was positive in the platinum resistant setting. So the idea here was to do this same experiment using multiple different chemotherapy backbones. There's a long history of that. They're all listed here, but I want you to just look at the red. So all of these trials essentially showed that there was a benefit to adding bevacizumab to chemotherapy in platinum sensitive patients. And these are big numbers, right? These are pretty strong hazard ratios. And then in 2 of these trials, we actually saw that there was an improvement in overall survival. So a very important effect. And in 2016, so 2 years after the last approval for bevacizumab, this was approved in recurrent platinum sensitive disease. But the big story here is really about PARP. PARP inhibitors are drugs that we use in patients who have deficiency at the molecular level in a process of DNA damage repair called homologous recombination. These trials were started out initially as therapeutics. So they were actually given as treatment in patients that were defined by genomic, first by genomic BRCA mutations, and then secondly by genomic instability we call homologous recombination deficiency. And the trials that proved their value were in that maintenance setting, where patients who had been platinum sensitive, had a response to platinum, and then they were randomized to a PARP inhibitor, and there's 3 of them, rucaparib, niraparib, and olaparib, versus placebo. And you can see that these hazard ratios are very impressive, numbers that we've never seen before in this setting, all of them highly statistically significant. And with this one trial here down at the bottom, Solo 2, there is a hint that there may even be an overall survival advantage to the use of these drugs in recurrent disease. So this is a big, big win. And of course, in the United States, all 3 of these drugs are approved approved for treatment in platinum-sensitive patients. So the current FDA approvals for this important role of maintenance are bevacizumab is approved for platinum-sensitive and for platinum-resistant disease to give with chemotherapy without restriction on the patient population, but there is restriction on the potential adverse events from bevacizumab, and that needs to be accounted for. The PARP inhibitors are also approved with no restriction on the patient population, but in my opinion, they should not be used in patients who've been previously exposed. While I can say to that about PARP inhibitors, it doesn't seem to be true about bevacizumab. So MITO16B was a study that was specifically designed to evaluate the effect of bevacizumab in patients who had bevacizumab in the previous line of therapy. And in this trial, what they used was gemcitabine and carboplatin, and it required everybody to have been exposed to bevacizumab with platinum in the frontline setting. And when they gave it to them in the recurrent setting, you can see that bevacizumab versus no bevacizumab has basically the exact same outcome that was observed in the OCEANS trial, which was in Bev-naive patients. So there doesn't seem to be a detriment to the reuse of bevacizumab. And this is not only for ovarian cancer, this has also been seen in colon and lung and many other tumor types. That's not the case for PARP. If a patient has been given PARP and they progress on PARP, giving the PARP to them again shows no effect. So, so in my opinion, it should not be used in patients who've progressed on PARP. The question about whether or not a patient actually progressed in patients who didn't progress on PARP in the frontline setting is actually the subject of an ongoing trial called OREO. And this trial will look at these patients who've been previously exposed to PARP inhibitor, have responded to platinum again, and then they're randomizing them again to a PARP versus no PARP. So we'll have some information about the PARP after PARP question, knowing that Bev after Bev is okay to do. All right, and so just before I close, I just want to just highlight, where this field is going. As we learn about the different processes of what drives cancer, we are developing more and more innovative ways to interrogate and disrupt these processes. And I've just listed kind of those just general classifications here on this dial, but I can tell you that they're becoming even more and more complicated as we understand, for instance, what is responsible for invasion and metastasis. This is an exploding field right now, as is immunotherapy. So, in terms of what we do in the recurrent setting, the first thing is to try to provide a very good description of what it is that we're expecting to see from the patient. In terms of their classification. So patients who fall into this platinum amenable setting, we tend to want to give platinum. If they don't have a contraindication of bevacizumab and they're considered to be homologous recombination proficient, we tend to re-challenge those patients with platinum and give them Bev. If we know about the tumor's homologous recombination deficiency status, then we will frequently treat with them with platinum here and then give them a PARP inhibitor as a maintenance strategy. There is a trial that's ongoing right now called the Bouquet trial, which is also, I just wanted to show it to you because this is kind of a phase 2 trial, and you can see the histologies that are listed here. These are all the ones that are generally excluded from the previous trials that I told you. But the importance I wanted to highlight here is that the arm assignment for this trial is all based on molecular characterization. So it gives you a good sense of how we're starting to dig into these tumors and even subclassify them even more. So instead of just having platinum sensitive and platinum resistant, we've got all of these other categories now that we're starting to explore into. And with that, I want to congratulate the society. Thank you for your invitation. Thank you for what you're doing. And thanks for your attention during this talk.
Thank you, Dr. Coleman. It was a very informative talk. I think a lot of new vistas, new directions that are opening up in recurrent ovarian cancer, and I think you really touched them in the right way. And I think it has been a really excellent talk, very comprehensive on the subject. Thank you.
Thank you. Appreciate it. Thanks for having me.
name for the chairpersons. That's Dr. Madhuri Patel from Mumbai. Hello, ma'am. Can you just wave your hand? That's enough. Yes. Thank you. Dr. Vaishali Chavan from Pune. Yes, I can see her name. If you can just switch on your camera, ma'am, that would be great. Moving on, I would.
Jinal, Dr. Vaishali is traveling, so
okay.
Yeah, she will.
Okay.
She could connect. She could.
That's it. That's it. That's it. I just wanted your confirmation. Nothing else. Thank you. Next, moving on, I would like to invite our next. Let me check if Dr. Swati's name is registered here. No, she's not between us. Maybe she can join in the later session. Moving on, with your permission, chairpersons, can I request if we can start our session 1 or 2 minutes early so that the speaker gets sufficient time to talk on their presentation?
Sure, sure, sure.
Yes,
sure.
Thank you. So, well, chairpersons, with all your permission, can I, Nitesh, can we have the first introduction slide? And our first speaker is Dr. Ajay Srivastav from Pune.
Are you going to introduce Dr. Ajay, or we are going to introduce?
Sir, ma'am, I would like, it would be honor if you would introduce the speaker.
Yeah. Okay.
Yes.
So I will just introduce myself in one line. Good evening, all my seniors and juniors. I'm Dr. Madhuri Patel, Deputy Secretary General of FOGSI. We are with our session on tumors during pregnancy. As all of us are aware, that some of them are benign and some of them are malignant. So we have to decide what to do during pregnancy. If they are benign, whether we can wait and watch and do still wait in early cases, or remove the tumor and wait for the pregnancy to proceed. It all depends upon the patient, understanding whether she wants to continue pregnancy or not. And in advanced stages of malignancy, we may have to do operative line of treatment and can stage at the time of laparotomy. So these are the different issues, different challenges, not only to the clinician, but also to the patient. So now we have our first speaker, Dr. Professor Ajay Srivastava. Before introducing to him, I would like to mention that he is going to talk on myomas during pregnancy. These myomas, as we know, we have seen, we all as an obstetrician has treated myomas during pregnancy. But he is going to give us a recent advances, which is more, these myomas are found more common in leg races, which is the incidence is about 10 to 18%, and out of these 10 to 30% develop adverse outcome. We are always taught, okay, what are the effects of fibroid on pregnancy? They are abortion, preterm labor, malpresentation, antepartum hemorrhage, that is placenta previa, abruptio placentae, labor dystocia, and then we can have. And we are taught what are the effects of pregnancy on fibroid. And all of us are aware that usually the fibroid grows. The patient complains of pain right from the second trimester of pregnancy, end of the second. Yes, yeah. And I will invite Dr. Dr. Professor Ajay Srivastava to elaborate on this topic.
Yes.
Doctor, it is my proud privilege to introduce Dr. Ajay Srivastava. He is the Armed Force Medical College, Pune. He is professor in Armed Force Medical College, Pune. He has been awarded prestigious Tripta Umranikar, that is commonly known as ME-DD award for standing first in Pune University in MD. He is a peer reviewer of Elsewhere Journal and our Jogi Journal of FOGSI. He is interested in medical education, gynaecological and high-risk pregnancy and gynec endocrinology. Over to Dr. U. Ajay Shrivastava.
I'm so sorry to interrupt in between, Dr. Ajay. Can you just give me a minute? This is a request from my end to keep the sessions on time. I request the chairpersons and the speakers to keep the questions and the introduction, the detailed introduction at the end of the session if we have any time.
So do I have a green signal now to start?
Yes, sir. Yes, sir. Your presentation is live. We can go ahead. Thank you.
Thank you very much. Firstly, my job easy because she has already explained a lot, so I don't have to speak much, and I am surely going to be within my time, and I'll not exceed. Now, topic has already been told. Now I'll just discuss a few cases which possibly will tell us the various things which happen. This is a live case which started on 11th of January. Complaint of nausea, vomiting, lower abdominal discomfort and heaviness, and on examination, size of the uterus was approximately 6 weeks. Now, whenever we have a patient where the discrepancy of uterine size is far away from what the patient says, our response is always such that the patient's history may not be correct. So this patient belonged to a family who the husband was a service personnel, and the service person had left about 6 weeks ago, and she said that it's not possible that her pregnancy could be 16 weeks. Of course, we are very big and we always would smirk at these things that husband is not required for pregnancy. So then we said, don't worry, madam, we'll just show the child and the size to you. And sure enough, we did an ultrasound. The moment we did an ultrasound, we realized that the patient was absolutely correct and had the last laugh. We had a gestational sac which was just about 5 to 6 weeks. We did not even see the fetal pole. And we had an anterior fundal fibroid which was approximately 15 centimeter in diameter. Now, therefore, what I was trying to show that this can always happen. The prevalence is 1.2 to 10.7%. However, the range varies, and as Madam Chairperson has just now said, it varies up to 18% in certain subgroups. The location can be variable, and it's not always easy to diagnose clinically, as the fibroids soften in pregnancy and therefore lose their clear margins and the clear boscillations. It merges with the rest of the wall of uterus, but usually not missed for very long because of frequent availability of sonography. This patient was followed up. We reached about 12 weeks, 3 days. She had no symptoms. She was normal. The uterus had by now become 28 week size. Fetal parts were still not felt. But on an ultrasound, we found that it was a 12 weeks fetus, which is corresponding to the size of the pregnancy. And what we must notice that the fibroid had grown in size by now. From 15 centimeters, it become 18 into 20 centimeters. This patient was followed up. Another 4 weeks later, she comes to us with mild fever, severe abdominal pain, mild tachycardia, blood pressure normal. On examination, she was found to have tenderness around the umbilicus. Biomanual examination showed a closed tubular cervix. Now, the worries were that did she have a red degeneration? Did we have a spontaneous abortion? Did she have a UTI? These were the initial differentials for this patient. Now, how do I evaluate? We have a bedside ultrasound in our outpatient department, and we evaluated this patient again. And the original, if you remember the previous image, that ultrasound had showed a smooth hypoechoic ultrasound fibroid. Now you see the changes had become heterogeneous, suggestive of degeneration. So this was a classical case of red degeneration. Now, what all can happen? Either can be no change, or the commonest symptom could be pain, which could be because of red degeneration, torsion, impaction, or pressure to the various neighboring organs like bladder, urethra, rectum, etc. Size may change with pregnancy, may increase, but most of the increase takes place exclusively in first trimester. But the growth is unpredictable. It may happen only in about 20 to 30% patients. It also shrinks back to normal during puerperium. One more thing which I forgot, the like a placenta which is close to the lower segment, there is apparent migration of the placenta as the pregnancy grows. Of fibroid, which initially in a non-pregnant early pregnancy appeared very close to the internal os, would appear to have migrated far away from internal os as the widening of the lower segment takes place in advanced pregnancy. Further follow-up, this patient became asymptomatic following conservative therapy for 3 days. What do we give? We normally give them rest, take care of any symptoms, so pain, NSAIDs can be given, and she was discharged after 3 days. Another 12 days later, she comes back to us. By then, she is 19 weeks and 4 days. Fresh abdominal symptoms. Again, she has pain. Now, this time, the cervix was dilated 3 to 4 centimeters, unfortunately, and she was diagnosed as a case of inevitable abortion. And unfortunately, she had a complete abortion within the next 2 hours. So you can see the same patient remained asymptomatic for some time, then had a red degeneration, then had a similar symptoms, but this time it was not degeneration, but it was a spontaneous abortion which completed within a short while. The second case which I'm going to tell you is a 27 years old second gravida who came to us with 34 weeks of immunity. Till now, she was absolutely all right. She had a well-diagnosed anterior wall submucous fibroid uterus with 5 centimeter to 7 centimeter. She presented with pain abdomen of 2 hours and a vaginal bleeding of 2 hours. Blood pressure was normal, pulse was high, she had pallor, uterus was tense and tender, and ultrasound revealed the placenta is upper segment anterior, located over the submucous fibroid, and retroplacental lakes were found. A bimanual examination of the cervix was 4 centimeters, delivered vaginally. She went into atonic postpartum hemorrhage, and the total antepartum and postpartum blood loss was approximately 2.5 liters. So now we will quickly talk about what are the possible effects of fibroid on pregnancy. We have seen in this patient, as madam has already told us, 10 to 30% develop complications, which could be miscarriage, preterm labor, PPROM. Abruptio placenta is 3 times higher, and the risk factors are a submucosal retroplacental fibroid, especially if the size is more than 200 centimeter cube. Placenta previa also is twice as common as a patient without any fibroids. Can also lead to FGR, and very rarely fetal compression has been reported, leading to dolichocephaly, torticollis, and even there have been 3-4 case reports of limb reduction. So these are very rare, but one should always know that these are always a possible complications. The case 3 which I have is a 38 years old primate, slightly elder. She has reached 39 weeks without any symptoms. She has an anterior low-lying 7 centimeter fibroid. She also has a malpresentation. Cesarean section has been planned. And now we are a little worried. This fibroid is low-lying and cesarean section has to be done from the lower segment. So how do we do? Our standard approach for cesarean section for a lower segment fibroid till about 13-14 years ago used to be, do not touch the fibroid. Go in an area where there are no irregularities. So we gave a classical incision on the upper segment of this uterus, delivered the child, sutured up the uterus, and closed the abdomen and came out without touching the fibroid. Now, this has been my standard practice for the first, let's say about 10-15 years of my gynae service. Then I saw one presentation of a colleague of mine with whom I ultimately worked also for about 1 year. He presented a series of nearly 70 odd cesarean myomectomies which he had done. And then when I got to a chance to work with him, he's a younger colleague, but he's very experienced in doing cesarean myomectomy. I also started with a little bit of courage. And this is my first cesarean myomectomy, which was done several years ago, maybe about 12 or 13 years ago, in which you are right now seeing the cesarean done. This is the head end and this side is the foot end. This is the incision of the uterus and the fibroid is below the incision. So this was, we are lucky that we could get a little bit of space, and this was something which was in the lower segment and extending to the cervix. Ultimately, a myomectomy was done, so fibroid was removed and the uterus was closed. I have a very small video of this. I will show some part of it because it's a more than a minute's video. So I'll just show this video a little bit. So you can see the video. This video is showing the same uterus being cut, where as you see, once the plane is found, the white glistening fibroid can be removed without too much of blood loss. Easily, with a little bit of blunt and sharp dissection, this fibroid could be removed. Wherever there was a resistance, some more sharp dissection was done. So this is how it was done. Now, ultimately, this is a case series which has grown from 70 to 113. I have operated only 7 cases out of that. My colleagues, mostly my friend in the Indian Navy who is in Bombay right now. Many people in Bombay might have heard of his hospital, INHS Ashwini. He has done most of these 106 cases. All kinds of fibroids, solitary, multiple, all locations including cervical and broad ligament. Blood transfusion was required in 6 cases. However, hysterectomy was required in none. Compared with cesarean section, the operation time increased by average about 13 minutes. However, there was no significant change in the post-op hemoglobin, rate of infection, or there was no increase in the hospital stay. Cesarean myomectomy, if you go through the review of literature, traditional teaching for most of us who have done our post-graduation about more than 2.5 decades ago has been to avoid myomectomy during cesarean section. However, in the last 2 decades, several reports have been published, and they have published about the safety of the procedure. Used safely for pedunculated fibroids for a very long time. However, obstetricians were forced to do myomectomies, causing difficulties to access of uterine cavity, especially if they were in the lower segment. Now it is expanded to all myomas if myomectomy is indicated otherwise also. So earlier, only for pedunculated, then gradually shifted to those cases where myoma was interfering access to the entry to the uterine cavity. Now, with more confidence and skill, people have started doing myomectomy during cesarean because the abdomen is open, the uterus is in your hand, and if you are safe and you are brave, you'll be able to do myomectomy at that setting and avoiding a separate surgery for that patient. In safe hands, it does not cause increased risk of excessive hemorrhage. It does not increase the chance of incidence of hysterectomy, does not increase infections, and does not increase hospital stay. So this is now there to stay. Many of us who are going to start doing myomectomies during cesarean should start similarly, like the literature says, with pedunculated fibroids, with those fibroids where it is to ease your access inside the uterine cavity to deliver the child. And then maybe as one develops confidence, that's how I also did. And as you develop confidence, you can then start moving towards others. What happens in this is, in these uteri, the oxytocics can work really well. And you can really use oxytocics, which can make the uterine wall contract after you've done the myomectomy. And that contractility of the myometrial fiber, which is high at this time, decreases the blood loss. So therefore, if you can get the plane, get the myoma out, ask your anesthesia colleague to give an oxytocic drug, and that will make the uterus shrink and contract and will not let that bleeding happen as one is so worried about. However, initially when one starts, one must have backup of blood. One should have enough blood products. One should also have a consent for hysterectomy, although it is rare. But for any myomectomy, when we do, whether it's a gynecological myomectomy or myomectomy in pregnancy, one would have to take a consent of hysterectomy. However, if one is careful, one may not have to resort to that. Now, the topic is only about pregnancy with myomas. However, one also needs to touch a little bit on preconceptional care. Those patients who have myomas prior to pregnancy. Number one, what can happen to them? Some of them have associated subfertility. Possible mechanisms are possibly distortion of fallopian tube affecting the entry of sperms into the uterine cavity. the distortive effect of endometrium inhibiting implantation and association with hyperestrogenic environment. Possibly these are the patients who have anovulatory cycles and therefore they do not conceive. 2/3 of them who do not have any other identifiable cause conceive following myomectomy. But if you have a patient with fibroid, myomectomy is recommended definitely for submucous fibroids. It may benefit in intramural fibroids which are distorting cavity. However, there is no proven benefit in subserosal fibroids. So subserosal pedunculated fibroids, please do not advise myomectomy for such patients if you are treating patients of infertility. The next topic we have to talk about VBAM, that is vaginal delivery after myomectomy. The risk of rupture uterus following a myomectomy is slightly higher compared to a lower segment cesarean section, nearly double. The risk for rupture uterus is less than 1% after a lower segment cesarean, is 2 to 9% after a classical cesarean. It is 1.7% after a myomectomy. The risk is higher after lap myomectomy, possibly related to excessive use of cautery and inferior approximation of walls when you are doing a layer-wise closure of the myoma cavity from which the myoma has been plucked. It's 0.5% extra. So if you say 1.7% is the risk of rupture uterus for myomectomy, so add another 0.5%, make it 2.2%. The total size of the defect rather than any breach within the endometrial cavity increases the risk of uterine rupture. So therefore, earlier we used to think that in case we are doing myomectomy, we should be careful in not breaching the endometrial cavity. Endometrial cavity, truly speaking, does not provide strength to the uterine wall. It is actually how much of the myometrial damage has happened, how much breach or how much defect is there in the myometrium. And that is what increases the risk of uterine rupture. And this is proven by the data that it is rare after hysteroscopic myomectomy. Hysteroscopy myomectomy, you will always go through the endometrium. And if you do a hysteroscopic myomectomy, it's unlikely that you will have a rupture uterus, except in case the myomectomy has led to perforation of uterus. So in only those patients where myomectomy has led to perforation of uterus, we may have a possibility of rupture uterus. Therefore, it is recommended that one should have individual approach. One should take a proper history of what myomectomy has been done, how much time has elapsed after the previous surgery, and what are the other factors like the size of the child, the pelvis, and other features which will give us an approach of taking a delivery after myomectomy, or whether you do not want to have a delivery.
Sorry to interrupt, sir,
of course,
but
I am one of the old school
up.
types, so I am still not very confident of giving a vaginal trial. So
Hello?
I do not do any TOLAM. I only give an elective cesarean. However, the literature today says that one should use an abdominal myomectomy, giving the same risk as a lower segment cesarean section. So if you are doing a VBAC trial or a TOLAC, then you can give a VBAM trial or a TOLAM.
I'm sorry to interrupt, sir, but I request you to please sum up as it is time up.
This is my probably last slide. The complications are very rare. However, pyomyoma is a life-threatening complication resulting from infarction and infection of fibroid, usually found in submucous kind of fibroids, and in case they are close to the placental site. It will lead to abdominal pain, high fever, and septicemia. And the common organisms such as Clostridium are the one which cause it. Diagnosis is very, very difficult because imaging findings tend to be non-specific. There is very little change in the ecotexture of the myoma which has infection. However, sometimes you might find some liquefactive changes. Definitive diagnosis and treatment are therefore achieved by laparotomy with either myomectomy or hysterectomy. So this is all I have to say. Thank you, POGS, for inviting me here. And in case there are any questions, I would be glad to answer.
Dr. Ajay, it was an excellent delivery. You told
Madam, you
about
have to
the
unmute your...
It was an excellent delivery. You had told about the recent development of cesarean myomectomy.
Madam, your microphone is mute.
Mute? No.
No, sir. No, sir. We can hear her.
Hello. Can you hear me now?
Ma'am, we can hear you, I guess.
1 minute. I just
Okay,
put on
well,
the mic.
ma'am, thank you so
Yeah.
much.
No,
But moving on.
see, I would like to
Jinal, wait,
request.
Madhuri madam wants to conclude. She is audible. Let her speak. Just
Yeah,
give her a
yeah,
minute.
So much, so we cannot. We have to give the clear message to the viewer. You are interrupting at each and every moment. I would like to request event management. So what we want to give message, we can't give the message. Dr. Rajay, can you hear me?
Yes, madam, we can hear you.
I think it was a very good lecture on especially cesarean myomectomy, and it is a good
Yes, yes,
message
madam.
to everybody that we should not get scared. We should expertise under somebody, and then we should start doing a cesarean myomectomy. Thank you. Over to you, Vaishali.
Yeah, thank you, madam. Yeah, can the event people please start my video because they have put it off? Yeah. This was a wonderful talk by Srivastav sir, and thank you for giving such practical tips. I'm sure it is going to help us all. And this is indeed a privilege to be here at FOGSI POGS International Conference Just Tumors. And heartiest congratulations to Dr. Harshit Parasnis, Dr. Ashwini Kare, Dr. Parag Beniwale, and entire team POGS, because this is a record-breaking virtual conference, the one of its kind. And I am equally privileged that my committee, Perinatology Committee, FOGSI, has been associated with this session. And it is a privilege, Madhuri ma'am, to be here with you on this session. So I would like to invite our next speaker. The talk is on ovarian tumors with pregnancy, Dr. Anjana Chauhan. And she is from Ahmedabad. She is consultant gynec cancer surgeon from Global Hospital Ahmedabad. Welcome, ma'am.
Oh, I just can't start my video. Hello.
Nitesh, can you please help
Madam.
her out?
Yes.
Madam,
Yes.
please share your presentation.
I shared my presentation. Now you can see.
Yeah. Yes, madam, I can see. Make it full screen.
I made it full screen.
Yeah.
Okay. Now my video is been stopped by
Madam, on the left side, on the start video, you just click on that button. Your video will be visible.
No, it is not visible. I'm trying. It says the host has stopped your video.
No, ma'am.
We can see your slideshow.
I go with the slide, but my video is
One second, ma'am. I'll just change.
now it
Yeah,
is-
yeah, yeah. Now is on. Yeah.
And go to my next slide. I just want to thank the organizer, Dr. Harshad, to give me an opportunity to speak in this platform. It's been a very wonderful conference since yesterday, and it is a very difficult task he has given me ovarian tumors with pregnancy because there are no clear-cut guidelines. And whatever today I'm speaking will be, I'll be speaking regarding my experience and what patients I have seen in my practice. Increase in incidence of adnexal mass diagnosed during pregnancy has occurred because of widespread of antenatal sonography during pregnancy. Majority of this mass resolved by second trimester. Most of this adnexal mass will resolve without intervention, reflecting the physiological nature of these masses. Ovarian tumor diagnosed in pregnancy is a great challenge for the obstetrician and gynecologists. Majority of ovarian neoplasia occur during pregnancy are benign. Incident reported is less than 10%. Only 2 to 6% of total tumors seen in the pregnancy with ovarian mass are malignant. Ideally, the ovarian mass diagnosed during first trimester of pregnancy should be followed up to 16 to 20 weeks of pregnancy unless they become symptomatic or pathological. Presence of adnexal mass beyond 20 weeks should be considered pathological and has to be evaluated. This event results in emergent surgical intervention and has adverse effect both on mother and fetus. Adnexal masses associated with pregnancy are a risk for complications such as torsion, hemorrhage, rupture, pain, and preterm labor. Now, the common masses discovered during pregnancy are benign masses, which are corpus luteum, mature cystic teratoma dermoids, serous or mucinous cystadenomas, endometriomas, paraovarian cyst and leiomyomas, pedunculated, which may present as adnexal masses. Borderline tumor, the common are serous and mucinous. Malignant tumors, the commonest are serous type and mucinous carcinomas. Germ cell, the dysgerminoma are the most common germ cell tumors during pregnancy detected with ovarian mass. And sex-cord stromal tumors, I have not yet seen any patient with sex-cord stromal tumor though it is mentioned in the literature. The commonest tumors seen in pregnancy, benign and leukemia, pregnancy and dermoid cyst. Malignant, if you see that dysgerminoma is the most common, second are borderline tumors, and third is mucinous cyst adenocarcinoma. In benign pathology, the persistent corpus luteum follicular cyst is seen in 17%, dermoids in 37% of the masses, cyst adenoma 24%, and other like paraovarian cysts, endometriomas, and are seen in 5%. Now, leukemia, coming to leukemia of pregnancy, it is the most common thing which is seen, and it is a benign process unique of pregnancy caused by hyperstimulation of human chorionic gonadotrophins, resulting in replacement of ovarian parenchyma. It is a self-limiting condition, and nothing has to be done. The mass resolves spontaneously with completion of pregnancy. Most of these patients either go for spontaneous abortion or preterm labor. You need not have to do anything. Now I'm just sharing one of my experience. A 25 years patient came with 8 weeks pregnancy. She had a spontaneous abortion, but on sonography, she had a huge ovarian masses. The CA125 was 200, 1200. So she was referred to me, an oncologist, saying that this is a malignancy. But when I took the history in the details, first she did not give me the history. She was coming from a very remote village of Rajasthan. Then she told me that the physician there had given her some tablets in form of which she took in a monthly. Then she showed me the prescription. So looking into the history, I got her MRCT, and you see there were huge ovarian masses. And we discussed with the radiologist, and it came, and we put in the diagnosis as OHSS. I convinced that patient, she came with for surgery, but I convinced her, and after follow-up after 6 weeks, the mass also resolved and CA125 was normal. So history taking and clinical examination, all these are very important in patients with pregnancy and ovarian tumor. History is particularly important because, as I said, it will help you to diagnose. Moreover, a patient, if she complains of sudden increase in abdomen or sudden distension, then it can be a germ cell tumor. If there is a pain seen in the first or second trimester, then it can be a torsion. So history is a way where we can diagnose. Clinical examination becomes a little bit difficult in the first trimester because it's ovarian tumors and pregnancy in the pelvis. But in second trimester, it is easy to diagnose because uterus is occupying the pelvis. So the tumors are mostly in the upper abdomen. Tumor marker doesn't help because all are raised in the pregnancy. Main thing which help us and guide us in management is ultrasonography. Yesterday there was a wonderful lecture of iota adnexal model where we can detect ovarian masses and assess the risk of malignancy. Once this becomes a standard of care, then it will be very easy for obstetrician gynecologists to identify which are the patients to be referred and which can be treated. The morphological criteria is the only criteria on sonography which will be helping to identify benign and malignant tumors. Whenever you are doing any surgery, you need X-ray, then it can be done with sealing. MRI pelvis is a method where we can use an additive when we are in doubtful cases. And in whatever you do in ovarian tumors with pregnancy, always do a fetal scan because we don't want to land up in having abnormal fetus. It is a mandatory. Whatever you do, intervention or not intervention, but fetal scan is mandatory. Management of adnexal mass during pregnancy can be challenging for patient and the clinician. In modern era of medicine, surgery is safe. Even general anesthesia is safe. Delaying pregnancy till 26 second trimester reduces the risk of malformation as organogenesis is complete. Timing intervention is very important. Surgical intervention depends upon the nature of the mass. Early intervention decreases the risk of first trimester complications. But if there is a malignancy, it avoids delay in adjuvant therapy. Delay in intervention also prevents unnecessary surgery and allows resolution of functional scenes. Thereby, majority of lesions which seen in second trimester are either benign or malignant. And whatever you do, you have to take a consent of abortion or preterm labor and the consequences of the further pregnancy. Expectant management is recommended for women with asymptomatic non-suspicious lesions. Surgical intervention during pregnancy is indicated for large or symptomatic tumors, or if there is a suspicion of malignancy. In doubtful case, please refer to a gynaecologist, because I will be discussing later what are the reasons. Mass than less than 6 centimeters, benign looking, doesn't require, if doesn't increase, can be observed, does not require laparotomy during pregnancy. Mass more than 6 centimeters, the surgery can be withheld till second trimester. If there is any complication, then she can go for emergency surgery. If tumor discovered in third trimester seems to be benign, surgery can be delayed till postpartum. There are certain dilemmas in treatment. Delay in surgery intervention may result in complications. During pregnancy, the risk of torsion of adnexal mass is at 3 to 15%. Hence, it is we have to monitor these patients very often, and it may and if you do a early surgery, then you may lose the corpus luteum and thus will affect the pregnancy. Or if you do a late surgery, so these all the patients, you have to balance yourself between the patient and because there are no fixed guidelines, you have to decide by your own, seeing the patients, and if necessary, you can take the help of your friends or colleague. Now, coming to cancer in pregnancy, it's a rare occurrence. Estimate incidence is 1%. These are the all common cancers seen during the pregnancy. Ovarian cancer coming as a fourth. Malignant ovarian tumors seen in the pregnancy, less than 6% are malignant. Ovarian cancer, 1 in 15,000 or 1 in 32,000 pregnancies reported in the literature. The commonest is germ cell tumor, and in germ cell tumor, the dysgerminoma is most common, accounting for 20% of tumors in ovarian cancers in pregnancy. Tumor markers are not at much help because most of them all rises in the pregnancy. Tumor markers are used primarily to monitor the disease status rather than the treatment. Management of malignant tumors in pregnancy, the surgical approach should be comprehensive, complete staging laparotomy as for non-pregnant women. It may lead to pregnancy loss. The extent of surgery depends upon the intraoperative diagnosis versus the malignant diagnosis of benign or malignant tumor. Depending upon the malignancy, gravid uterus should be removed with the consent of the patient, and the patient has to be always explain the risk of pregnancy loss. More aggressive surgery is indicated if there is ovarian malignancy confirmed. Conservative surgery is appropriate for borderline and germ cell tumors. In germ cell tumors, you have to do staging, but opposite ovary and gravid uterus can be preserved. In borderline tumors, cystectomy, adnexectomy, and limited is enough. Point to remember, hence adequate knowledge whenever you're dealing with ovarian cancers in pregnancy, you have to know the tumor characteristic. So ultrasonographic appearance and gestational age are the key factors for the most effective management, only not for this pregnancy, but also the future pregnancy. You have to remember you're dealing with two lives whenever you're dealing with ovarian masses and pregnancy. Now, staging laparotomy, most of the gynecologists only believe that it is total abdomen hysterectomy, oophorectomy, and omentectomy. We have been hearing in this conferences there are lots of procedures to be done, and this all has to be done even in pregnancy also. You cannot avoid them. So I've just divided the 3 trimester management. And first trimester, if the malignancy is detected, irrespective of the pregnancy, you have to explain to the patient that your life is more important and you have to do a complete staging laparotomy, except in germ cell tumors where you have to do a staging laparotomy. But you have to again explain that during first trimester, because she may need chemotherapy, that pregnancy has to be terminated, but uterus and ovaries can be preserved for a future pregnancy. In borderline tumor, cystectomy can be done, staging is necessary, but pregnancy can be continued. In second trimester, same thing, a patient has to explain if there's a malignancy detected, epithelial tumors malignancy, she has to go for comprehensive staging with removal of gravid uterus. In germ cell tumors and borderline tumors, The uterus can be, gravid uterus can be preserved, pregnancy can be continued in this case, and chemotherapy can be given. Third trimester, nearing term, you give corticosteroids, do elective cesarean with completion of surgery with staging laparotomy and remove the uterus, and can be performed. In germ cell tumors, yet you can preserve the opposite ovary. It is not recommended, but if patient is keen for pregnancy, you can preserve the uterus. So it's a teamwork. It is not a one-man domain. You have to have a team of obstetrician, gynec oncologist, pediatrician, medical oncologist, radiologist, pathologist, all to work together for management of such cases. Chemotherapy is safe. Cisplatin is safe in first and second trimester. Second trimester onwards, you can give DEP or cisplatin or paclitaxel. In advanced malignancy, you have to balance the risk. It is a matter of risk, and fetus is not given much outweigh the fetal consequences. The extent of surgery, tumor bulking depends upon the stage of the disease and fetal viability. If malignancy is detected during first and second trimester, then complete staging laparotomy and removal of the gravid uterus. There are certain areas where what to discuss. There are no guidelines available whether to do a laparotomy or laparoscopy. I personally don't believe much in laparoscopy, but in first trimester, if there is a benign tumor, if there is a torsion, if the tumor is less than 10 centimeter, a laparoscopy can be advised. But second trimester, laparotomy is advised because it is an abdominal organ. In malignancy or doubtful cases, please no laparoscopy. No means no, it has to be a laparotomy. There are certain areas like point to ponder whether to do or not to do. Frozen section. In doubtful cases, because doing a frozen section, you send the specimen and the report comes in, it takes 20-45 minutes that to give lots of anesthesia. It's going to have affect the fetus to do a frozen section or not to frozen section. These questions, they don't have yes or they don't have no. You have to individualize and you have to decide upon the patient and upon the case which you encounter. Same way USG guided biopsy, there is no particular yes or there is no particular no. In doubtful cases, you want to know the pathology, it can be done. Now, once you have operated a patient and our final reports come, you think it is a benign, but our final report has come malignant, then what? If it is detected in first trimester of pregnancy, same, you have to do a completion surgery with removal of the uterus. Detected in second or third trimester, you can counsel the patient, give new agent chemotherapy, and then go for cesarean section and complete surgery. Now I'll be discussing 2 more cases and then I will end my lecture. A 29-year patient came with 6-month pregnancy. She had a multicystic mass about 10 centimeter, which was above the uterus. Tumor markers was raised. An MRI was done which suggested a mucinous tumor. She planned for laparotomy with frozen section. The report was borderline mucinous tumor. Hence, the abdomen was closed and patient was observed. But her final report, to her surprising, came mucinous cyst adenocarcinoma. He advised her completion surgery, but patient was very reluctant. She wanted pregnancy, hence we're doing all the counseling. She was given 3 courses of chemotherapy, carboplatin, Taxol, with intrauterine pregnancy. At 9 months, he underwent cesarean section with completion of surgery. Mother and child both are fine. And further 3 courses of chemotherapy was given postpartum and breastfeeding was avoided. Now, this was our case we managed. This is our third case. A 24-year female came in with 5 months pregnancy. Tumor markers was raised. She had a biopsy outside which suggested endodermal sinus tumor of ovary. The uterus, the USG showed 22 weeks live pregnancy with a solid complex mass. We took our consent regarding the risk of pregnancy, and because she was a germ cell tumor, we planned for staging laparotomy with fertility preservation. Now, this is the patient. You can see this was the whole tumor in the upper abdomen, and this is the gravid uterus. We removed the tumor, and this is the opposite ovary. We did the total staging laparotomy. There was no residual disease. The final histopathology was a yolk sac tumor, stage 1C. The capsule was infiltrated. We gave her, because it's a yolk cake and it's the fastest growing tumor, we gave her BEP regime, intrauterine with a pregnancy. Patient took 3 courses and she went in spontaneous labor at 8 months, and cesarean was done and she delivered a female child. Now this was treated in 2008. It's nearly 12 years now. Now this is the girl. She's recently sent me the photo. She's 12 years. She received intrauterine chemotherapy and she's fine. After 5 years, she had a second pregnancy. Both her child were fine. Now she's 100%, we can say more than 90% cure. Now the second case, mismanaged. This is the case just I want to highlight. She had 2 months pregnancy. She had 10 centimeter ovarian mass. Tumor markers, we advise the tumor markers and surgery. Outside sonography showed dermoid. But she ran away. She went to some doctor and she got laparoscopic removal with morcellation, 10 centimeter mass. And it was mature cystic teratoma. After 4 months, she had 7 months pregnancy, huge distance and ascites, mass, breathless, discomfort. She came on trolley. And when we examined her, we sent the tumor markers as usual, they were raised. We got her slide reviews, it was immature teratoma. MRI showed massive disease in the abdomen, gross ascites, ovarian presley. She had 7 months pregnancy. The fetus was normal. She had even effusion. Now the diagnosis was mixed germ cell tumor. It was inoperable, and hence we gave her 2 courses of chemotherapy. After chemotherapy at 9 months, underwent massive surgery that we did a cesarean section, removal of the tumor. Tumor was adherent to the sigmoid. We had a surgeon. We had to do omentectomy. So this was a massive surgery.
Ma'am, I'm so sorry to interrupt, but I
Yes,
have to request you to please sum up.
Yes, this is my last case. I'm just winding up. This was the whole tumor you can see. This was the whole tumor. We did a very marathon surgery, and it was immature teratoma with mature growing teratoma syndrome. Next. Slide is not moving. My slide is not moving. Okay. So I want to say 2 cases. The first case came directly properly managed. She was stage 1. Now what happened to the next case? She underwent laparoscopy, totally mismanaged. As stage 1 became stage 3. Her survival goes down. I always believe in oncology. Always remember, in malignancy, the first surgery is the best chance a patient has for a cure. And please don't mess up this surgery. Whenever you see a malignancy, even in pregnant or non-pregnant women, send to an oncologist and do a proper surgery and think of the patient. We have to change this attitude. Ovarian tumor diagnosis is always a challenge, difficult to interpret, and very important to manage correctly. My take-home message is proper evaluation of ovarian tumor pregnancy is required. Imaging is a backbone. It will guide the nature of tumor. Majority of the mass is resolved by second trimester. Ideal intervention is second asymptomatic and non-suspicious masses, but for malignant tumor suspicious case, you have to revert to an oncologist. Surgical intervention is required if there is a suspicious mass or there is complication. Informed consent regarding pregnancy should be taken, and it has to be always a multidisciplinary approach. Thank you very much for patient hearing.
Was, madam, a very fantastic and an elaborate lecture. Absolutely wonderful, clear-cut message. Gynecologist to practice in to see the tumor dilemma in these cases.
Swati, you can introduce the third speaker.
Okay, ma'am. Thank you. N. Singh from Professor and Head, NSCB, Medical College, Jabalpur. Over to you, ma'am.
Hello, this is not opening. Event manager, can you help?
Open your slide and then share.
Okay.
Yes, madam. Make it full screen.
Is it okay?
Yeah, it is okay.
Kavita, you are not seen.
Please.
Can you make video on?
Madam, it is not, it is showing that I have been
muted by
switched off.
Okay.
Somebody,
No,
maybe from
ma'am.
the event manager.
No,
Ma'am, I
ma'am.
have sent you a request to accept
Everybody's.
the video. Yes,
Now,
ma'am.
now we can see. Now we can see you. Yes.
No, yeah. Just make it full screen, ma'am.
Yeah, yeah. Just a minute. Huh? So, Swati ma'am and Vaishali ji on screen, and me, because anyways, keeping time in mind, I'll just go to my presentation. So today I'm going to so greetings from Netaji Subhash Chandra Medical College and the premises during various conferences would recollect this picture. So greetings from Netaji Subhash Chandra Bose Medical College. I'm going to today I've been asked to speak on cervical cancer and pregnancy. And as far as the cervical cancer in pregnancy is concerned, as you have seen just in Dr. Anjana's slide, that the four common cancers during pregnancy is more likely to. So this statement relevance to the topic, that why it has been chosen and to be kept in this conference, that pregnant women are 3 times more likely to. There is need to diagnose. Early realization of coital activity and the maternal age, childbearing age has been we know has been advanced. So now there is a possibility that we get such patients. Improved awareness helps early detection. So that's why this the entire session is very important, whether it is an ovarian, whether it is an other tumors with pregnancy. They have our day-to-day practice. Improved maternal and fetal survival is definitely and helps us in preventing complications. Most patients, as discussed, are diagnosed at an early stage of disease, hence better prognosis. So cervical cancer is one of the with an estimate incidence of 10,000 birth. Half of these cases are diagnosed prenatally, and so not only the pregnancy period, but the pre-pregnancy period plus postnatally also, we have to follow our patients carefully. And this the figure says, the statistics says 1 to 3% of cervical cancer cases are diagnosed during pregnancy and postpartum period. Pregnant women are 3 times more likely, as we are reading it again and again. So staging at the time of diagnosis of cervical cancer in pregnant and non-pregnant women, uh, uh, if detected early, there lies the relevance of routine prenatal screening. Because here you can see in stage 1, the 70 to 80% of the patients, they are to non-pregnant, that is 42%, stage 2 11 to 20% and 35%, and stage 3 and 4 again more in the non-pregnant side. So after stage 2 and beyond, the chances of getting higher stage disease as compared to stage 1, which is with pregnancy. And when we are seeing our patients in OPDs, and when we are talking to them, and when we are counseling, the effect of pregnancy on CA cervix may, as we know that it remains unaffected, but there may occur rapid spread following vaginal delivery and induced abortion. So this has to be kept in mind, that even after delivery or after induced abortion, so sometimes the patient, they come for termination of pregnancy, and then we, but that is an opportunity to screen them and to keep this in mind. Effect of cancer on pregnancy, there is increased chances of abortion, preterm and secondary cervical dystocia, traumatic PPH and leukemia, pyometra, sepsis. So the conditions, all these conditions will depend on the case scenario and which the patient we are getting. Cancer cervix in pregnancy definitely gives us a problem. So the ability to detect early neoplasia may be limited to normal pregnancy associated cervical changes, that is increased vascularity, stromal edema, and ripening and softening. So normal decidual reaction of cervix may resemble cervix with an ectropy, or sometimes it resembles like carcinoma. Extension to the parametrium may not be well defined, and as such cases are often understaged. So these are the things we have to keep in mind. So PS examination, usually nowadays the patients are apprehensive. We are too savvy with an USG probes nowadays, but the that should not be missed. So gross cervical lesion may be observed due care for the pregnancy. The size of the cervix increases by the 3 times to be kept in mind, and transformation zone becomes exuberant and due to a version of squamocolumnar junction. FIGO staging of CS cervix, I won't go into the detail of each stage, but we all know that microinvasive stages are has to be kept in mind, and screening is to be done. So in PS examination, if you are getting a disease 1B and beyond, you will see, but as far as the microinvasive is concerned, we have to screen them. As far as the clinical presentation is concerned, symptoms and signs of cervical carcinoma in pregnancy are dependent on stage of disease. The patient with stage 1A and 50% of those of stage 1B are found to be asymptomatic, and had their disease detected by routine cancer screening. So, and symptomatic stage 1B disease presented with abnormal vaginal bleeding or discharge. So many a times we confuse these patients with threatened abortion or spotting of during a first trimester. So these are the patients when we are just sending them home with a prescription of threatened abortion. We should not miss putting in speculum and looking at the cervix and doing, if possible, doing a screening, which is recommended. So advanced disease patients present with pelvic, and the advanced disease, if the patient is to stage 2 and beyond, then these patients can present to you with pelvic pain and sciatica, leg pain. And we always confuse their pain story with that this is due to gravid uterus. This pain, when the patient is constantly telling you about this pain and hematuria, or it is not always a UTI, the chronic anemia or shortness of breath, because the nausea, vomiting, breathlessness, weakness, anemia, we take it as an with the pregnancy and other conditions. So here cancer is best diagnosed 5 to 7%, which is almost close to non-pregnant population. I won't go to the detail of invasive because the topic is cancer cervix in pregnancy, but this has to be again kept in mind as in practitioners that we have to screen our patients, and if you get in cytological abnormality, then you have to reevaluate even after delivery. Per speculum examination, as I said, it is mandatory doing in VIA, VIAM, and colposcopic evaluation. And the experienced colposcopists can pick it up. Not cone biopsy, but the coin biopsy in case of suspicious lesions. Coin means it is a flat coin-like biopsy, so that you're not disturbing the endocervical canal. So if you get a lesion on the ectocervix and on the, then you can go ahead with a coin biopsy. Colposcopy and directed biopsy is most sensitive diagnostic tool. Sensitivity is 83% and specificity is 95%. Complication of biopsy like bleeding, preterm labor, chorionic amenorrhesis has been reported, but in very few cases. Conization for diagnosis is restricted for cases in which cytological test reveals high-grade lesion and colposcopy is inadequate. So in those cases, we can go for cone, but again, it has to be done by a gynecologist or person who is trained in this. As the previous speaker is also said the same thing, and I do also agree, because the first chance is the best chance, and it should be done by an expertise and due respect to the patient's prognosis. So endocervical curettage is contraindicated because of the pregnancy. A chest X-ray with an abdominal shield is warranted for evaluation for pulmonary metastatic disease. USG and MRI is used to evaluate other organs. Endoscopy, if needed, is safe in pregnancy. Cystoscopy, actually they are very rarely needed, but still if it is needed, they are safe. As far as the CT scan is concerned, dose allowed to fetus is 10 to 15 centigrade, and the CT is hardly more than 1 centigrade, so it can be done if needed. So to assess USG and MRI has gotten very good value, diagnostic value to assess the tumor site, adjacent organs, lymph node metastasis, method of choice for staging in pregnancy. So they are done, and we should continue doing them. As far as the management of pregnancy with CS cervix is concerned, we have to discuss with the patient and the partner. So multidisciplinary approach. Why? Because we have to discuss. Here is there we are living in a medical legal era, and we have to discuss everything. Where is the problem? What is needed? What intervention? And what are the complications? So we have to assess the risk and the benefit of termination of pregnancy or continuation of pregnancy. So whatever the couple is accepting is to be documented, and individualized treatment should be based on stage and the gestational. So two important thing in the management is stage of the disease and the gestational age of the disease. So stage 1A1, conization best between 12 to 20 weeks of gestation. Coin biopsy instead of cone biopsy should be for the early lesions, and concurrent prophylactic cerclage if needed. If you get in smaller size of the cervical length and if you feel that it is going to benefit, then you can go ahead. 1A2B1, conization or simple trachelectomy. Node negative disease, simple trachelectomy is beneficial, and there is no added risk. Node positive disease, trachelectomy with laparoscopic pelvic lymphadenectomy if the pregnancy is less than 20 weeks. Obstetric outcome is poor with radical trachelectomy. And stage 1A, 1B1 and locally advanced disease, we go ahead with a neoadjuvant chemo with or without pelvic lymphadenectomy. Safest in the second trimester, but can cause slight increase in preterm labor. So if needed, you can go ahead with a neoadjuvant, but then this is to be explained to the patient. Stage 1A1 and B1 in women with advanced pregnancy beyond 22 to 25 weeks of gestation. So if the story is before 20 weeks, it's fine. But if it is after that, postpone definite treatment till the fetal maturity is attained. NSCT can also be given for those with advanced pregnancy and locally advanced cancers. Definitive treatment is cesarean delivery, which is followed by either radical surgery or definitive chemoradiotherapy. So this has to be when pregnancy preservation is not desired, then the termination of pregnancy followed by treatment as in non-pregnant state is recommended. If less than 12 weeks, then spontaneous abortion occurs after pelvic irradiation. And in second trimester, hysterectomy followed by definitive chemoradiation is preferred. We got a similar patient with an 18 weeks pregnancy with an demise, and then when we were thinking that it should come out, there was a huge growth in the cervix, so we took this patient for neoadjuvant, and then after that there was a spontaneous expulsion, and then the definitive treatment of chemoradiation was done. So if the patient is in first trimester, treatment can be delayed till postpartum period if the patient is in pre-invasive stage. If the patient is in early stage disease, then wait until 12 weeks and then go ahead with a simple trachelectomy, and as discussed earlier. Advanced stage, termination pregnancy is advised. If more than 12 weeks, spontaneous abortion occurs with, if less than 12 weeks, the spontaneous occurs with pelvic irradiation in second trimester. Hysterectomy followed by definitive chemoradiation is preferred. Similarly, in second trimester, so either trimester wise or stage wise. So if you are taking trimester wise pre-invasive, treatment can be delayed till postpartum, no problem. 1A to B1 disease, the laparoscopic lymphadenectomy, as discussed, node positive. If the disease is node positive, termination of pregnancy advised. If the disease is node negative, then you discuss with the patient, and if ready, go ahead with a neoadjuvant chemotherapy and then treatment. Neoadjuvant chemotherapy, if the advanced disease followed by surgery, chemotherapy should be avoided in first trimester due to fetal malformation. Termination of pregnancy is advised if the disease is advanced. So in third
Sorry to
trimester again,
interrupt, ma'am. Can I request you to
yeah, I'll
please
finish.
sum up?
Yeah,
Yes, ma'am.
I'll
Yes,
finish.
ma'am.
Okay, so cervical cancer and pregnancy, immediate definitive treatment regardless of gestational age is in general appropriate in following settings: that documented lymph node metastasis, progression of disease during pregnancy, or patient's choice to terminate. So these are the definitive indications. Maternal prognosis and fetal prognosis, this has to be explained to the patient. And with this, the things for the practitioners and actually the motive of keeping this is that if something is there in the mind, we'll think of it. If it is, we are just missing the cervical cancers in pregnancy, then we will be missing. Micro-invasive can be monitored and managed postpartum, so need not to worry. And if invasive, less than 20, immediate treatment and definite, and immediate treatment and definitive treatment, and immediate termination and definitive treatment. More than 20 weeks may wait for fetal lung maturity and followed by delivery and definitive treatment. So with this, I thank you all that even in this is our public setting, we are in the hospital. So thank you, Madam Madhuri, Madam. I couldn't see your claps because working in a...
Kavita, it was an excellent delivery, very clear-cut message to all the delegates that which stage, what to do and what not to do. All three speakers were excellent, and because of the paucity of time, we hand over to the event management the mic,
no
and they
problem.
can go with the second
Yeah.
session. Thank
Okay,
you,
thank you,
everybody. Thank you, Harshad. Thank you,
thank you so much.
Srini,
Excellent
all of you.
talk. Yeah.
Thank you, Madhuri.
Thank you,
Thank you,
everyone.
Madhuri.
Thank you, everyone.
Thank you, Vaishali. And thank you,
Thank you.
Swati,
Thank you.
for chairing this
Swati,
session.
you must say thank you to Swati.
Yes, that's why I keep on
Thank you,
saying.
everyone.
Yeah.
Thank you,
Thank
Swati.
And kudos to Harshad for moving from one screen to the other.
Yeah.
Every 5 minutes. Yes.
It's like going
Excellent
from
talks.
one hall to another, isn't it?
Yeah.
Harshad is
Yes.
Superman. He has pulled off a conference of its kind.
Yeah.
Congratulations.
Yeah, thank you.
Yeah, really.
Harshad, be there. I'll take one. Harshad, be there. I'll
Ah.
take one photo.
You can stop share
I
screen.
think-
So
Yeah. Done. Thank you, everybody. Yeah.
Everyone, can I request you to please
you.
switch on your cameras? Everyone. Yes, can I request everyone to please switch on their cameras? I might take a picture and put it in the group. Okay, ready, everyone?
Yes.
Let's cheers. 3, 2, 1, cheers. That's perfect. Thank you.
Thank you.
Thank you.
Okay. Well, moving on to the next session, and we have the next session is for 45 minutes. That is panel discussion. I would like to invite our moderators, Dr. Bhagyalakshmi Nayak from Cuttack and Dr. Bindya Gupta from Delhi.
So thank you very much, organizers, and thank you, Dr. Harshad, for all the hard work you have been doing for so many months and months now. I think it may not be a year. Of course, he has started working that since more than a year now, of course. So thank you so much. So Bindya, will you be sharing the screen? So I have with me Dr. Bindya Gupta, who is a senior gynecologist from UCMS and with a keen interest for gynaecology. And please share your screen, and we have a gamut of experts here. So we will be discussing a few cases which will be of help in our day-to-day practice. So we have with us Dr. Ramesh Bhosale from Pune, Dr. Sailesh Sinde from Pune again. He is a radiation oncologist. Dr. Uma Vankade from Pune, Dr. Geeta Balsarkar, who is the assistant editor of our Jogi and senior gynecologist from Mumbai. Dr. Rohit Ranade is a senior gynecologist and of course, he's a gynae oncologist from Narayana Cancer Hospital at Bangalore. and Dr. G.S. Sekhawat, again a senior gynecologist from Mumbai, Dr. Ravi Vategaonkar from Pune, and Dr. Arpita A from Jipmar. So over to you, Bindya, for the first case.
Okay, good evening, everyone. And thank you, the organizing team, Dr. Harshad and Dr. Bhagyalakshmi, for giving me this opportunity. And this has been a stupendous response to the conference, and it's going really, really well, and enjoyed all the sessions today. So I'll proceed with the panel discussion. So we have 9 cases in our this thing today panel, and we have an expert team. So without any further delay, I will just start with the first case. So this first case is 28 years old. She's para 1, and she presented with complaints of intermenstrual bleeding and postcoital bleeding. And there were no allergies, no medical problems. And however, she had no previous smears also, and she was a chronic smoker. And because of the intermenstrual bleeding, she underwent a TBS in which it was normal except for bilateral polycystic ovaries. And smear showed a high-grade dyskaryosis with positive HPV, and endometrial biopsy was normal. So subjecting her, took her to colposcopy, and on colposcopy, there was a high-grade lesion with a very high sweet score, dense astrocyte area with an irregular surface and suggestive of high-grade disease. And finally, we proceeded for LETs, and a good depth LETs was taken, and it revealed CIN3 in all the blocks and all the margins. HPV-associated changes were present. However, there was a single superficial focus of invasive squamous cell cancer, which is around 1 mm, and it was too small that the grade could not be assessed. So I would now like to request Dr. Arpita to just suggest what will be her further plan for the case. Dr. Arpita?
Yeah, Dr. Arpita was here just now. I had seen her. Dr. Arpita?
If Dr. Arpita is not there, can Dr. Geeta, Dr. Geeta can take the case? Whoever, I mean, anybody can answer in this?
Rohit, please take it. Rohit, please take the question.
Madam, because the margins are all positive, there is CIN3 in all the margins.
Yeah, yes,
So
ma'am.
we will go with cone biopsy.
Okay, yes, ma'am.
Yeah, can I make a comment, please?
Yeah.
Yeah, so para 1, okay. So primarily you need to go and re-excise this. So either you can do either a cone, or if facilities for leap are available, you can again do a re-leap. The idea is to get a negative margin.
Yeah, okay. So that's true. And we did a repeat less for the patient. And it
I think
was...
Arpita has joined. Bindya, Arpita has joined.
Okay, so we'll proceed with this. So so we did a repeat less for the patient. HPV associated changes or any
Very poor.
So, Dr. Rohit, you can only continue.
Yeah, so she just needs a regular follow-up with. I would just do a wall smear on. I would just do a wall smear on her. The only thing is, pre-op, I would be interested if the endocervical involvement has been ruled out. So in a LEDs, we would also require what is known as something like a top hat specimen. So if that was negative, and if a pre-op MRI or something was done to rule out, then I wouldn't repeat an imaging in the follow-up. Just a wall smear would be more than, I mean, a cervical smear would be more than sufficient.
So yeah, that in this we did not do a top head excision, but what we did was, because there was negative margins all around, the radial margin was free, so we did not proceed for any other excision. So that is why the second this one was not done. But endocervical evaluation was and this was after the second excision.
Yes.
And and for how long will you like to follow this case?
Maybe I would do an intensive follow-up maybe for the first 2 years, but after that she needs a regular screening till the age of 65.
Exactly, yeah. So
Yeah.
annual smears till at least 2 years,
Yes.
and then what RCOG says, it says up to even 9 years of annual smears, they say, and then they can go for
Yeah.
normal screening once all of the smears are negative. Okay, so another question I would like to, in the same case, is that would your management, this was a squamous cell cancer, so would management be different for an adenocarcinoma of stage 1 of this stage, especially with respect to excision of the margins?
Yeah.
Yeah.
You would go much more deeper to involve the internal loss.
Yeah. Yeah, so basically in this we will try to do a top hat, because of the adenocarcinoma is especially known for skip lesions, and so
Yeah.
that is why an extensive endocervical evaluation is required for adenocarcinomas. And also sometimes they're focal, sometimes they're extensive. So how do you interpret LVSI in your setting, and how do you manage LVSI in microinvasive cancers?
Since it's a small biopsy, it is actually very difficult to comment on LVSI because there will be a retraction error that has to be differentiated from an LVSI. Sometimes it might require an IHC to determine whether it's just a retraction error or an LVSI. If the pathologist is very sure about the LVSI, we need to revisit and do pelvic lymph node excision for this patient, laparoscopic.
Okay. Would
If
you
the
like to go
option is
for a
there,
sentinel node or for lymphadenectomy?
we can consider sentinel node also.
Okay. Yeah.
No, I would
sure.
tend to differ. For adenocarcinoma stage 1A, instead of a lead, I would prefer a cone, because probably the depth is more better in the cone as compared. And again, I think taking the endocervical curate is more important. You need to get a negative endo, because these are some which can go endocervically, adenocarcinoma as compared to a squamous carcinoma. 1A1, even with LVSI, I wouldn't go for a lymph node dissection, because I don't think there is enough evidence to do a lymph node dissection for a 1A1 with an LVSI. 1A1 just needs either a hysterectomy if she's completed her family, or it just needs a cone with a negative margin.
So that is why sentinel nodes are better, and they say it is like preferred. It is not a acceptable thing that we have to do lymph nodes. But yes, it is you can or you cannot. But then if you are planning to do, a better option will be doing a sentinel nodes rather than doing a complete pelvic lymphadenectomy. And as I said, because endocervical these adenocarcinomas have skip lesions, so that is why extensive endocervical evaluation, like what you said, is required for these patients. Okay, thank you so much. And for now, case 2, I will request Dr. Bhagia to do the second case.
We go ahead with the second case. It's 67 years, para 3, living 2 with previous 1 cesarean, postmenopausal for 20 years. Complaints of postmenopausal bleeding, a single episode 2 months back. There was no other pain, bladder or bowel symptoms, or loss of appetite, loss of weight, or comorbidities. And her external genitalia was healthy. The speculum examination showed that the cervix was flushed with vagina, and the posterior lip showed a lesion of 1.5 centimeters, not bleeding to touch, and the vagina was normal. PV uterus was small, cervix flushed with vagina, and hard growth felt. Fornices are clear. So the bilateral parametrium was free, and the investigations were all normal except the cervical biopsy with endocervical curating, which showed keratinizing squamous cell carcinoma. So, and again, so these are small cases. I think we all agree that for the local spread, MRI is a better method. So focal mass was seen at 1.5 to 2 centimeters at the 6 o'clock position with no significant parametrial extension. No significant extension is seen in the upper third of the vagina, and the pelvic side walls were normal. So Rohit, what would you plan in this case? Any further management, or was the MRI good enough? And would you explain that there was a growth in the cervix, but it never bled on touch also? So what could be the type of the growth that we are looking at? Please unmute.
It is likely that this was a very small tumor and it was probably a non-proliferative growth. Now, if cost is not a problem, then one should go for an MRI because, as you already said, the local tumor and the parametrium, as compared to other imaging modalities, MR is more better. But even doing a CT is not wrong in these cases. I think I personally would even just do a CT scan as well, because ultimately the amount, as a surgeon, you need to know if the parametrium is involved and the primary tumor, whether the vaginal fornices are involved. That local good imaging is good enough to know whether the para is involved or not. MRI has good, excellent, you can say, role in very doubtful cases where you're not sure whether it's the inflammatory parametrial lesion or it's actually involved. In that cases, maybe MRI would definitely have an edge over a normal CT scan. But MRI pelvis and then maybe with a CT screening of the abdomen is more than sufficient.
Yes, I think because it was a small lesion and it was an infiltrating lesion, because it were not a proliferating type. I think especially in infiltrating lesions, I think there's given a choice between CT and MRI, I think we'll prefer MRI to know about the infiltration, because proliferative lesions are better to delineate clinically.
Yes, yes, and I think since this case also had the endocervical curettage positive, in this case it would be better to do the MRI.
Okay, okay. So, is there any? Can we go to the yes? What is the role of PET CT? Do you really encourage patients to go for a PET CT at the first go, or what is the role of PET CT in these cases?
No, in early stages, in early cervical cancers, I don't think PET scan has any additional role over a good CT scan or an MRI scan. PET scan has a very limited role in cervical cancer. Maybe for advanced cases, for 3Bs and above, it's a little better for imaging of the retroperitoneum. And yes, when you are considering recurrent disease, definitely before planning something like an exenterative surgery, PET scan should be the modality of choice.
Yes. So given a choice, I think in the early stages, we can do MRI for local spread, and in advanced disease, we prefer a CT scan for the nodal status, and in recurrent settings, it is PET scan. So that's it. So radical hysterectomy was done for this patient, and the histopathology again showed a keratinizing squamous cell carcinoma, stromal invasion, middle 1/3 with extensive LBSI, margins uninvolved by invasive carcinoma, lymph node samples 14, all were negative, parametrium was negative. So she was staged as PT1B N0 MX. So is the Dr. Shinde around? I can't see him actually. He has not logged in. So anyone else can take this? Okay, I think anyone can take. Dr. Geeta, can you comment on the role of MIS in cervical cancer? What is your take on that?
Well, this is the time of a minimally invasive surgery. The whole world is looking, even in case it's a malignancy, we are going towards, minimally invasive surgery. So we should look as far as possible to, sort of minimize the surgical this in cancer, even in patients with cervical cancer.
I think Rohit, can you comment on this?
Yeah, so if you look at data till 2018, it was all pro minimal access surgery. We thought minimal access was as good as open surgery, but then came a trial called the LACC trial, which you have mentioned in your slide. So it was probably the first site where minimal access has favored inferior to open surgery. The patients who underwent primarily laparoscopic assisted radical hysterectomy had a significantly inferior survival as compared to open surgery. Now, this trial was not powered to answer question of tumors less than 2 centimeters, and it also had a few cases of robotic surgery. So, though in spite of having equal parametrial margins, equal nodal count, still these patients recurred earlier as compared to the open patients who underwent open surgery. So, if you are considering randomized evidence, I think you can offer minimal access surgery, but you need to discuss the results with the patients. That is what the NCCN guidelines, the ESGO guidelines, and all the Even the FIGO, even the NCC and ESGO, all these guidelines have clearly told. Now, there were a few criteria why this trial minimal access favored inferior to open surgery. Some say it was because of tumor contamination. Some say it is because of the use of uterine manipulators, but we actually don't know. There have been few retrospective studies where they have not used manipulator, and they have tried to close the vagina with a vaginal technique or use of uterine staplers, and in that minimal access has not favored inferiorly. But if you consider randomized evidence, as of now, we need to discuss these results with our patients before offering them for minimal access surgery. Otherwise, open surgery is the gold standard as of now at present for cervical cancer.
But in case you really plan to do as a patient insists, I think that she should know the results. And then again, you also have to characterize your patient very clearly. It has to be a small growth, no other risk factors and all those things. And there are some proponents of MIS who tell that until we have Indian data that shows that the mortality is high, we can go ahead with that. So I think, but I agree with Rohit that as of now, I think open is the gold standard for cervical cancer till we have some more data on that.
No, I mean, tomorrow if you discuss with your patient that I will do a technique where it has shown, a randomized trial has shown an inferior result, it's very difficult for the patient to accept that.
No, it all depends on actually how you counsel the patient. We agree that open surgery, we have experience of so many years, and minimally invasive is really new. And because even in that, the robotics as well as the laparoscopy, each survival is different. So it depends on the patient, what does she want and how informed she is, and the doctor, what they can offer in that particular setup, and what is their expertise. So put everything put together, whatever best we can offer the patient, we have to offer in that particular situation. But true, we have to keep the patient informed and take her consent as to what we are doing.
Thank you so much. And so anyone to take this question on the criteria for post-op radiotherapy. So Dr. Uma, can you take this question? Because we don't have Dr. Sindhe with us today. He was supposed to be here.
The criteria of radiotherapy will be all the high-risk factors like lymph node involvement, lymphovascular space involvement, large tumors, if there is parametrial invasion, if the margins are positive for tumor, and with deep stromal invasion, middle and outer. So all these cases have a high chance of lymph node involvement and stage, so they have to go for radiotherapy.
Bhagya ma'am, unmute.
So that's Bindya, can we go back one slide? So just to revise what Dr. Uma has told, if there is one of these parametrial invasion, lymph node positive or margin positive or closed margin, I think that's a high risk criteria. Any one of them will potent adjuvant radiotherapy. And out of these two factors, LVI, large tumor more than 4 centimeter, deep stromal invasion. So any two of these. So these are again other criteria also, deep 1/3 invasion, middle 1/3 and superficial 1/3. So you can characterize what is stromal invasion and then plan the radiation according to that. So this is again another criteria, and LVSI has now come up in a very big way. So anyone can comment, Dr. Bhosale, on this radiotherapy criteria. Dr. Arpita, are you there? Okay. So I think that the NCCN has very clearly given guidelines about if the nodes are negative, margin negative, and the parametrium is negative, you can observe. Or pelvic EBRT if combination of high risk factors, that is primary tumor size, stromal invasion, and or LVSI that meet Sedley's criteria. Or you can also give concurrent cisplatin-based chemotherapy, that is CCRT. But if there is a positive pelvic node and or positive surgical margin or positive parametrium, there is no doubt about adjuvant treatment. And if para-aortic lymph node is positive or by surgical staging, which we regularly usually don't do unless you have isolated para-aortic node, imaging workup for metastatic disease is done. If this is negative for distant metastasis, we can do a para-aortic lymph node EBRT with chemoradiation plus pelvic EBRT plus or minus brachytherapy. But if it is positive for distant metastasis, we consider biopsy of the suspicious area as indicated. If negative, we go ahead with only para-aortic lymph node metastasis. And if that is positive, we give chemotherapy, which is now, of course, a systemic disease, and of course, individualized EBRT according to the stage. So this is the NCCN guideline about radiation. So, Vindhya, please take the third case.
Thank you. So coming to the third case, so this is a 41 years old female para 2 with 2 living issues. She presented with irregular bleeding per vagina for 1.5 years. On examination, per speculum examination revealed a 3 centimeter cervical growth with purulent discharge. And on per vagina and per rectal examination, there was a growth in the cervix, which is 3 centimeters. Bilateral parameter were free and all fornices were free. And a biopsy was taken, which revealed a poorly differentiated carcinoma. MRI was done for this patient, which revealed the same growth. However, there was pyometra. So a very common question which comes to our mind is, should we drain the pyometra before offering any kind of treatment? Dr. Ramesh can take the question, please.
Dr. Ramesh, please unmute. Dr. Ramesh.
Okay, Dr. Umar, Dr. Geeta, anyone can take the question?
Yes, madam. I will drain the pyometra before treatment.
Ma'am.
Patient adequate antibiotics and then consider treatment.
Okay, any difference of opinion from this?
No, ma'am. Pyometra is to be drained. We are sitting on an abscess and we are waiting for sepsis and any other complication.
Okay,
so I
So
think
it should be drained by all means.
Yeah, it should be drained. Patient should be kept head high so that it drains further on dilatation, and then we have to send it for culture and antibiotic sensitivity and start adequate antibiotics for the patient.
Okay, ma'am. But sometimes what happens, like if suppose they're taking up the patient for surgery, if suppose there's a small amount of pyometra, around 2 ml or 3 ml, we normally, it is sterile, so we normally leave it also because it's just a collection because of the growth of the cervix, which is obstructing the secretions to drain. So sometimes in our hospital, we just leave it also, unless and until it is too big that it might have a rupture intraoperatively. But otherwise, if it's a very small one, sometimes we do operate it inside. And before radiotherapy, definitely we do drain the
So at the
pyometra.
time of the biopsy, wasn't the pyometra tackled?
Yeah, so it did not drain completely because it was a big growth and it revealed that there was a pyometra. So we did not.
No, if you look at
yeah.
if you look at the MRI images, the pyometra is not that significant. So it is obstructing the internal os. It is bound to collect inside the uterus. So since the findings mention that this patient is fit for surgery, it is likely a surgical candidate. There's no need to go and drain the pyometra. Most of the times while taking biopsy also the pyometra might drain, but there's no need to do an additional procedure just to drain. You can go for surgery straight away. Even if the patient is for radiation, most of the times once you start radiation, the pyometra, the growth reduces, the internal os gets unblocked and the pyometra reduces on its own.
Yeah, but I don't know. But sometimes in our hospital, the radiotherapists, they really want the pyometra to drain before giving radiotherapy. But surgery,
no,
we don't.
Only question is if the uterus is quite huge and because of that their radiation planning is getting altered.
Exactly.
Then they insist that the pyometra is better drained off.
Yeah.
No, right. Before brachy also they insist for draining the pyometra because they have problems.
So before radiation, they do insist, but for surgery, like I said, if it is very, very big and we are thinking that it will have an intraoperative rupture, then we might attempt. Otherwise, there's no need to drain the pyometra before surgery. So surgery was done on this patient and there was, as you can see, there was a big growth. And this growth was also extending into the endometrium and into the lower part of the endometrial cavity. And it was involving up to less than 50% of the stroma. And ectocervix was not really involved, but basically it was predominated endocervical growth. And microscopy revealed an invasive adenocarcinoma of the cervix, which was grade 2, and which was involving the lower uterine segment. And there was an endomyometrial superficial part which was involved by adenocarcinoma. Bilateral ovaries and tubes were normal. Bilateral parametria was normal, and all the regional lymph nodes also showed reactive changes. So now we have a confusion here that this is an adenocarcinoma. So whether it is an endocervical pathology or whether it is an endometrial extending to the endocervix, because what happens is that sometimes an endocervical adenocarcinoma can have a limited endocervical component and a dominant endometrial component, and sometimes it is vice versa. So, and also they also have some shared morphological features, because like endometrioid features and sometimes even the mucinous differentiation also. And tumors of both types, they share the glandular architecture, and both can have the below glandular or the papillary pattern also. So do we need to do something more on histopathology to differentiate whether it is an endometrial origin extending to endocervix, or whether it's an endocervical carcinoma predominantly?
This cervical biopsy or whatever tissue we receive, that should be sent for ISC panel of preferably vimentin, P16, carcinoma antigen, and ERPR. But now these vimentin and P16 are significant markers, and by that we can differentiate if it is a adenocarcinoma of endometrium origin. In that case, vimentin will be positive, and if it is a carcinoma of endocervical origin, then P16 will be positive. That way we can differentiate, and differentiation is very important because then our line of management.
So this tumor was P16 positive and vimentin negative, and so diagnosis was finally primary endocervical adenocarcinoma of stage 1B2. So thank you, sir. And continuing with your answer only, so why is it important to differentiate between the two and know the tissue of origin? Sir, can you continue with your answer? Sorry. Hello. So,
hello.
Yeah.
It's necessary, ma'am. If it is an endometrium origin, we can simply get away with simple all other. We have to think for the further plan of lymph node and any other things. So it's necessary to know, and later on follow-up is very important. If it is endometrial origin, then you see progesterone, other therapies also come in play. If it is simply a cervical origin, then she is requiring further follow-up for lifelong, even after. So that way it is important to know the origin of tissue.
Okay, yeah. So basically to see the treatment modalities and type of surgery to be done is very important. We need to differentiate whether we are dealing with a primary endometrium or primary endocervix. Our adjuvant therapy, our lymph node dissection also depends on this. And so we need to have certain techniques to differentiate between the two. And as you rightly said, the immunohistochemical staining by vimentin and P16, the panel is important to differentiate the two. Thank you, sir. And what about ovarian preservation in early cervical adenocarcinomas? We are dealing with a youngish patient. So do we preserve the ovaries, and what is the consensus for adenocarcinomas of the cervix?
She is a very challenging case because she is very 44-year-old, and this appears to be because 3 centimeter tumor mass is around, then she is falling in stage 1B. In that situation, ovarian to get rid that we should areas whether to remove the not to remove ovary, and those criteria mainly depends on the age of patient. If definitely more than 45 years, we should remove. Then the stage, if it is beyond 1B, then there is no chance we should remove the ovary. If the tumor size is more than 4 centimeter, we should remove. Then we should also take into consideration a stromal invasion. In this patient is a 7 mm. In case how much is parametrium involvement. So in this patient, luckily parametrium involvement is not there. Then we also look into if there is a myometrium involvement is there, but in this patient there is a minimal myometrium involvement is there. Then we also look for lymph node, they are negative in this patient, and also LBSI we have already discussed. So seeing this case is absolutely borderline case. Seeing our Indian scenario and the follow-up of the patient, I would like to go removal of the ovary this patient.
Okay,
because
so
he is absolutely at the borderline.
Yeah,
for all criteria.
Yeah, so she is a dilemma. So anybody who will like to
Yes,
preserve.
I would like to discuss it with the patient, because some patients, they are very insistent that no, if my ovaries are healthy, I would like to have, so sometimes we may have to give in and for particular patient, but then remove the ovaries.
Okay.
Discuss with her about.
Yeah, I mean, basically conserving first, whether that is required at the age of 44. And then if at all she's very keen, then we can talk about transposition. Yes.
And suppose if you remove the ovaries, would you like to give a HRT after removal of the ovaries? We've done, she
See,
said, okay, remove my ovaries. And
yeah, see, long-term role of long-term HRT after the recent trials, they do not advocate giving long-term HRT. HRT, if at all she develops any symptoms, then only we give, and that too only minimally for 3 months. Wherever possible, we give local creams. Otherwise, oral, if we are giving, we do not give more than 3 months at present. But we also have to take her other comorbidities, diabetes, hypertension, and other risk factors into consideration before giving HRT. But we do not give any prophylactic HRT nowadays.
she was an adenocarcinoma.
But no, but even recent trials, we do not give anything prophylactical. If she develops any symptoms, if she develops hot flashes, or if she develops repeated urine infection, then she needs something, then we give. Otherwise, we do not routinely give.
And will you advise her to do a ERPR before giving any kind of HRT?
In this case?
Yes, because it's adenocarcinoma. So would you like to do the ERPR before
See,
doing
whatever it is, HRT, the maximum this comes from estrogen. Progesterone is just as an antagonist to estrogen. So, even if she is estrogen receptor negative, still it is advisable not to give estrogen at this particular age. So, wherever possible, we have to just avoid. And there has been a large trial in which they found that it is extremely detrimental to give prophylactic. If she has complaints, if she has any complaints, then it is okay, but not otherwise.
Okay. Rohit, your take on the HRT in adenocarcinomas?
If you look at data for endometrial cancer, stage type 1 adenocarcinoma, stage 1, there is definite data that HRT is safe. There is in fact a large paper from MSKCC which says that the risk of recurrence is not that high, especially for stage 1, type 1 histology. Type 2 histology, it should not, there's no data, so we can't ascertain the safety. As far as cervical adenocarcinoma is concerned, I don't think there is substantial data to whether to give or to not to give. Maybe an individualization is more important. But regarding the ovarian preservation for an adenocarcinoma at the age of 44, I wouldn't advise for ovarian preservation. Squamous, definitely yes, you can safely go and preserve the ovaries. Yes, but it's again important. It's again important to do an ovarian transposition at this time, so as to at least avoid, in case she requires radiation, you can avoid the side effects of postmenopausal because the ovaries, the radiation tolerance dose of ovaries is very, very less.
Thank you so much. And I think we agree with Dr. Geeta that we have to give the HRT only when needed and for a very short time, just for the symptom relief. So thank you. So Bindya, I go ahead with the next case. Yeah. So she is 26 years, para 4. By 26, she is para 4. She has foul smelling vaginal discharge for 4 months, lower abdominal pain for 4 months, 3 episodes of postcoital bleeding, history of weight loss of appetite, is a tobacco chewer for 8 years, has a posterior lesion on the posterior lip of the cervix, which is replaced by a proliferative friable growth for 4 into 5 centimeters with discharge and bleeds on touch. And it is soft, friable, and again 4 to 5 centimeters in the posterior lip. The uterus is normal, bilateral parametrium is free, rectal mucosa is free. So all the investigations are normal, and the cervical biopsy shows carcinoma in situ with no foci of invasion. And so a repeat biopsy was taken because it was a frank growth, and this again confirmed that it's a non-keratinizing squamous cell carcinoma. So MRI of this patient showed a heterogeneous enhanced lesion in the cervix, 5 into 4.6 into 4 centimeter bulging into the endocervical cavity. And fat planes between rectum and mass appear focally indistinct. Fat planes between urinary bladder and mass appear focally indistinct. Parametrial extension not seen. Pelvic lymph nodes not enlarged, few subcentimetric, mesenteric, and inguinal lymph nodes are seen. That's a different story. So the impression from this was a stage 1B3, and she is only 26 years old. So what would be the management options in this patient, Dr. Uma?
Madam, there are two options. One is, since it's a large tumor, a vascular tumor, we could give a neoadjuvant chemotherapy and after 3 months post-op or radical hysterectomy. Or the second option would be to give concurrent chemoradiation. That will depend on the expertise and the wish of the patient also.
So because she's very young, would
Yes,
you consider her for any kind of surgery?
Yes, madam. Neoadjuvant chemo cisplatin and after 3 months poster for hysterectomy.
Okay.
Ma'am,
So,
ma'am, can I comment, ma'am?
Yes, yes, sure, sir.
Ma'am, I'm medical oncologist basically.
Okay, okay, great to have you here. Yes, sir.
Yes, ma'am. Basically, one trial from Tata, recent trial published from Tata, it has shown that upfront chemo radiation is better than neoadjuvant chemotherapy followed by radical surgery in case of in stage 1B3 onwards, ma'am. So
yes, agreed.
so
Very much agreed. So my only concern is that she's 26 years. So do you want to go ahead with CCRT and?
Yes, ma'am. Definitely, ma'am. Because salvage surgery is better than salvage radiation. So we prefer upfront chemo radiation, ma'am.
Okay, then. So the whole panel, I think, Rohit, can you comment? Yes, Rohit. Unmute.
5-centimeter tumor and it's a proliferative tumor and you are confident of you will get a negative vaginal margin, we can consider her for surgery as well because she's young. Definitely neoadjuvant chemo is not an option outside a trial in the view because the NACT trial has shown either it is concurrent chemo radiation or surgery. But if I'm sure of getting a negative vaginal margins with a good cuff, I would consider her for surgery as well, because she's quite young.
The tumor is like very big, and just in case if she has some margin positive, will be, and you end up giving dual treatment, so which people generally avoid.
Yes, agreed. The aim of treatment in cervical cancer should be unimodal, but if this is a proliferative tumor, you can get a negative vaginal margin. It's just that the size may not be the only criteria. So
but like MRI also, they were like the planes between the bladder and between the growth and this were very indistinct. Although we are not, there's a lot of false, but still there is a higher chance that she may need post-operative radiotherapy after surgery. Higher chance.
Yes, no, but in a proliferative tumor, for it to go into the bladder, it takes a long time. You can always know whether the bladder is involved on a good MRI imaging, or you can even do a flexible cystoscopy as well. So, and usually young women have good fornices. So the fornicel length is quite significant. For it to go to the fornix and then to go to the bladder, you will detect vaginal involvement on MRI. So if on an EUA, if I am sure that I will get a negative margin, I would go ahead and operate.
Had she been 45 years, there would have been no confusion, I think, because she is 26 years and it's a purely proliferative tumor. Just not considering the fact planes what you have told, I think would agree with Rohit that you can go ahead with surgery in case you can do a complete surgery though. But then because, and again in Indian scenario, all the women do not have the facility of a radiation, because many centers they really don't have. So I think we can't wait till her radiation will she'll get a date after 1 month or 2 months. So I think in those cases, I think we can sometimes consider. So looking at the trial, I very much agree with Dr. Ravi Kumar, but I think so once in a while you can take an individualized call.
No, unfortunately, these patients respond very well to neoadjuvant chemo, but the trial has not shown any survival advantage.
So, but if you're planning for surgery upfront, so can we give a trial of neoadjuvant chemotherapy and then post-op for surgery? Because anyways, you're going to give surgery. We are going to do surgery like 2 cycles or 3 cycles later. So why not give NACT and try to minimize the chances of post-operative radiation?
No, in fact, giving NACT will make your surgery more difficult. If you give chemo, you have to give chemo only if it is making your job a little easier. Usually after chemotherapy, the fibrosis is more. I have worked for 1 year as a research fellow in the NACT trial in TMH. So after chemo, when we used to operate on this patient, the incidence of fibrosis was much more as compared to operating them de novo. So there's merit in giving neoadjuvant only if your job was going to be a little less difficult and the patient was going to have a survival advantage. But I don't think even the EORTC trial has not shown a survival advantage. So as of now, I think you should either go directly for surgery or for concurrent chemoradiation.
And I
would
think
like
a
to differ from it.
proliferative, yes, yes, Arpita.
Thing is, yes, of course, outside the trial, it is our option. And more than our option, we have to ask the patient and discuss with the patient her preferences
Yes.
of having primary chemo radiation
But
and
Arpita,
versus
most of
surgery.
the time they'll tell
And
app, you decide what. So
Right.
they will leave
yes,
it on you only. Most of the
yes.
time they leave
And
it on you.
that is true. That is true. But
Yes.
what Rohit was telling about the amount of fibrosis after chemo radiation, we need not give the chemotherapy until it is 3 cycles. We actually can reassess after 1 cycle, and actually most of the tumors will melt after 1 cycle. Within 1 cycle or 2 cycles, we can take her for surgery, and it will of course make a difference. Yeah, this is outside the trial.
So agreed, agreed. So in a young patient, you can give 1 cycle of chemotherapy and operate. But in case you are comfortable to operate with a tumor like this, I think you can go ahead and operate also, because she's 26 years. She may not have the feasibility of having a radiotherapy date early. So you can do this. And this is a trial. I think this is the, so yeah. So this is a research article which shows that neoadjuvant chemotherapy plus surgery versus concurrent chemoradiotherapy in stage 1B to 2B cervical cancer. This was a systematic review and meta-analysis in which the Tata trial is also there. And I think we have discussed everything about that, this neoadjuvant chemotherapy does not give a survival advantage. So thank you very much. So can we go ahead with the next case? Because we are running short, I think.
Yeah. So this case number 5. So she is a 25 years old female, nulliparous, with complaints of postcoital bleeding for 4 months and no other complaints. Cycles were regular and no significant personal or family history. And on examination, there was a small 1 to 2 centimeter growth on the right side of the cervix, and uterus was antibody normal size, non-tender, fornices were clear, and rectal mucosa was free. So a cervical biopsy was done, which revealed an adenoid cystic carcinoma, but oncopath review showed it was an early invasive adenocarcinoma. So investigations were done accordingly. Uterus was normal, endometrium and endocervix was normal, and MRI just revealed a focal mass in the cervix, 1 into 1.5 centimeter, and no significant parametrial or vaginal extension, and there were no enlarged nodes. And considering the young, she was nulliparous, so a hysteroscopy with an endometrial biopsy and a radical trachelectomy with bilateral pelvic lymphadenectomy and a transabdominal cerclage was done. And the uterus was normal size, bladder was normal, bilateral tubes and ovaries were normal, and parametrium was also normal, and nodes were not enlarged. And there was a small 1 centimeter growth on the right side on cut section of the specimen. The final histology revealed a 1.5 centimeter growth in the cervix, which is a well-differentiated adenocarcinoma. And it was there was no LVSI, parametrium was free, vaginal margin was free. The cuff was almost 1.6 centimeters. Lymph nodes harvested were 18, were all negative, and so it was a 1B1 cancer cervix, for which a radical trachelectomy was done. So I would just want to ask, does anybody have experiences with radical trachelectomy, and what are the criteria followed? And if have experience and follow up, what are the expected outcomes and pregnancy outcomes following a radical trachelectomy, both pregnancy and oncological safety?
See, I have not done a radical trachelectomy myself, but I have had patients who have had radical trachelectomy conceiving. They actually, there is no problem for conceiving in these patients. They conceive quite fast, and quite a few of them continue pregnancy and have no problems, but about 30 to 40% do have cervical factors, like they have premature opening of the os, threatened preterms. So these patients we do tackle, and cervical stitch or McDonald's os tightening becomes slightly difficult. So we need to do an abdominal os tightening for these patients.
Yeah, so with radical trachelectomy, normally we put an abdominal cerclage when we do a trachelectomy. And anybody else, Dr. Rohit or Dr. Arpita or anyone has done has experiences with trachelectomies?
Unfortunately, I don't have any experience with trachelectomies. But, the take-home baby is what literature says is around 60%. That's what is, but no personal experience.
No, pregnancy, if they occur, quite a few of them, they go till at least 34 weeks, if not to 37. And a few of them, like about 20 to 25%, almost 30% of them have premature opening of os, repeated threatened preterms, needing complete bed rest, needing abdominal cerclage. So it does become difficult also.
Yeah,
But we have.
Yeah, correct. No, please go on. Sorry, madam.
No. So we have to discuss this with the patient. We have to find out whether the patient is desirous of fertility. We have to rule out the other contraindications, multiple comorbidities, the other issues related with the fertility potential. Now we are seeing very young patients with very low AMHs, whether it is really worthwhile doing conservative surgeries in these patients. We need to think. And of course, the disease, how is it? If it is less than 2 centimeters mass, and then it is SCC or adenocarcinoma, the MRI showing tumor at least 1 centimeter away from the os. Even if you say it is 1 centimeter away from the os post trachelectomy, there is a considerable amount of fibrosis that does occur and causing cervical incompetence in these patients.
Yeah. Also, though your patient is an adenocarcinoma, usually adenocarcinoma is a sort of a relative contraindication because there is more of an endocervical. But if you are getting a 1 centimeter margin on MRI, I think you can still offer it to your patients.
So yeah, that is why we debated it also. But then it was there was a margin was the tumor was quite low. It was not really extending to the endocervical canal, and fortunately all the margins were free. And this patient, in fact, is an older case. She was followed up. She already has had one child, and this case I saw it in UK. So she already had one child, and she was planning to conceive for the second one, and she was without any recurrence for 6 years after follow up. So. So this was quite a rewarding case. So adenocarcinomas are not a contraindication if you have a good margin, you've got a good and good preoperative assessment and good assessment for the growth size and all. So,
sorry to interrupt.
Yeah.
But as we are running late, can I request to sum up?
Dr. Bhagya, you want to deal with the sixth case?
There is no radiation.
Yeah. Ma'am, you have to unmute. Unmute yourself, ma'am.
Okay. So case 6, I think we'll just summarize because we don't have a radiation oncologist with us. So can we go to the last slide of this case?
Yeah, this was a
principles of radiotherapy. I think we have only gynecology, so we don't need to know much about, and we don't have a radiation oncologist also. So next slide, please. Okay.
So we'll just leave this, and what we wanted to highlight was the surgical staging and whether it is important to do surgical staging prior to chemoradiation or just a PETS imaging is okay with it. So this was the only randomized trial which was done. The latest trial which has been published is Uterus 11, which shows that the laparoscopic staging did lead to upstaging, and it showed that it was better, superior to clinical staging with respect to disease-free survival, especially in the stage 2B cases. So that was an advantage with the laparoscopic stage, with the surgical staging.
Even the French retrospective group data also says the same, though there is not a significant overall survival benefit, but there is a trend towards a DFS benefit in especially 2B cancers. So maybe laparoscopic or robotic surgical staging might have value.
Yes. Okay, thank you. So we'll just go to case number 7, and this is a patient. This was very interesting. She had a treatment done for cancer cervix 2B in May 2009, in 2009, and then she presented 10 years later with recurrence, basically loss of appetite and all the systemic. They found it to be radiologically and clinically 1B1, but it was a carcinosarcoma of the cervix. And we all know that, the cancers, post-radiotherapy cancers, normally sarcomas are quite common. And this patient underwent laparotomy, however, it could not be completed. And then a repeat biopsy was taken only at that time. It was a carcinosarcoma, and then she was referred to a cancer center, and where it was found to be a widespread with both the parameter were involved in this patient. So in this patient, again, the repeat biopsy was taken, which is carcinosarcoma. And because it's such an atypical tumor, we got this for the tumor board because we just wanted to discuss the further management of a carcinosarcoma, which is now an advanced stage. So just to summarize.
I think we can call on Arpita or this one, Dr. Roy.
Yes, ma'am.
Yeah.
Can I comment?
Yes, Doctor. Yes, Ravi. Yes, sir.
Yes, ma'am. Carcinosarcomas, ma'am, they are very rare tumors. They are more commonly seen in.
But this happened because of previous radiation. She already had radiation for C cervix.
Yes, ma'am. Ma'am, it has two components. One is carcinoma component, other is sarcoma component. And both components, generally, they are high-grade components. We treat on the line of carcinoma only. So commonly preferred regimen is taxane-based regimen, paclitaxel and carboplatin or paclitaxel with cisplatin. If patient don't respond to these regimens, ifosfamide-based regimens can be used. But generally, these are very aggressive tumors. Many patients don't respond to chemotherapies, so they have a very bad prognosis.
This was non-metastatic, right?
Yeah, this was an advanced.
No, advanced. Okay, I'm talking
locally
about
advanced.
advanced cancers, metastatic
This is
cancer.
locally advanced, not a metastatic, but it was spread in the parametrium.
Okay.
Yes.
So,
Rohit, this was a case, I think it was operated in site care in Bangalore, and they could not complete the surgery, and then she was, because she belonged to Cuttack, so she came back here.
Yeah. Okay, so we have the last case, Bhagya ma'am.
So she is a 69 years old, presented with postmenopausal bleeding, no other complaints, no significant positive. And so her cervix showed a exophatic growth of 3 into 2 centimeters, not extending to vagina, and it bled on touch, and the uterus was bulky. Phonesis were free, and the parametrium was also free. So it was so, but unfortunately, the cervical biopsy showed a carcinoma cervix, poorly differentiated carcinoma. So, according to the stage, and the imaging also confirmed the stage. So, a type 2 radical hysterectomy was done, and the findings were uterus was atrophic, bilateral tubes and ovaries were normal, dissectability was good, and cut section showed a 4 centimeter friable exophatic mass arising from the endocervix. Next. So the post-op histopathology showed a small cell poorly differentiated carcinoma, and the morphology was consistent with neuroendocrine carcinoma, which is a very, very rare diagnosis. And the lower uterine segment and endocervical canal were involved, and LVSI and PNA were not seen. Bilateral parametry and vaginal cut margins were free. Ovaries were normal, and all the lymph nodes were reactive hyperplasia. So the thing is, issues to discuss is what is the management of neuroendocrine tumors of the cervix. I think we have Dr. Ravi with us, who can comment on this. But before this, I think the important thing would discuss that we missed the diagnosis of this PNET in the pre-op histopathology. So we don't have a pathologist here, but Bindia, can we go back to the slides? So the pre-op histopathology was a poorly differentiated carcinoma, and the post-op histopathology was PNET. So the thing to be told here is that whenever you get a biopsy of a poorly differentiated carcinoma, I think you have so many options that can happen with that. So I think it's better to go back to your pathologist, talk to them, and ask for a confirmatory diagnosis by IHC before proceeding for the final treatment. So this is where we missed the diagnosis of a PNET tumor. Next. Dr. Ravi, please go ahead.
Yes, ma'am. High-grade neuroendocrine tumor, ma'am, they require adjuvant chemotherapy. We generally use platinum-based chemotherapy, platinum and etoposide combinations. Those patients who are node negative, they don't need adjuvant radiation. They just need adjuvant chemotherapy only. For node positive patient, after chemotherapy, we can add radiation also. And for node positive patient, in addition to adjuvant chemotherapy and radiation, in clinical trial setting, we can offer prophylactic cranial radiation, because these neuroendocrine tumor, they have high chances of CNS spread also.
So do you think we need to do some imaging for the brain as soon as we get a diagnosis of a PNET?
Yeah.
For node positive, at least you should.
No,
Okay.
this is one where there is merit in getting a PET scan done,
Yes.
even in early stage cases.
Yes.
And irrespective of even it's a small tumor with node negative, I think all should receive chemo and radiation because they need to be aggressively treated. It's very important to counsel the patient that this is an aggressive tumor and the chances of recurrence are quite high.
Yes. And I think, the next slide. So the patient defaulted and we lost the patient, unfortunately. So this, we have to remember that PNET tumors is, once in a while we may get those diagnoses, but I think your pathologist has to be very, very learned to pick up this diagnosis. Yes. So that is also very important. So I think we come to the end of the session. Thank you all our panelists. Thank you, Bindia, for making all the cases and arranging them also systematically. Thank you so much for all your inputs.
Thank you,
Dr.
Madam.
Ramesh, Dr. Uma, Dr. Arpita, Dr. Rohit, and Dr. Ravi. And thank you
ma'am,
again,
for
Dr.
inviting me.
Parag, for your. Dr. Shekhawat is also there. I think his video is not on. So, thank you, Dr. Parag, Dr. Ashwini, and for the opportunity for discussing all this cases that we come across in our day-to-day practice.
Thank you,
Madam.
Bhagyalakshmi. It was
Thank
indeed
you, ma'am.
Madam, thank you very
interesting.
much. It was so comprehensive.
Yeah.
Thank you, thank you, thank you.
And it was pleasure to see Bindya. I've never heard her, but then I'd heard her name from you. So it was pleasure to see her. And I'm especially
you so
pleased to
much.
see Rohit because we've seen him as a very young man, and then he's here today as gynae oncologist. So it's really heartening. And of course, our three teachers from Pune, they are really good at it. Thank you so much, Bhagya. Thank you, Bindya.
Thank you
Thank
so
you
much.
very much.
Thank you
Thank you
so
very much,
much.
sir.
Thank you
Thank
so
you.
much. Finally, time to dinner, and we all should move and get decked up for the tomorrow. That's the last day, day 3. Well, thank you so much for cooperating with us. Because of your cooperation, we could make sure that we can keep this hall in time, on time, perfectly. Thank you.
Thank you.
Very
Thank you.
much.
Thank you so much.
Everyone, thank you.